his major interest and many years of experience in point-of-care ultrasound. Please welcome Dr. Ahmed Bakhreba.
Good morning, everyone. As Dr. Ma'an just introduced me, my name is Ahmed Bakhreba, an emergency consultant. Today I'm going to talk about the basic concept and ACS update. So I think this topic is very important because next shift, I promise you, when you're going to be in emergency department, you're going to see a patient with a chest pain. And one of the differential diagnoses that's going to be on your top list is going to be acute coronary syndrome. So you have to be updated about the new guidelines and what the society, just the big society, think how you're going to manage the patient with acute coronary syndrome. So in this lecture, we're going to talk about the most important terminology and the concept that you should keep in your mind when you contact with your colleague, especially the cardiologist, because if you speak the same language that everyone just use, you're going to improve the patient care. Later on, we're going to talk about the difference between conventional troponin and normal troponin or high sensitivity troponin. And nowadays, why we change that and how that's going to affect the patient care. The next step, we're going to talk about the ultrasound and why the ultrasound is very important when you saw a patient with a chest pain and how that's going to improve your diagnosis and sometimes confirm your diagnosis. And the last step of the lecture, we're going to talk about the new update in the management for the patient with acute coronary syndrome. So let's get started. So those three most important concepts that I wanted to have everyone in this room understand and really grab those concepts. The first one, not every patient with acute coronary syndrome, he has myocardial infarction. And not every patient with a myocardial infarction, they're going to have acute coronary syndrome. And not every patient with a high troponin, he has non-STEMI. So don't just oh, my patient is having non-STEMI because the troponin is high, I'm going to start him on heparin. So in the next couple slides, I'm going to just illustrate all those concepts because I don't want to just look you to memorize everything without understanding what's going on. So what is acute coronary syndrome? As everyone knows, acute coronary syndrome is a broad spectrum of disease. Usually we're going to start with unstable angina, non-STEMI, and STEMI. And all those patients, they have something common. When they came to emergency department, they're going to have a severe chest pain. And when you dig a little bit in the history, oh yeah, the chest pain gets radiated into the left shoulder, right shoulder, and sometimes going to associated with a nausea, vomiting, but it's not classic. You can't tell, oh, this patient have a STEMI or non-STEMI based on the history alone. So history is not going to be helpful to differentiate between all the types of acute coronary syndrome. But the pathophysiology for everyone here is completely different. So if you have a patient with a STEMI, that means you have complete occlusion in the coronary blood vessels. But if you have a patient with non-STEMI or unstable angina, we are talking about around 90% or 80%. So how we can tell the difference? According to all society, the big non-society, they recommend to have the ECG in the first 10 minutes. Because if you did the ECG in the first 10 minutes and you found the patient you have a STEMI, so you should have a protocol in your hospital. We call it a STEMI protocol. This patient, either he gonna go to the cath lab, or this patient he need, if you have a fibrinolytic, so whatever, you have to follow it, and that's gonna affect your patient care. But if the ECG for the patient is normal, so you're gonna follow up with the troponin. Troponin is normal or high. That means if the troponin is high, your patient having non-STEMI. If the troponin is negative, and the patient have you still concerning for him, and you may gonna have a stable angina. And this time you have to call your cardiology because he just gonna continue the care of the patient if there is any further investigation need to be done for this patient. So what is a myocardial infarction? So myocardial infarction is just acute myocardial necrosis in the setting of acute myocardial ischemia. So you have a necrosis and you have ischemia. And because you have a necrosis, all the troponin in the heart is going to go high. So you have a raise and falling troponin. And that's the definition of acute myocardial infarction. But the patient with unstable angina, the troponin is normal. So that's why you can't include every patient with unstable angina. And just like you're going to see the patient, oh, this patient is having an acute coronary syndrome. So that means the patient is having myocardial infarction. And that's going to be a wrong diagnosis. And when you call your cardiologist, he's going to get mad because he knows you don't know what you are talking about. It's fine in the beginning when you saw the patient, you just like, oh, I'm thinking about acute coronary syndrome. But after you do all the investigation, the ECG, you have to decide if your patient having unstable angina, stable angina, non-stable angina. And this is the first concept that I wanted to have everyone just understand it. Okay, your patient is having high troponin. Troponin is going up and down, and that's going to be acute myocardial infarction. I think everyone right now is fine with that. But what about the people or the patients who came to emergency department and all the time they have high troponin and there is nothing changing? We saw it all the time. And I think the old definition for that, I think we called it trop leak. Just like when you told someone, oh yeah, that's his troponin is high all the time. So this patient, what should I do with him? Do we have a definition for it? According to European Society of the Cardiology, 2019, they put a specific name for that. They call them chronic myocardial injury. So if the patient, he doesn't have a chest pain right now, and just like only have like a different problem, and troponin, his troponin is stable right now, you don't have to start him in troponin. And that's the second concept we talk about. Not every patient with a high troponin, he has non-STEMI. Not every patient with stable chronic myocardial injury, like the patient with end-stage renal disease, you need to start him on heparin right away. So you have to think, troponin is just like a number. And troponin is enzyme, like a protein in the heart. Don't do a wrong management according just to the numbers. So this is the fourth universal definition of myocardial infarction. Believe it or not, we have a 5 subtype of myocardial infarction. The first one, I think everyone knows about it. Like someone came with a chest pain, and you found out the patient has an acute myocardial infarction because we have a plaque, get ruptured, platelet, have a complete occlusion in the blood vessels. And this is just going to be very simple. The second one, we call the demand ischemia. We have a mismatch between the oxygen need and the demand. We saw it with a sepsis, pneumonia, patient has a stable coronary artery disease, and troponin right now is going to go up. So what about the third type? Third type, in an emergency department, we don't know what is it, because the patient gonna come already dead, or just like the patient gonna die in your emergency department. The ECG, it wasn't conclusive. Patient, he doesn't have any segment elevation. You send the trop came back negative. But on the table, when they do the autopsy for the patient, they found out the patient has a myocardial infarction. So that's a type 3. Type 4, and I think this is gonna be like very important for any emergency physician. The patient who just like had a cath, we had a stent 3 days ago, and right now he came back to emergency department, and the troponin is high. This is most likely due to the stent. And once it's fine to call the cardiology, but when he told you the patient having high trop because he did the BCI or he just put the stent, you have to believe him because you know it's something common here. The fifth one is due to the cabbage. If the patient he has a cabbage, this is going to be the cause of high troponin. So we have like a different type. And here, that's the second concept we talk about. Not every patient with the myocardial infarction, he has acute coronary syndrome. Like for example, the patient with a cabbage or the patient with, if he had like a demand ischemia, he doesn't have acute coronary syndrome. So the patient could have high troponin due to something different. So okay, the patient right now, you did ECG for her. You did troponin for him. It was elevated. So what should I do for the patient? So the first question is, do you have a baseline for the patient or not? If the patient, he has a baseline and the troponin is elevated all the time, that's going to be the chronic myocardial injury. And we have 2 differential diagnoses for that. Either the patient going to have a structural heart disease or the patient, he going to have a chronic kidney disease. Okay, but if you have a fallen raise in troponin, so you're going to ask yourself, does the patient have ischemia or not? If the patient, he doesn't have ischemia, so this patient have something we call it acute myocardial injury. And we have 2 differential diagnoses for that or more. One of them is going to be acute heart failure, myocarditis, trauma to the chest wall. All that's going to cause high troponin. And the patient, he doesn't have ischemia. Okay, for the ischemia we have, if the patient have ischemia, that means, as we mentioned before, the patient, he going to have acute myocardial infarction. And we have 2 types, type 1, type 2. Type 1 due to plaque get rupture, or plaque get ruptured, and we have like a plaque on top of that. Just like you have complete occlusion in the blood vessels. Or you have mismatch due to ischemia. Okay, So this is a sensitivity, high sensitivity troponin and normal troponin or conventional troponin. Before I start, what's the difference between both of them? So what's the common? The common here, we're going to get the same answer. I'm looking for a troponin. Does the patient have high troponin or not? All of them, they're going to give you the same answer with a different specificity. So the first one, they're going to give you high specific answer. So if the patient is having high troponin due to high sensitivity to high troponin, because you are using high sensitivity troponin, you are using a nanogram per liter. So the parameters here is completely different. Here we are using a nanogram, and on the other side we are using a microgram. So on the right side, it's going to be more sensitive, but you're going to involve like more normal patient, and the false positive is going to be very high here. So you have to be very careful when you do that, because not every patient right now with a high sensitivity troponin, you can have high troponin, the patient have like myocardial infarction. So this is the sensitivity and specificity of the two, just like troponin. So if we are talking about high sensitivity troponin, the sensitivity of this is going to be 95%. If you want to compare it to the standard troponin, it's going to be 72%. We can have a huge difference here. But on the other hand, the specificity, the standard troponin is not that, it's more specific, it's like a 97. And that means that we are, in emergency department, we like to rule in, not to rule out, especially the killing disease like the patient with MI. So right now we are ruling more in than ruling out. And according to the European Society of the Cardiology, they found out even those patients with 80% just like specificity, they have just like the 20% that's left, they have something serious in their heart. Either it's going to be structural heart disease. Those people with patient, they need to have an extra investigation. So it's fine to just like admit them to the hospital, and the cardiology, they're going to take care of those patients. So, and also the accuracy, diagnostic accuracy, we are increasing our like accuracy in diagnosing those patients by 96% compared to 90%. So that's why nowadays, if you are using in your hospital the normal troponin, at some point you have to change to high sensitivity troponin. I think in just like in my institution, just like I think 2 years ago or a year ago, they changed it. So I think that's going to be universal changes in all over the world. So why some people, they have just like, what's a false positive for high sensitivity troponin? We have 4 different types or different causes for that. We're going to start with a fibrin clot. So what that does mean? So if the technician, he get the sample, and after he did the transfusion for the sample, and he left it there, so the clotting fiber gonna be just like waiting there, and once you wanted to get the test for the troponin level, it's going to be high, and that's going to be false positive because we have a lot of fibrin clot inside the sample. The second one, if the patient have heterotrophic antibody, and the third one, if the patient have high alkaline phosphatase, and the last one, it's going to be if the patient has rheumatoid factors. All those going to be causing a false positive. So what the European Society of Cardiology recommend for troponin? So you have a patient, you suspect non-ischemic for him, and you wanted to send the troponin level. How frequent should we send it, and how many samples should we send? So according to 2023, they have a 2 pathway. The first one, you have to send the troponin at 0 hour, and you have to repeat it at 1 hour. This is going to be the best pathway. And the second best pathway, they just like recommended, you're going to send the troponin at 0 hour, and the repeated one after 2 hours. And if the patient is having very low initial high sensitivity troponin, you don't have to repeat it. And just like they mentioned, ruling out pathway, and the patient gonna go home. If the second one, it was just only high, and you wanted to repeat, just normal, you need to repeat it again. Make sure it's not like raising up and the delta is negative. So this patient gonna go home also. But also they mentioned something very important. You have to have your clinical judgment. So if the patient, you think the patient is having high risk, you don't think so, the patient, you think there is something wrong. The patient, he could have a chronic heart disease. If you think there is, I'm not feeling comfortable to send this patient home, he has multiple risk factor, or this patient just like, I think he looks sick. So those patients, you can put him in observation pathway. And that's why they mention if the patient, he doesn't meet all the criteria, that's the physician decision, and the patient be in the observation pathway. If the patient have high sensitivity to troponin, it's high from the beginning, or if the delta is different, those patients need to be enrolling out that way. So what's the role of the ultrasound in diagnosing a patient with acute coronary syndrome? So if you have a patient with just like, if the patient have like ST segment elevation MI on the ECG, you are done because you know what you're gonna do. But what if the ECG, it wasn't conclusive? And we saw it all the time. Okay, do you know what? I'm not sure. Does my patient have myocardial infarction or not? I don't know. So the ultrasound can help you here. So what you are looking for? I mentioned that all the time. The POCUS, the point of care ultrasound, you should have a specific question for it. And before you do your exam, you have to ask yourself, what I'm looking for. You have to be very precise. Okay, in this case, we are looking, does the patient have abnormal wall movement abnormality? If the patient is having, you are done. Don't just like search for everything, because you're gonna waste your time, and you have only 5 minutes, 10 minutes. So that's what we're gonna do today. So here, I'm gonna start talking about little bit about the anatomy and where we are gonna put the probe and what view we have it here, just because I wanted to have everyone here in the room just like be with me. So we're gonna start with the first one here. We have, can you see the pointer? Marker? No. Okay, can you see the laser here? Okay, so the first image we have it there, it's parasternal long axis. So in the blue light there, that's gonna be the septum, and here we have a lateral wall. I think the lateral wall is gonna be there. And the lateral wall is gonna be supplied by inferior right coronary artery, and part of the middle of the lateral gonna be supplied by lateral circumflex. And in the short axis view, is gonna be almost like that. We have 3 parts. I will say the upper part of that gonna be supplied by the anterior. That's gonna be the anterior wall. That's gonna be inferior wall, and we have a lateral wall here on the right side. On the left side, we have a septum here. So the septum gonna be supplied by the anterior wall, and I'm sorry, the septum gonna be supplied by LAD, and the lateral wall gonna supply by circumflex. Inferior wall gonna be supplied by right coronary artery. So if you have infarction of those blood vessels, what you are looking for? So you want to see if there is any thickening and thinning in the wall. So I have example here. So you can see that. So this is the normal. So you can see how the muscles right now is getting like thicker and smaller. And sometimes there is a trick I use it. I put my finger in the middle of the parasternal short axis, and I want to see if all the muscles gonna come to my finger. If the all muscle come to my finger, that means I don't have anything, and that's gonna be normal. And there is another trick you can use. You can see if the muscle itself get thinner and thicker, and that's gonna be like very precise right now. Like example, like here, you can see this patient have inferior lateral MI, and you can see the lateral wall here, it's not getting thicker and thinner. If you want to compare it to the normal patient there, you can see the green color there. You can see the muscle there is getting thinner and thicker, and that's normal. If you want to compare it to the patient with acute MI or acute non-ST segment elevation MI, you can see the wall here, the muscle is not moving at all. That's what actually you are looking for. So how sensitive we are in doing that? So I wanted to be promised with you. I did ultrasound fellowship. I know what I'm doing. But if you just are just like a normal, just a regular resident, or if you are just a new consultant and you're just holding the probe, should you believe your scan or not? So this is a study done on 2019. And the first question everyone can answer, who did the scan? Because if you got like 88% sensitive and 92% specific, that's a good number. So can I get the same numbers or not? So the one who did the scan, he's only got, it was a resident, they had only one workshop for doing echo for 1 week, and after that they were able to get those numbers. So if you have a decent training in ultrasound fellowship, or just any kind of training for a week for echo, you're gonna get the same numbers. So don't freak out, and that's why I encourage everyone just like to do echo. You have to practice point of care ultrasound. It's gonna change a lot of your management. So this is the new guidelines we have it for approaching a patient with acute coronary syndromes or any patient with chest pain. This is from European Society of the Cardiology 2023. And I don't think so there is a lot here. So any patient came with a chest pain, you have to start with ACG, take in history, do the physical exam, take the vital sign, and you have to send the troponin right away at 0 hour. Don't wait like 2-3 hours, just send the troponin right away. If the patient have a STEMI, you have to follow the STEMI protocol as I told. If you have a PCI, the patient need to have it. If the patient, you have a fibrinolytic, because the patient, he will not gonna get a PCI soon, just go ahead and do it for your patient. If the patient need to have a heparin, anti-aspirin, just give it to your patient. If the patient is high-risk patient here, so the patient need to have a PCI right away. If you don't have it, fibrinolytic, it could be possible. If the patient having non-STEMI, so the patient can have a PCI plus a platelet, and further investigation, they put an echo there. Echo, they mean it here, just an official echo. But still, you have to do your own echo if you want. And they just like, I mentioned they wanted to have a patient with angio, like non-emergency angio, and other nuclear images, or non-invasive images, and serial trope ECGs. Okay, so this is the update in the management. So what's new here? I think I have like a couple things changed in the last just like year from 2022 to 2023. So according to European Society of the Cardiology, they mention any patient came to emergency department in the first 10 minutes and you suspect acute coronary syndrome, you have to start the patient on aspirin. That's class 1A. But what about Plavix? I saw it a lot. They just give the patient Plavix or clopidogrel with aspirin. Is it recommended? Answer is no, because this one is a class 3. If the patient gonna go to the cath lab, this is a class 2B for the B2Y12. So don't give any patient Plavix unless the patient gonna go to cath lab, or you have to discuss the case with a cardiology. So what if the patient have a STEMI? Should I give the patient anticoagulant? The answer is yes. If the patient have a STEMI, you have to start with unfractionated heparin. And enoxaparin is going to be the second line. Best line, we have it here. If the patient having non-STEMI, and that's going to take less than 24 hours, start the patient on unfractionated heparin. And if the angio going to take more than 24 hours, we have a Fentoparan X. That's another anticoagulant you can give it to your patient. So if the patient going to go to the angio, what's the best second antiplatelet should I give it to the patient? In the past, I think everyone you know about the clopidogrel or the Plavix. We just give it to everyone. Just like a loading dose, like a 600 milligram to everyone. But right now, that changed. Because the study found prasugrel, anticoagulant is going to be better for the patient. And that's what should we practice right now. I think we have it almost like in every hospital. We have it there. So try to use it. Call your cardiology. Use it, because outcome is going to be better. And if you have both of them, prasugrel, anticoagulant, which one is better? The study showed, the recent one, prasugrel is going to be better than anticoagulant. And this is based on the study, they call it ERAS REACT-5 trial. They involved 4,000 patients, and they found out the prasugrel gonna decrease a risk of recurrent risk of ischemic event in the future compared to the anticoagulant, which is like not that significant. But if the patient is having a bleeding, anticoagulant is going to be better, especially if the patient he has birth stroke, if the patient is having elderly, going to have a risk of bleeding, or if the patient is having low body weight. I think I'm done. 5 minutes, okay, it's fine. Does anyone have any question?
Thank you, Dr. Ahmed. Any questions? We have 2 minutes, 3 minutes for questions. إذا شايف أنا ماني شايف.
ما شايف حد.
Nobody? If no questions, we'll move on to the second one. Dr. Rawan Al-Asami. She's going to give us a lecture around heart failure and approach and management. Dr. Arwan is an American board graduate of emergency medicine, and she's an emergency medicine consultant in King Abdullah bin Abdulaziz University Hospital. Please join me in welcoming Dr. Arwan.
Good morning, everyone. وين أضغط على هذا to move the slides. Okay. Good morning, everyone. I'm very happy to be here with you today. That was a tough act to follow, Dr. Ahmed. I was hoping he wouldn't do so well, but I'm going to keep it short and concise as possible. The topic I was asked to talk about, okay. So approaching heart failure in 25 minutes, approaching and managing heart failure. So promise you I'm not going to spend the whole 25 minutes because this is a topic, a 2-hour worthy topic. We're going to try our best to summarize the basic concepts and basically discuss the management in a way that any resident starting their career in emergency medicine or intern can know the basic concepts and what to expect and how to manage and approach a patient with heart failure. So talking about the heart, what does the heart do? The heart is responsible for pumping the blood throughout the entire body. And you know, if we're going to have an equation for it, it's going to be the cardiac output. The cardiac output is the amount of blood that is pumped by the heart in each minute. Usually that equates to about 5 liters. So this equation basically, I still have to figure this. Okay, so it's the cardiac output will equal the stroke volume times the heart rate. What is the stroke volume? The stroke volume is the amount of blood that is ejected from the ventricles per second, or per beat, not second, beat. So if we say that we have about 100 ml of blood that is ejected per beat, what controls the stroke volume? So from its name, volume, which is preload. Preload is volume, the amount of blood that exists in the ventricles with each beat. So whenever you have more volume that's coming into the ventricles, it's going to increase your stroke volume, and by that it's going to increase your cardiac output. Also contractility, calcium, whenever you have something that stimulates calcium, in the muscles, in the muscle fibers, it's going to increase your stroke volume. And remember the Frank Starling law of the heart. Whenever you stretch the ventricles, you put in more preload and more volume, you're going to have higher pumping and higher cardiac output. So that's one way to control the cardiac output by stroke volume. The other factor is heart rate. Heart rate, what factors into heart rate? What increases or stimulates heart rate? A lot of things. Catecholamine stimulation, for whatever reason, by drugs or when you have a thyroid storm, whatever the reason, that will increase your heart rate, will increase your cardiac output by default. So when we talk about heart failure, we can basically divide them into 2 broad spectrum, high output and low output heart failure. Talking about high output heart failure, basically when we have more than 8 liters per minute pumped from the heart. So the heart is normal, but it's failing to meet the increased demand or the increased metabolic demand of the body. When you think of the heart failure, I want you to think of it as a symptom to an underlying disease rather than a disease entity itself. So whenever a patient's heart is failing, it's not just enough to treat the failure itself, but to also look for the causes of why this patient's heart is failing. So this is high output heart failure. Anybody can mention any reasons for high output heart failure? I'm sorry, pregnancy, excellent. So you have a increased plasma volume, increased circulating volume in the body. Also you have this anemia that's associated with pregnancy, which will increase the oxygen demand. Anything else? You have beriberi disease, which causes which vitamin deficiency? Thiamine deficiency, which will cause anemia, and also it will cause some increased peripheral vasodilation, which will decrease your peripheral vascular resistance, and vice versa, it will increase your cardiac output. So these are causes of high output heart failure: thyrotoxicosis, beriberi, anemia, pregnancy, as somebody mentioned. Now, let's talk about what we encounter most in the ED, which is low output heart failure. So low output heart failure, basically when you have less than 4 liters of blood pumped from the heart per minute. So the metabolic demand of the body is normal, but for some reason the heart is failing to meet the normal metabolic demand. Now, this is the cardiac cycle. We know we have our systole and diastole. When we have, and heart failure can be left-sided or right-sided. So talking about left-sided heart failure, you can have a systolic left-sided heart failure with reduced ejection fraction. The normal ejection fraction of the left ventricle is more than 55%. So when you think of the left ventricle, there's always some blood. For example, if 100 ml is there in the left ventricle, we would say about 55 to 60% of that blood is ejected from the left ventricle. The ventricle, there will be always blood in there. It's never empty. So an ejection fraction of more than 55% of blood is a normal ejection fraction. When that ejection fraction is reduced, then we have a pump failure, or what cardiologists call HEF-ref, which is heart failure with reduced ejection fraction. Can you have heart failure with preserved ejection fraction? Yes. So when the ejection fraction is intact, but the heart doesn't have enough time to fill, or you have diastolic failure, the ejection fraction is intact, but for some reason the heart does not have enough time to accommodate the blood and eject it, or doesn't have the amount of space, which happens in cases of restrictive cardiac disease such as amyloidosis, hypertrophic cardiomyopathy. The ejection fraction is good, but there's not enough room for the heart to fill and to eject all that blood. Anybody can mention causes of reduced ejection fraction left-sided heart failure? Any students with us? I'm sorry? So you have heart attacks, right? Acute myocardial infarction is a cause. You have valvular diseases. You have hypertension, prolonged uncontrolled hypertension. These are all causes that lead to heart failure. So what happens when you have, whether it's systolic or diastolic, what happens when you have the heart is failing, for example, in this in the left ventricles? So the heart is unable to pump all that blood. Where is it going to get back into? Anybody knows? So the pulmonary vasculature, right? And that's basically the concept of why patients come in congested. The heart, either there's an increased afterload, which is the systemic vascular resistance, it's increased, and it's backing up into the ventricles, and all that fluid is also backing up into the pulmonary vasculature, and now you have edema, pulmonary edema, or pulmonary congestion. So with left ventricular failure, you're going to have the fluid mostly showing in your lungs. What about right-sided heart failure? So with right-sided heart failure, anybody can mention causes that might lead to right-sided heart failure? I'm sorry? What did she say? Left-sided, exactly. That's the most common cause. Left-sided heart failure will eventually lead up to increased pulmonary congestion, increased pulmonary pressure, and that will lead to right-sided heart failure. Anything else, if it's PE, excellent, COPD, all of these are causes of right-sided heart failure and should be looked into. So when you have the right side of your heart over there is failing, what's going to happen? So the blood is coming back from the inferior and the superior vena cava. It's trying to pump blood, but the right ventricle is failing. It's accumulating fluid. That blood and fluid is all going to back into other organs, and it's going to show. It's going to show on your legs. It's going to show on your liver. It's going to show on your jugular. So this is where you look. Usually with left-sided, you will see it more prominent in the lungs. With the right-sided, you will see it in the lungs, in the liver, and all over the body, basically. So let's talk about approaching the patient. You have a patient that's coming into you. Whether you know they already have heart failure with reduced ejection fraction or preserved ejection fraction, or you don't know if they have any heart failure at all. They're coming to you, they're dyspneic, they're short of breath, they don't know, and you're seeing some signs that might indicate. You start off just like with how you would start with any patient, ABC. You assess their airway. Are they able to maintain their airway? Are they awake, talking to you? They're alert, they can protect their airway. You move on to breathing. You look at their oxygen saturation. Are they satting well? Are they basically needing a supplemental oxygen to keep their saturation up? You listen to their lung sounds. Do they have crackles? Circulation, are they hypertensive? Are they hypotensive? And that would give you an idea about their volume status and where to go. Also, you approach it through history and physical. So history, what happened today before, what brought you to the ED? Are they having an MI, a myocardial infarction? Did they start having chest pain and all of a sudden their heart is failing and they're going through a cardiogenic shock? Do they have pre-existing heart failure, but they have not been compliant with their medications and now they're in decompensated heart failure? The other thing, were they pregnant and now they're coming in with severe shortness of breath, and the next thing you know, you might be looking into a PE. So all these factors, history is very important in determining what's going on. Anemia, thyrotoxicosis, as we mentioned in the previous examples. Always look for the reason of why their heart is failing, and you will find it in your history and physical. So physical exam, you're gonna basically look at them. You're gonna look at their GVD, you're gonna listen to their lungs, you're gonna basically look at their abdomen, and you're gonna look if they have a pulsatile liver, how we would say when they're volume overloaded. You're gonna look at their feet and determine if they have pitting edema or no. And then you're gonna use your POCUS, and POCUS is an excellent tool to help you differentiating what kind of heart failure you're dealing with. If you're ultrasound trained and you can figure out if it's, the EF is preserved or reduced, that will be great. But also you can look into their liver, which is basically an elementary level. You can always assess for B lines and know if you're dealing with congestion or no. You can always look at their IVC, because not all heart failure will be volume overloaded everywhere. They might just be overloaded in the extravascular space, but they're intravascularly depleted and need more volume. So all these things will help you. POCUS will help you to determine your treatment and know what you're dealing with. So cardiologist, I know, maybe not in all centers, but in a way, when you pick up the phone and you want to relay to your cardiologist what kind of heart failure you're dealing with, these are some simple terms that we can use. And how we approach it, how we're going to describe our heart failure patients, is by looking into two things. One is their perfusion status. If they're warm, that meaning they're perfusing well, or they're cold, meaning they're not perfusing, and their congestion status. Are they wet or are they dry? Are they wet in the lungs or they're dry? So you have, if your heart failure patient is warm and wet, which is basically what we deal with most of the time in the ED. That's the most common type you'll see. You'll see a patient who's coming to you, that means warm, they're perfusing well, their blood pressure is probably in the normal range, but they're congested for whatever reason, whether they're having a heart attack, whether they haven't been compliant with their medications or their diet. So what do you do with the warm and wet patient? So that means no hypotension, hypoperfusion, but they have pulmonary congestion. So cold and wet. Cold and wet is very scary in the ER. That means you're dealing with a hypotensive, hypoperfusing patient that is also congested. This is where we go into the realm of cardiogenic shock and how to manage it. And then you have cold and dry, meaning that they're not perfusing, but they are also not congested. So this is our warm and wet patient. For starters, when you have somebody who their blood pressure is maintained but they're having pulmonary congestion, I always start with non-invasive positive pressure ventilation because you will see a drastic improvement in their symptoms just by putting them on CPAP or BiPAP. So it has been actually proven to reduce the need for intubation, and also there's a trend towards decreasing mortality. So non-invasive, always remember, you have somebody with heart failure, their blood pressure is fine, put them on BiPAP. But also remember, be careful of BiPAP in the hypotensive group, because BiPAP, by default, it will increase your intrathoracic pressure, meaning that it will decrease your venous return. So it might make your hypotensive patient even more hypotensive. So be wary when you're dealing with a hypotensive patient. What else? Diuresis. So you're going to give your Lasix, your loop diuretics, right? So the goal is basically you want to use a dose, their home dose, into an IV form and give it. If they're naive, you can start with 40 to 60 milligram of Lasix IV, and that's a good starting dose. Usually it takes about 1 hour to 2 hours to work. And the goal is basically to diurese them 1 to 2 liters per day. Now there's a study, the ADVOR trial, that was released last year. This study, it's a double-blinded randomized controlled trial in a multi-center. They had 2 groups. One group, they gave placebo, and the other group, they gave acetazolamide, 500 milligram IV. And they gave it once for 3 days. And the primary outcome was to basically see if the congestion and the volume overload have resolved completely without the need for further intervention. And the acetazolamide group did really well. So that might be something you might add to your patient in addition to Lasix. You have nitroglycerin also, which can aid in these warm and wet patients. And there's many different protocols in using nitroglycerin. But you have to avoid it in cases of RV infarction because it might make your patient hypotensive. Now, an honorable mention, since we're speaking about nitroglycerin, is SCAPE. And what is SCAPE? Basically, it's a subtype of the warm and wet acute heart failure. It stands for sympathetic crashing acute pulmonary edema. And in this subtype of acute heart failure, there's usually an inciting event that makes the sympathetic system goes wild. So whether it's an MI, whether it's an uncontrolled hypertension, but you're going to have this activation of your catecholamines, you're going to have peripheral vasoconstriction, and all the blood is going to go into the lungs, and it's going to be concentrated into the lungs. Also, so you're going to have increased preload with the fluids going into the lungs, and you're going to have an increased afterload with peripheral vascular resistance increasing due to the vasoconstriction. So this is basically, this develops within minutes to hours. This is not it's a gradual onset of shortness of breath. This happened basically within hours. So you always should keep it in mind because the treatment for that is slightly different. So these patients usually respond very well and within a few minutes to hours to treatments if done correctly. So what you're going to do is you're going to put them on BiPAP just like you would with your heart failure patient, but also in addition, there's a lot of evidence that supports the use of high-dose nitroglycerin. Now, there's many ways to use nitroglycerin in this subtype of patient. Some literature supports the use of 1 to 2 milligram over 2-minute boluses. But others, for me personally, I like to use a high drip nitroglycerin. I started at 400 mics per minute for 2 minutes, and then I down titrate based on my patient responsiveness. And usually they respond very well to nitroglycerin, and you're going to see them improving with that. Just a side note and something to be mindful with SCAPE. As we mentioned, all the fluid is being mobilized into the lungs. When you put your IVC, when you put your probe to look at your IVC and your volume responsiveness, you might notice that they're volume depleted. So not all warm and wet, they have to be volume overloaded all over. So they might actually be volume depleted in a sense. So that is something to keep in mind when you're guiding your treatment or resuscitation for these patients. So how about your cold and wet patient? So this is basically, we're going into the realm of cardiogenic shock. You don't want to diurese this patient while they're hypotensive. So you want to wait, you want to address their hypotension first, because ABC's first, and then you want to look into their volume status afterwards. So for your it's better advised to keep the MAP above 65. You can use vasopressors and inotropes, your dobutamine, your levofed, all these vasopressors. You try to optimize as much as you can because that. And then you want to look for causes. Why are they hyperperfusing and why are they pulmonary congested? Now for these patients, just as I mentioned, you want to be careful with non-invasive positive pressure ventilation while they're hypotensive because it can actually worsen their hypotension. So it might be a good idea to start them on a pressor, to start them on an inotrope, and then consider non-invasive positive pressure ventilation. How about your cold and dry patient? When they're cold and dry, I'm more inclined to look for other causes of shock rather than cardiogenic. Can somebody mention an example? Hypovolemic shock. So it could be hypovolemic shock. Even if they have heart failure, that doesn't mean that heart failure is going to be the cause why they're cold and wet. They might be bleeding somewhere, they might have had an accident, they might be having a bad case of gastroenteritis where they've been vomiting and nauseated and having diarrhea and haven't eaten anything for a few days. So they might be volume responsive. So look for those causes. And also small fluid challenges and assess for responsiveness. You can give 250 to 500 cc of fluid boluses and basically let POCUS guide your resuscitation by looking into the IVC. And as well, keep the MAP above 65 even if you had to use pressors or inotropes. Thank you. Of course, I didn't mention the warm and dry because that's basically healthy. They have no business in the ED. Any questions? All right, thank you.
Thank you, Dr. Arwan. Any questions for Dr. Arwan? No? Okay. As a simple and modest gesture and appreciation for our presenters, Dr. Ahmed, can you please join us and accept this very humble award? Dr. Arwan. for coming. Thank you all for attending. We have a short coffee break. Please enjoy, and we'll see you in a little bit. يعطيكم العافية جميعا.
We're starting in 1 minute, guys. Please ask everybody to come in. We want to be on time. الله يكرمك.
انا داعمك انت بس تطلع.
ايوه هنا استريح. كيف تبغى؟ I thank you all for coming and welcome to the second session of the day. It gives me great pleasure to announce to you our next speaker. He's going to be presenting a topic of anaphylaxis and an update in anaphylaxis. I think he needs no introduction. We're in his hometown. Dr. Ammar Ismaili is an emergency medicine consultant. He has a fellowship in ultrasound, and he's the deputy program director at National Guard Hospital. So please, without further ado, help me welcome Dr. Ammar to his next lecture.
السلام عليكم. طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. صبحكم الله بالخير في هذا الصباح الجميل، صباح اليوم الوطني. كل سنة وانتم طيبين، كل سنة والوطن بخير. Today I'll be talking about well, anaphylaxis. So the take-home points right off the bat is going to be early recognition is important. Uniphasic is only in 70 to 90%. Anaphylaxis does not equal anaphylactic shock. Epi is the drug of choice. And then if you have an involvement of the airway, breathing or circulation, please do the epinephrine. Early fluid boluses is important. Glucagon if the patient is using beta blocker. Methylene blue, for some reason, is used for refractory anaphylactic shock. Observation is at least for 6 to 8 hours. And then if you are dealing with a patient who's allergic to antivenom and even developing anaphylaxis, probably you should proceed with that. So this is the take-home points, and the rest of the lecture is going to be only pathophysiology. I'm only kidding. So let's start with the case 1. So an 11-year-old male with acute urticarial rash and wheezing. The patient does not have any previous known allergies. Okay. Case 2, 11-year-old male with an acute lip swelling and syncope. The past medical history is unknown, and there is no known medical illnesses, no known medical allergies. A 12-year-old female presenting with wheezing, abdominal cramping after peanut ingestion. Patient is known to have allergies to peanut, and she's not taking any medications. 12-year-old female with generalized hives and shortness of breath after peanut ingestion. No past medical history, and the patient is known to have peanut allergies. Well, a lot of the cases are just pediatrics, so the patient is not known to have any allergies and now hives with shortness of breath. A patient is 60 years old, patient presenting with dizziness, altered mental status, found to have a blood pressure of 85/50 after taking ibuprofen. The patient is known to have allergies to NSAIDs from before. Okay, so what all of these patients have in common, they meet the definition of anaphylaxis. And I need to stress on the point that anaphylaxis does not equal anaphylactic shock. Because, well, anaphylaxis is a multi-system disorder, and it manifests with signs and symptoms related to either cutaneous, respiratory, cardiovascular, and GI system. The full-blown anaphylaxis syndrome will end up with an angioedema and airway obstruction, hypotension, and then a distributive or a mixed shock, cardiopulmonary arrest, and then death if it's not recognized early and managed appropriately. So there are some classification of the anaphylaxis. Well, based on system based on system involvement, we're talking about grade 1 urticaria with angioedema, diarrhea with hypotension and wheezing, and dyspnea. Grade 3 if there is a severe cardio respiratory manifestation, collapse and shock, arrhythmia and severe bronchospasm, or if the patient is going immediately to cardiac or respiratory arrest. So severe anaphylaxis, if the patient is having hypoxemia less than 92% of oxygen saturation, if the patient is hypotensive less than 90 for adult for systolic blood pressure, if the patient is manifesting or presenting with an altered mental status collapse or fecal and urinary incontinence. So again, anaphylaxis does not equal anaphylactic shock. The risk factor, if the patient is taking, if there is a parenteral infusion of a medication, if the patient has a history of atopy, if the patient is using beta blocker or ACE inhibitor, not by itself for the beta blocker, but because of the how difficult to manage such a patient, it can be a bit put the patient at a higher risk when you are dealing with that patient. So the other risk factors, if there is a delayed use of epinephrine, which is something that we are responsible for, the family are responsible for upon discharge or upon the long-term treatment. If the patient is presenting with anaphylaxis but with the absence of urticaria, this will put the patient at higher risk of poor prognosis. If the patient is presenting with a biphasic reaction, this is another risk factor that would set the patient high in how to manage such patients. So vulnerable patients, if you're dealing with an infant, there are case reports of a 2 weeks old patient who actually presented with anaphylaxis, and then a teenager if they are trying out stuff, and then a pregnant woman who is not known to have any medical problem or any previous allergies, and they are receiving intrapartum penicillin injections, and then elderly, and then asthmatic. So some cofactors will exercise, fever, if the patient is having concurrently a URTI, or the patient is in an emotional stress. So I'm not going to go over the pathophysiology of the phenotype and the endotype that is the clinical manifestation or the molecular mechanism or pathways, but we need to understand that the triggers for anaphylaxis is 31% of them are related to food, and usually this is present early in life because patients are presenting, they are exposed to these triggers early at life. And then if we're talking about medication, which is 34%, so we're talking specifically about antibiotics, the use of NSAIDs, and then the stinging insects of about 20%. So not to go really deep into it, but we have an IG mediated that requires a prior exposure, antibiotic, particularly the penicillin family, if there are any venoms or latex allergies or vaccines. So the non-IgA mediated, so if the patient is experiencing anaphylactoid reaction, iodine or opiate use, or vancomycin. So just a few words about the angioedema, which is the subdermal or submucosal edema that will put the face, put the airway at risk, and then it might actually involve the GI tract. ACE inhibitor can cause angioedema, by the way, independent of the length of use. So I'm not trying to say that ACE inhibitor by itself is an anaphylaxis or the angioedema that is related to the ACE inhibitor, but just keep that in mind. So what do? You want to take appropriate history from the patient, especially to know if the patient has any introduction of new food, or if the patient is using any new medication that is known to cause allergies. So the rash, if the patient is presenting with urticarial rash, which is most of the patient, but not all patients. If there is an airway involvement, which is probably 70%, if there is a tongue or throat swellings, and even if there is a drooling or hoarseness of voice, and then conjunctival injection. So in cardiovascular, it is reported to be 10 to 45%. Patient can present with chest pain in addition to hypotension or tachycardia on the extreme of types of anaphylaxis. And then patient also can present with a GI symptom, so nausea, vomiting, and then abdominal cramping. Those could be manifestation of patient presenting with anaphylaxis. So the diagnosis, it is supposed to be clinical, okay? So if you really want to send a lab test, which is something I'm not really recommending, but it is there. You can send a trypsin, a tryptase level, and it takes several hours to come back. But this is for a follow-up and to assess with the allergies as an outpatient. Let's go back to being clinical. So to diagnose anaphylaxis, you want to have three criteria, any one of the three criteria fulfilled. So if the patient is presenting with an involvement of multiple systems, so if the patient is having wheezing with respiratory, wheezing, so a respiratory distress in addition to hypotension, or if the patient is having a skin rash with a GI upset, if you have any two symptoms in addition to a patient being exposed to either a known trigger or known trigger to a patient, or a trigger that is well known to cause anaphylaxis or allergic reaction in the general population. However, if you have a patient who has a history of allergic reaction to a certain medication, and that patient received by mistake or without asking, received that medication, and the patient is well known to have allergic reaction to that medication, and the patient only developed hypotension, this meets the definition of anaphylaxis. Okay, so and this has been validated with a sensitivity of 96% and a specificity of 82%. So the first line, which is the bottom line, which is the most important thing that I want you to take home from this lecture, is that the use of epinephrine. When you think about anaphylaxis or anaphylactic shock, you need to start the patient on epinephrine. So the epinephrine is the drug of choice. The decision can be really easy if you are dealing with a patient who's presenting with a respiratory or a cardiovascular collapse. But if you're dealing with a patient, for example, who is only having a mild swelling of the tongue and then a bit of a skin rash, and then you see that the patient is not progressing really bad, you might hold off on the epinephrine, and this is wrong. You need to act early, because delaying giving the epinephrine actually is associated with a higher mortality and poor prognosis. So how do we give the epinephrine? So the starting dose is going to be 0.3 to 0.5, so half a milligram of epinephrine, and we are talking about the 1 to 1,000 IM injection in the anterolateral thigh. Usually this is being injected by the patient. So the patient usually is supplied with an EpiPen that usually contains either the 0.3 or the 0.5 milligram. So if you are faced with a patient who is presenting with an anaphylaxis, you want to ask the patient, do you have your EpiPen with you? Because this is probably the easiest way to treat the patient. Because unfortunately, it's not available in the EMS system, and it might take some time to reach the hospital for you to give the epinephrine with the appropriate dose. And then even if you arrive at the hospital, some hospitals actually, they stock the EpiPen in the crash cart, so for the ease of administration. The EpiPen is right there. So you want to give the epinephrine 1 to 1,000 IM injection. Well, there is a question about giving a 1 to 1,000 and subcutaneous, or giving an IV. So your go-to medication should be epinephrine. Your dose is going to be 0.3 to 0.5 milligram for adults, and it should be an IM injection, and that should be in the anterolateral thigh. So what if the patient is still manifesting a symptom? You can repeat the dose in 5 minutes, okay? And then between the first dose and the second dose, there should be a trial of establishing an IV access, so you can either continue giving IV infusion of epinephrine, or you want to give the additional treatment that we will talk about. But it is really important and really imperative to start epinephrine as soon as possible via the IM route, which is very easy and does not require a big talent to proceed. So, the other first line therapy are the use of diphenhydramine, hydrocortisone, albuterol. All of these should not preclude and should not delay the administration of epinephrine. And then if you want to go to the second line, so racemic epinephrine, or most importantly, glucagon. So if you want to use if you are facing a patient with an anaphylaxis who is not improving or responding to your adrenaline or epinephrine that you are giving right now, maybe you want to look for or suspect if the patient is on a beta blocker. So you might want to give the 1 to 2 milligram IV, IM, subcutaneous route, or if you establish an IV access, maybe you can go for a 5 or a 10 milligram of IV glucagon. So the airway management, if the patient, obviously if the patient is unstable, it is easy just to decide, but it's difficult to proceed. So you might end up with doing a crike on that patient. If the patient is stable and you have some time and you have the luxury to take a look, maybe it is good to explore the other options. So what about H1 blocker? Well, I don't want you to read this busy slide. What I want you to focus on is giving epinephrine. What about giving the steroid? So it is unclear whether the efficiency or the efficacy of the steroid is there. So I don't want to leave this slide for long, because I don't want you guys to focus on giving the other medication in lieu of the epinephrine. Glucagon, as we said before, if the patient is suspected to be on a beta blocker and it is working independently of the where the epinephrine is working, and after you give the first dose and the second dose, between the two, you are establishing an IV access. So it is really recommended that you give the patient boluses of fluid, multiple boluses of fluid, because patients with anaphylaxis, they have tendency to lose 30% of their blood volume into the interstitium, and this is one of the reasons why they go into hypotension or anaphylactic shock. So the best treatment is to avoid allergens, right? So in this episode of the Big Bang Theory, Howard's wanted to take eat a peanut to achieve something, and he knows that it is there to, he knows that if he takes this, he will go into a full-blown anaphylaxis. The reason I'm mentioning this is that because 2 days ago we had a snake expert who actually was bitten by a snake a few months ago, and he actually was treated by a few of our colleagues, our toxicologists, who actually presented a snake bite workshop 2 days ago. In this workshop, actually, we got to learn how to identify, and he advised us not to identify and not to try to identify snakes, but nonetheless, they actually brought 8 venomous snakes. But the important thing is that they wanted to address the point that that patient, Mr. Knife, he actually was bitten by snakes 4 times before. So he has received the antivenom in the past, and he developed allergic reaction to the antivenom. He was starting to develop anaphylaxis. He was seen in the emergency department in a rural area. He was given a test dose of the antivenom. He starts to have allergic reaction to that, so they actually waited for him and they actually withhold giving the antivenom. So because they held the antivenom, the patient was not doing better. The recommendation here is actually to proceed with the antivenom at a slower rate and then deal with the anaphylaxis at the same time, because the patient was going to either lose his limb or even die from the envenomation from that snake. So enough about snakes. If you are dealing with a patient who is in an anaphylactic, in a severe anaphylaxis, and the patient is going into a refractory distributive shock from the anaphylaxis, then you want to consider the use of methylene blue, okay? The evidence behind this is only on animal models, and it seems to have synergy with epinephrine. You want to give 1 to 2 milligram IV over 20 to 60 minutes, but keep in mind, if the patient does have a G6PD, then there is you should be cautious about that. So what's the disposition of this anaphylaxis patient? Well, obviously, if the patient is in an anaphylactic, a severe anaphylaxis or anaphylactic shock, not responding or refractory status or intubated, obviously the patient is going to go to the ICU. If the patient is responding better, maybe you want to keep the patient in a monitored bed. And then keep in mind the biphasic reaction that we talked about. So you want to wait for a complete resolution of the symptom. There is no evidence how much or how long you want to keep the patient. Should you keep the patient for 1 hour, 2 hours after resolution of symptoms, 6 hours, 24 hours? Because the biphasic reaction actually can take up to 72 hours. So it is actually agreed upon that if the patient is doing better and you have a very reliable, robust system for the patient to come back in case the biphasic, in case the patient is the unlucky 10% who might actually develop a biphasic reaction, then you probably are okay to discharge, but remember, there is no evidence to support that. So it is uniphasic in 70 to 90%, leaving 10 to 30% of people who will present later. So usually the symptom will present, will peak at 30 to 60 minutes and then resolve after 1 hour if treated. So the biphasic reaction, it is the recurrence of the symptoms hours after the resolution of the initial symptoms without re-exposure of the trigger. So how do you discharge the patient? It is important that you give the patient 2 EpiPen. Usually we are dealing with pediatrics, so one pen is kept at home with the parents and the other one is kept at school where the patient, usually the patient is spending most of his or her time. So discharge instructions, well, whether you want to give a steroid, H1, H2 blocker, just focus on giving the epinephrine. So take home points again. The early recognition of anaphylaxis is really important. The uniphasic is only in 70 to 90%. Anaphylaxis does not equal anaphylactic shock. Epinephrine is the drug of choice. If there is an involvement of the airway, breathing, or circulation, please do the epinephrine. Early administration of IV fluid, glucagon consideration if the patient is taking or suspected to be taking beta blocker, methylene blue for refractory anaphylactic shock, and then the duration is suggested to be at least 6 to 8 hours, and then the use of antivenom and weighing the risk versus the benefit of using the antivenom if the patient already is known to have anaphylaxis from that antivenom. Thank you.
We'll open the floor for 1 or 2 questions if anyone is interested. Can somebody with the mic check if anybody has any questions? Okay, so if you allow me, I have a question. Being a victim of multiple episodes of anaphylaxis, as you said, you would recommend to discharge the patient with an auto-injector EpiPen to be used at home. Unfortunately, there is a shortage of that worldwide. You can't find it anywhere, and even if you want to buy it yourself, it's too damn expensive. is there any way to go around this? Like if you take the epinephrine ampoule at home and use it, because this is what I'm doing. My wife is always carrying an epinephrine ampoule in her handbag. So do you have any idea if this is useful or not?
Short answer, no, because the concentration of 1 to 1,000 is different from 1 to 10,000. And the absorption, it's going to be a bit unpredictable. But what are you going to do about it? If it's not there, it's not there. I think this calls for a national initiative to make it available, actually not just available for people who are requesting it, for people who are suffering from that.
I have another question, please. If you can elaborate more on the epinephrine use regarding the ischemic heart disease patients, elderly, and the patient with severe tachycardia at presentation. So what would you advise in short?
So if the patient is having anaphylaxis and you are even suspecting anaphylaxis, I think you should just proceed with treating that patient. So I don't have any reservation against using epinephrine, even if the patient is manifesting with other condition.
Yeah, so there is no absolute contraindication, so we just go and use it, okay?
No.
Yeah. Bye. Thank you very much. So we have another guest speaker, Dr. Rashab Ahmed. She's an assistant professor at Mohammed bin Rashid University. She's an emergency consultant with the interest in ultrasound. She's also the president of Emirates Society of Emergency Medicine. And she loves teaching, and she's teaching residents and students all the time. Yeah, welcome, Dr. Rasha.
Yes, sir. I'm not going to use this. Assalamu alaikum. Good morning, everyone. First, ألف مبروك على اليوم الوطني السعودي. This is honestly an amazing celebration, and it's an honor. I'm originally from Dubai, so Dubai is lit in green, and it's amazing to be here in Jeddah celebrating the Saudi National Day. And congratulations on the SASM conference, and I'm absolutely honored and pleased to be here presenting on the first day. So the presentation I was asked to present on, the use of point-of-care ultrasound in the emergency department. And obviously, I think everyone knows, right? The only thing I can disclose is I am a point-of-care ultrasound enthusiast. So this is something that I love. But today I'm here not to convince you why ultrasound is important, because I think my fellow speakers have all done that. In the earlier track this morning, there was a talk about coronary artery disease, and they talked about POCUS in MI, and my colleague was talking about POCUS in heart failure, and the previous speaker is actually a POCUS expert, did fellowship in point of care. So the point of this presentation is not to convince you, because I think you guys are convinced. The conference, there was a point of care ultrasound workshop before that, so the use of point of care in the emergency department is actually, I think, well established already. What I'm here to do is to try and update the team with the most updated guidelines for best practices of the use of point of care ultrasound in the emergency department. And you know, to start with, I just want to get a feel of who is the audience here today. So if you can, please go to the menti.com and use this code, and you can just answer, and just to see who is the room and who are we catering this presentation to. This will help me skip some slides or spend more time on others. So I want to know, are you a consultant emergency physician, specialist, resident, nurse, intern, student, or others that I have missed? Because, you know, using point-of-care ultrasound, I think, is already integrated in the system. But tailoring my talk will depend on who is the audience. So you can see good number of interns, students, and residents. I am hoping some of the audience or anybody of the audience will be some of the decision makers, whether head of departments or part of the scientific committee in the Saudi Commission, because there will be a lot about how do we actually manage point of care education and practice in the emergency department. So you see this, majority of the attendees are our future hopefully leaders in emergency medicine. There are residents, interns, and students. There's a good number of consultants and specialists, and I'm excited to actually hopefully share this presentation with all of you. The next thing, do you use point-of-care ultrasound in your practice? From the earlier presentations, I think it's already very clear and evident to me that it is already part of the majority's practice. And you would see here that, alhamdulillah, I don't think that's why the target of my presentation, when they gave me this, the objective was not to convince the audience, because I think the audience is convinced and actually use point-of-care ultrasound in their practice. And you can see here, 62 of the attendees said yes, and only 29 said no. And I'm hoping this 29 will probably be very early in their career, maybe students, interns, and probably will be converted to yes once they join the field of emergency medicine. Now, we all know, and this is clear, that ultrasound is an essential diagnostic tool in the emergency department, and not just emergency department, actually any emergency situation. For our colleagues in critical care, anesthesia, pediatrics, emergency medicine, we know that the role of using ultrasound is crucial. Mainly, it's important for us to provide rapid diagnosis, help us with our decision making, and especially in critical situations. You see the general guidelines, they classify the use of point of care into resuscitative, diagnostics, symptom-based procedural guidance, and therapeutic and monitoring. And I think many of you have been using them. There are different applications, and I'm interested to see from your experience, what are the common applications that you've been using point of care ultrasound for in your daily practice? And I will tell you, these applications have grown. It was started, the first guidelines by the American College of Emergency Physicians, they published 8 to 9 applications. The second iteration, they had 14 to 15, and the number of applications is only growing. And you can see here from the audience participation, just to let you know that you can answer more than one. You can see the most popular point-of-care ultrasound application is the trauma application, followed by gallbladder. I'm surprised, actually, gallbladder. There is definitely the cardiac, the procedural guidance. So from my just quick visual view, trauma definitely is the lead. And you're absolutely right, because this was the first introduction of point-of-care, came along with the trauma, but the number of applications of point-of-care has grown over the past few years. Now, how often do you use it? Because I'll tell you, even if you're trained, when it's a busy, sometimes you might not use it every day. So it's important to see how often do we actually use it. But I can see that's awesome. 40, 30, the majority says they use it almost every day, which is very, very heartwarming for me, and it's great. And even more why I want to emphasize in my talk, how do we manage ultrasound in our emergency department. So the majority of you actually use it on daily basis. And this will, inshallah, will make my presentation more relevant. So according to the American College of Emergency Physicians, they identified 16 point-of-care ultrasound applications. And I will tell you, this is the latest guidelines that was published this year in April. And this is only growing, the number of applications. There are other settings and population where this use of point of care is growing in. And I will tell you, pediatrics is one of the most important. There was another point of care talk using in pediatrics trauma, critical care, pre-hospital, public health, and military. Just for my colleagues in pediatric emergency medicine, there was a recent update in the pediatric emergency medicine curriculum in US that point of care actually is an integral part of that fellowship integration. This tells you the importance of using POCA, especially in the pediatric population. So training and proficiency. and this is maybe boring to some of you, but for the educators and the decision makers in the room, I think it's very important and it's very clear. Obviously, we emphasize on knowledge, but there is a big part of it, it's psychomotor skills acquisition. So motor skills teaching, and then interpretation and integration of what you learn into your practice is the most important part. So how do we actually, I think personally, from my experience, teaching the knowledge aspect is quite easy. The skills and the integration is what really we need to focus on, especially when you're early in your career as a resident, as an intern, because it's a skill that requires practice. One of the earlier lectures was saying about cardiac. It took me 1 whole year of practicing cardiac echoes to be able to think that I'm confident enough actually to use it in my clinical decision making. Now, the level of training, many medical schools use it in their undergraduate. From my literature search in the GCC, this is still not yet well established, but hopefully we will try and work out something with the undergraduate leadership team here. How do we incorporate POCUS? But it is definitely very evident. I reviewed the Saudi Commission curriculum for emergency medicine, and ultrasound is established in the residency program. Fellowships, we still don't have a dedicated point-of-care ultrasound fellowship in the region. I know that my colleagues in Qatar have established one recently, and in the region we have maybe some certification programs adapted by international governors such as WinFocus and other things that provide these certification. Now, why am I emphasizing this? Just because point of care is a skill, and I think it's very important for us to identify what is the background training that the physician receive to be able to appropriately privilege them to actually perform these point of care ultrasound, especially if you're going to make critical decisions based upon them. I get a lot. They say, you know what, you guys did the ultrasound and it was negative, or this ultrasound was wrong. So it's important that we develop a system that actually supports the use, and the most important part of that system is the quality assurance. So educational methods, you already, mashallah, are very well established. You have access to all these amazing online, very well reliable educational material, narrated lecture, podcasts. So I will leverage on that and spend the time giving hands-on experience, which you guys had an amazing point-of-care ultrasound workshop. I'm sure many of you in residency have ultrasound scanning shift that have supervised examination performed during your clinical work. And then the most important part is closing the loop by having quality assurance of these images and giving the trainees and physicians feedback. And simulation is very, very important because there are very good task trainers that can help, especially before they use it in the clinical practice. Now, I think personally, from my experience in residency program back in the UAE and currently in my clinical practice, this is where we are still lagging behind, is documenting this experience and the proficiency. So procedure logs. Do residents in the room have a certain number of procedures that you're required to do for ultrasound? Yes or no? Because from my review in the curriculum, there was no number specified. They just said proficiency in performing ultrasound. So there was no number. And then, in terms of quality assurance, having standardized assessment, whether it's going to be through OSCE, through standardized direct observation, simulation assessment, I think it's very important that we treat, because if you're asking emergency physician to use this skill in their future decision making, we have to make sure that they're proficient. Attending a workshop is not enough. By chance, you are maybe having excellent trained point of care ultrasound expert in your team who you try and tag along with, but that should not be by chance. It should be embedded in the curriculum where you have a point of care ultrasound rotation, your scans will be reviewed, and you need to complete certain number of scans before you graduate. And so this is the guidelines. The benchmark says you need at least 25 to 50 ultrasound scans per application to actually reach that benchmark of being, proficient in that. Obviously, along with assessment. This is a lot of work. But trust me, you're already doing it because you scan every day. But does that mean you actually save the patients? demographics, save the scan, have a faculty to actually later review this? I'm not sure. From the program that I've been closely working with, I would say this infrastructure is not there. And I think we are at a level where we have enough point-of-care ultrasound trained in Saudi, in the UAE, that I think we need to emphasize the importance of establishing this system. So by the end of your training, 4 years in emergency medicine, you need to have a minimum of total of 150 to 300 application. That range, it depends on what are the number of applications you will be taught. And this is based on the curriculum. So it depends on how many applications you will be required to complete and be proficient at. But this is the minimal number that you need to complete by end of your training. And then thereafter, every emergency department, especially who uses point of care in their patient management, you need to have a system that you will actually audit and quality assure the images. And that's at least 5 to 10% of all of the images that are saved in the and done in the department. They should go under quality assurance. Now, when it comes to fellowship training basically trains you to be an advanced leader in point-of-care ultrasound. So whoever is fellowship trained will probably be the point-of-care ultrasound lead of that unit or division within the emergency department. It is not, you will be entering that fellowship to be an expert in point of care. However, the expectation that your routine utilization of point of care should be part of every emergency physician's training if you went through structured point of care ultrasound education. So I just want to make sure you don't need to be a point of care ultrasound fellowship trained to use point of care. However, you need to have structured ultrasound training during your undergraduate, during your residency, to be able to be privileged to actually use point of care appropriately credentialed. And this is where the quality and ultrasound management in the emergency department is very, very important. This is to help us ensure the quality, facilitate education, and satisfy the credentialing pathways and plan for improving the process, because we're using this to make decisions. And it's important that we have this safeguard to actually close the loop and give the providers feedback. So all of you will know the outcome of your airway skills, right? By the number of actually successful intubations. So you don't need to actually, your head of department will tell you how many procedures you did this and that. When it comes to ultrasound, you actually documented it in the patient's note, made decisions of it. But who will give you the feedback? Nobody. And I think this is what is lacking. This is the chain that is lacking in our system. And I'll tell you, it's the same in the UAE. So do you have any ultrasound management process in your department? And I think this will really help to move forward. So you see, the majority said no. You know, some said they're not sure. And there's a 12 of the people in the room said that they have an ultrasound management process. And I'll tell you, this is awesome. But I think the number that is the higher number should change. Because I think most of you, from the earlier poll, said that you use ultrasound in your clinical practice. So how do we actually manage that? And it's important for the head of departments, the leaderships in the hospital, to consider establishing an ultrasound division, ultrasound unit within the emergency department. The most important person in that will be obviously the lead of that division, the director of point of care ultrasound, to make sure that we actually manage and quality assure all of the imaging. So what does that process require? So all of the images that are done, especially related to patient care, the images should be saved and archived. So appropriately labeled. So you go to the machine, you put the patient's name and everything, and you save it. Now, many of the departments in North America, they actually have electronic, archiving system where all of these images will automatically upload in there. Some hospitals go directly to PACS, but have limited access to emergency providers, not the whole hospital. And others, there are other solutions. So that is the first most important. Many of you do it, don't save it, صح? and just make decisions. Obviously, we understand, but for quality assurance purposes, saving your images will be very, very important. And then you have to document your finding in the chart using a standardized documentation. Image review. This is where it will be done and led by the point of care division chair. So they usually will have weekly image review session that they will go through at least most of the images, and then they will provide feedback to whoever saved that image, whether it's a resident or the faculty who did and supervised that image, and all of these images should be archived. This is really the quality improvement process that every department who uses point-of-care ultrasound in their decision-making should have well established. And this ties along with risk management. If we don't have this process, how everyone can challenge you about your ultrasound finding because it's not saved, right? No one knows if it was accurate or not. But trust me, ultrasound is an excellent risk reduction tool. But if we don't have the proper process, it might actually lead to risk because we don't actually have any evidence of the decision that is made based on your point-of-care ultrasound. How can you reduce your risk? Obviously, you increase the diagnostic certainty, you shorten the time to definitive treatment, you decrease the complications from procedure. And it's important to make sure if you're going to use it for risk reduction, you need to have a quality assurance process. And this is a quote: "The greatest risk regarding emergency ultrasound is the lack of its use in an appropriate case." So far in the literature, you rarely find any cases where someone actually complained and had raised a lawsuit because of using ultrasound. It's actually for not using it because of delay in findings or management of the patients. And then reimbursement. I'm not sure of the Saudi system. Do you bill or charge for ultrasound? No. But eventually, I'm not sure, but UAE, we are going that direction. So that's the reason why many of the departments are interested in actually developing the quality assurance, because you need proper quality assurance and process to be able to, reimburse for these for the studies. With point of care, obviously the technology is growing. There is wireless transducer, handheld devices, app application, AI that is integrated in many of these machines, and the introduction of telesonography. This will affect how we use ultrasound in the emergency department. It used to be this portable machine that we wheel in, but now with this access of technology, it will definitely revolutionize, but it does not affect the process of our ultrasound management in your emergency department. Trust me, if we develop that, it will be so much better than, because you will find many anecdotal cases where you were lucky enough, maybe you were working with an ultrasound train, but you might be working alone, and you feel you're competent enough, but you need someone else to make sure to quality assure the studies that you conduct. So in closing, I just want to summarize a few points. So emergency ultrasound is a fundamental skill. I think we are all, practicing it. If you're junior, you are part of your training. It's integrated in your practice, so that's a no-brainer. The scope of the use can be in different categories, and there are very well-established applications but remember, training and proficiency should include knowledge, skills, as well as how to integrate this finding in your patient care. Because you might be able to interpret a slide, an ultrasound finding, but how does this go and affect the patient's management? And then ultrasound training in emergency really should be, obviously, luckily it's integrated in the system, in your curriculum already, in the Saudi Commission curriculum. I would just recommend that we really define the number of procedures and how do we assess the proficiency in these skills. And it should be very similar to any other skill that you are taught. There should be proper credentialing process in your hospital to help basically delineate. Maybe you have more training in trauma. I see most of you use it very frequently, but you might not be privileged to do cardiac or gallbladder, and it all depends on your training. So the departments should actually have a very clear pathway. And I'll tell you something, you will not do this work out of scratch. these are very well established privileging and credentialing process that are published that can be adapted. The quality assurance and management of ultrasound is very, very, very important. Yes, it requires resources, and that's where convincing the head of department might be a challenge, but you need to give them the benefit and the importance. And I'll tell you, this is guidelines. This is not anymore a luxury of having an ultrasound management system in an emergency department. This is the best practices and recommended guidelines for managing point-of-care ultrasound. So you will need to have a dedicated physician director to that program. You will have obviously the machine, digital management system. How will you give your providers feedback? And all of this requires resources. But whoever is interested, I'm more than happy to actually work with you to convince the head of department, because I think, honestly, I was so happy to hear all of the presentation. Ultrasound is mentioned in almost every single presentation since the start of the conference. But we need to make sure that we actually have proper guideline practice to safeguard and quality assure this. And then finally, the evolving technology will definitely affect how we use this technology in our patient care. With this, I would like to thank you, and thank you very much for paying attention and participating in the poll, and I'm happy to answer any questions if the moderators have time.
Any questions?
يعطيك العافية دكتورة. Do you think that AI can help with the quality assurance of the images in the next coming years?
Excellent question. And honestly, this is a very interesting research area because, like you said, quality assurance will take time. And it depends on the volume of ultrasound done in every department. I know there are some solutions that actually have AI integrated in it, but you need to buy the unit related to it. What I foresee, the future, probably the digital management system will have AI, integrated in it to help the program director to actually, interpret, is this good or not? But they are not yet well established. Some units, and I will leave them unnamed, have them, but others are still, I think in the next 10 years, for sure, there will be a smart system that will help the quality assurance.
I have a comment/question.
Yes, sir.
So you touched on this and you said you want to go to the head of the department to have this supported one way or another. If you ask any of my residents, I usually tell them I don't like to play radiologists. I don't play radiologists. It's not that I don't use an ultrasound, but there is a problem with authenticating or making clinical decision based on my ultrasound. Usually, hospital administration does not give us the privilege as emergency physician to report these ultrasounds and to take actions upon it. Like, for example, if you see someone and you say he has an acute cholecystitis, you call on the surgery department admit this patient, he might need surgery or something like that. They say, no, we will need an official ultrasound to make that decision. Did you go through wherever you're in UAE, where you did something to overcome this obstacle?
Absolutely. So this is a very, very valid question. And I will tell you, these are battles that are still many departments are struggling with, but have been actually won in others. So I think we should learn from experiences. So when you say, I will not replace the radiologist, absolutely. There is no mean that we are actually replacing radiologists. Maybe that cholecystitis can wait, and that's fine. But there are someone who comes in shock, and you're not really sure what is the cause of the shock, and your decision making can be actually. So you have to decide what will your physicians in the emergency department be privileged with. And I think if you have success stories to convince the management with that, will be very important. And I would start small and then expand. And it all depends on the needs. If you tell me you have someone who is in shock, and I'm not privileged to make any decision making on whether if this is cardiogenic shock or this is obstructive shock, it's gonna make, and these are time sensitive. There's no echocardiographer who is going to come at 2 a.m. when you have that hypotensive, hypoxic, and you're not sure if this is massive PE and you want to make a decision, are you going to do thrombolysis or not? So I would pick, so whoever, I think establishing an ultrasound division within the department is the first step. Next is for that program director, there will be probably a point of care ultrasound have advanced training in point of care. They will identify what this department commonly use, and they will develop a privileging system. So for example, you identify trauma. This is one of the most common. For example, you want to identify the rush protocol, you will do the basic cardiac in it, IVC, AAA. So you will identify 5 applications. Make sure all your emergency physicians are actually privileged. And that's where you will actually start small, and you will build the confidence of all of your emergency physicians. And it might not be for all the applications. Maybe gallbladder, you know, the cholecystitis, they can wait for having a formal ultrasound. But there are important life-saving decision-making parts of the use of point of care where it will make a big decision, and important that it is efficient and quick, but we need to have the proper training, proper privileging, so nobody will come and question, why did you make this decision later on?
Yeah, okay, one more comment if you don't mind.
Absolutely.
Regarding the stethoscope use, whenever I have chance to talk to students or residents, I tell them that stethoscope will go to the museum sooner or later, and everybody should have his own ultrasound. The money that you keep for a branded bag, you can't just save it for ultrasound maybe, or if you want to buy a car, just save some money for the ultrasound. So what do you think of the stethoscope in the future?
So I'm from the school of, I think stethoscope should stay, but it's limited to its use, and we know everything has its own limitation because technology can fail. Technology will fail at some point, right? For one reason or the other. These are 2 separate skills that I think complement each other rather than actually delete, you know, from one another. Because if that ultrasound machine is not charged and you need to listen to the patient's chest, you know, for one reason or the other, I would rather that have both of the skills that I'm competent in, and they will complement rather than actually delete or, you know, replace each other. But I agree, using point of care early. I feel like when I changed location, the department I went to did not have point of care. I felt like I'm blind. داخل غرفة المريض, I really felt part of my complete assessment of the patient was missing. So it is integral, but I don't think we'll replace the stethoscope. Thank you.
Thank you so much, Dr. Rasha.
يعطيكم العافية. Thank you.
So regarding our next speaker, me and my colleague Dr. Khalid, we had a huge argument who should be presenting our next speaker. We played rock, scissors, papers, and I won, but Khalid reminded me later on that he was my senior and my teacher at some point, so he got to introduce him. Dr. Khalid.
So Dr. Azam is an ECMO specialist from the critical care, and he is the president of ECMO Society in Saudi Arabia. So welcome, Dr. Azam, please.
Of course, if you read the bio that he sent us, there is nothing related to emergency in his bio. He's a medical director of this, he's the chairman of that, nothing related to emergency, so I'm not sure why they invited him to this conference. So,
just to say hi to my old friends. طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Good morning, everybody. I thank my colleagues for introducing me and the scientific committee and the organizing committee for this great conference and inviting me to it. Before I start my lecture, my take-home message, which is not a clinical part, is if you want to do something, you can do it. And I think as ER physician, we are leaders in our society and our field, and we can become national leaders. And if you see our colleagues everywhere are leaders, whether in the MOH, National Guard, the military hospital. They have succeeded and they did great jobs. And I think this is one of the successful stories in Saudi Arabia, and I'm really proud of coming to this level. And we will discuss what we have done in Saudi Arabia in terms of ECMO services. So this is my outline. I'm not sure why my slides have some problems, but it's okay. So my outline is to introduce you what is ECMO and brief history about ECMO and ECMO during the pandemic and what we did in Saudi Arabia, especially in the Ministry of Health. So it's an extracorporeal life support. It's basically an artificial lung and a machine, a pump, that help you to replace the heart and lung of a patient when they fail after you exhausted everything. The main two functions are is VV ECMO, veno-venous, when you want to support the lung, and veno-arterial when you want to support the heart. And so the indication is acute refractory hypoxic or hypercapnic respiratory failure or acute refractory cardiogenic shock. It's an advanced service to the point now that ACLS recommended when you have severe patient in cardiac arrest and refractory cardiac arrest. So we do something called eCPR, and now it's part of the ACLS guidelines. It is already recommended since 2019 in the ACLS. And just to understand what's the patient journey, so you have three phases: acute, and then the subacute phase, and then the chronic phase. So the acute phase is the emergency part, when the patient really needs the service and you need to reach him fast. In a respiratory case, you have up to 6 hours, depend on the patient condition, but in cardiac cases, you really need to be at the patient's side somewhere between 0 to 1 hour. And then you have the ICU phase, and it ranges, depends on cardiac or respiratory, between 5 days up to sometimes 3 weeks, and there is cases in the literature that actually stayed almost 500 days on ECMO, especially cases lung transplant, and they did the rehabilitation on the machine until the patient is ready to have lung transplant. And then, as you see, the rehabilitation phase at the end is the 1 to 3 months. That's the average, but I said you can have longer periods on ECMO. So the history. So this is the Bramison machine, this big machine on the side of the patient. This was actually the first adult successful ECMO case, was done in 1972. So it's a very old service. It's not something that we invented recently. However, the evidence has shown in the last decade. So as I said, first case was in 1972. It was a trauma case with severe chest trauma and ARDS, and the patient was put on this machine to calm his hypoxic respiratory failure, and he responded. The next case was done in neonate. 1976 was a successful story. And then in 1989, ELSO registration, ELSO society came. ELSO is like ASIP for us. So this is the international body that has educational, putting policies, taking data analysis for all the patients all over the world. And it's a well-recognized organization. Since 2000, so again, from 1989 until early 2000, there was cases and there was a patient that was been on ECMO services. However, it wasn't that famous because, again, it's a very expensive service, a very advanced service, and as we know in our practice, evidence is the way that guide us to do things. However, this is cases that is very hard to do evidence because it's rare. But then during the pandemics, starting SARS and H1N1 and MERS-CoV, because of a lot of respiratory failure and a lot of cases going to ICU, ARDS, it became more famous, and we started to see more of the use of ECMO. The evidence, the biggest study was the CAESAR trial, which showed the decrease in mortality comparing to the conventional therapy. And these were in centers that are very, very advanced in managing. So everybody who needed an ECMO was moved to this center in England, and they were randomized whether they get ECMO or they get conventional therapy. And despite that, in an advanced center, ECMO group was having a better survival. And then recently, the EOLA study which showed also different in the mortality, 35 in ECMO patients versus 46 in non-ECMO patients. This is the ELSO registry. It shows an overall international survival rate in 55 to 60%. Very important to understand, these patients, if they don't get ECMO, their mortality rate is 100%. Nothing is 100%, but it's, let's say, 95, 99%. So when you look at ECMO, and especially for people who would like to start a program, when you talk to the administration, it's not about, this is a big number, 55 to 60% survive. That means about 50% are dying. But the talking is different. You say, no, this patient, if I don't put him on ECMO, he will 100% die. If I put him on ECMO, he has a 50% chance that he will survive. As you can see, the numbers during the years has been going up. It's almost now 120,000 cases per year. During the COVID era, there was around 8,388 cases that were done, and with a 48% in-hospital mortality. And this is just to see that the disease of COVID, and that was a big challenge to us when we started, whether we should introduce the service during the pandemic or not, because at the beginning, all patients who went on ECMO actually died due to crisis resource management and due to the disaster situation all over the world. And that was a difficult situation. How would you manage these patients with a very expensive service and using the ICU beds for a longer period, and maybe other patients would need that ICU beds. So the disease itself is completely different than the regular ARDS patients, and that's why the numbers were less in terms of survival. So what is the Saudi experience? So actually in MERS-CoV 2014, now ECMO is in Saudi Arabia for a long period, especially in the biggest hospital, National Guard, King Faisal Takhassusi, and King Faisal Specialty Hospital, and Military Hospital. Again, these services were given to the patient in their hospitals. So it was an individual service for their patients. During MERS-CoV, an initiative was done by the MOH by purchasing almost 50 machines and distributed all over Saudi Arabia. But to be honest, it was more in Jeddah and Riyadh. There was 2 centers following the MOH that was giving the service, Prince Mohammed bin Abdul Aziz in Riyadh and King Fahd General Hospital in Jeddah. And these hospitals were receiving patients who needed ECMO, and there was 2 or 3 players that were responsible at this service. Unfortunately, it was, again, an individual service, and once the corona phase or the MERS-CoV phase disappeared, it was very difficult to reach these patients to reach the service because nobody knew how to contact them or how to communicate them. I'm sure in Jeddah, Dr. Mohammed al-Shahrani was a leader on this, and it showed that there is decrease in mortality comparing to conventional service. So as I said, so it's 100%, almost 100% death if you don't get ECMO, and 60% if you get ECMO. In 2018, as I said, we established the extracorporeal life support, and then the first ECMO was done conference was done in Riyadh, hosted by Prince Mohammed bin Abdul Aziz Hospital. And then, as I said, that these are the establishment group that created the Saudi Extracorporeal Life Support chapter, different doctors from different fields and nursing and perfusionist. And this was the vision of the Extracorporeal Life Support, and basically was to improve the care and the standard of care for ECLS services through education, awareness, consultation, and developing programs in hospital or at the national level. As always, education awareness is the way to get to people before you start developing policies and procedure and having a service in a hospital. There was a lot of courses locally and internationally. SWAG is one of the international conference that's taking all the region of Southwest Asia and Africa, and Saudi Arabia is a representative of this, and every year they have an annual conference. This was in Egypt. We have been holding the training in Dubai for the last 5 years, I think, or 7 years, in the Critical Care, Emirate Critical Care Society Conference. And as I said, in 2020, things just boomed, and we started to have more program or more organized service for ECMO. So in brief, as you can see, January, we started to have a committee to understand what's going on with the global pandemic and how are we going to get this service in Saudi Arabia and whether we should implement it or not. The first case was done in April. The case was in Tabuk. And remember this when we get to the start of new centers in Saudi Arabia. So ECMO was done in Tabuk. This was the first center. There was no ECMO service in Tabuk. We just implemented the program a month before, and they had the first case, and it was a successful story. And now they did almost more than 30 cases, which is a big success for a small center starting. And then we developed a national ECMO hotline. So basically you call 1937 and you'll get the life-saving line and you will ask for an ECMO expertise and they will answer you and they will decide whether you get ECMO or not. The program started, as I said, 2021. I was assigned as the head of the national program, and we developed the committee it's a scientific committee to help us in deciding whether all the supplements and equipments and how much do we need and how many machines do we need and which center should have the ECMO. It's very important. Again, it's a very attractive service. ER guys would love this. It's resuscitation, you know, your adrenaline goes up. However, you need expertise. So to say that we should have this in every hospital in Saudi Arabia, that means nobody will have expertise. Again, the total number in Saudi Arabia up till now that we do is somewhere between 250 to 350 cases per year. So imagine if 10 hospitals have ECMO, that means each center will have 30 cases. 20, they will have 15. To become an expert center, you need at least above 20 cases per year to call yourself as an expert center. So more centers is not actually good for the outcome. Again, to have ECMO, you have to have an advanced ICU, you have to have an advanced ER, you have to have advanced OR. So it's not just a service that you just plug in and then the rest of the hospital is not up to that standard. And this is just to show the things that we were doing as a, sorry. Yeah, how did we assess equipment and supply? At that time, we had 72 machines in the country. We developed policy guidelines and we had a flow chart on how to call and what are the indications to call. We were very, very selective. Abu Abdullah here, Dr. Usama Kintab. Yeah, Dr. Usama Kintab almost made me feel that I'm not Muslim when we came with the first selection criteria, because people were saying which age should we put people on ECMO. As I said, it was very, very difficult decision. So my colleagues said 35 years old and above, no ECMO. And with big hustle, I said, you guys are not going to talk to the public. I'm the one who's going to talk. So we decided it will be 45 years old. And once we send this the policies, I received harassment calls from everybody. I was 44 at that time, so I was okay. So I wasn't worried about myself. But it was a very difficult decision. And interestingly, this was all based on expert opinion and just looking at what's happening in the world. And then when things got better, we increased the age of 55. And what's interesting, all the literature that came, even from our Saudi local literature or Saudi local data, 55 was a cutoff age, and everybody who was less than 55, their mortality was somewhere between 45 to 50%, and once you hit above 55, it went up to 80%. And it was actually a contributing factor to mortality by itself. So, and all the literature that came from France. France is one of the biggest countries that has ECMO. They do almost in one center 400 to 500 cases. That's one center, and it's very famous, L'Apité. And it was interesting that the number that we suggested is actually now became a factor of mortality. So if you have someone above 55 years old, talking about COVID, we're not talking about any ARDS, just specifically for COVID, that their mortality goes sky high if they were above 55. We developed MOH guidelines. So we have guidelines for COVID patient, and this guidelines is more for people who are calling for the service. So what's the selection criteria? And if you want to call, these are the indication and how to call and how to do initial management until the expert team comes. And this is a slide that I'm proud of. This was 2014, 2019. This is the ECMO service. Again, we're talking about MOH, but even if we can, if you include the MOH centers, there was probably 4 centers around the country, and now we're talking about 13 to 14 centers around the country, active ECMO centers, receiving patients, retrieving patients, going outside the country to bring patients, and this is really something that I'm proud of. The 1937 ECMO hotline is a 24/7 service. You have ECMO physicians and perfusionists and lifeline specialists. These are the people who answer your calls, and nurses and RTs. Almost now 19 consultants, 5 cardiac surgeons, 33 nurses, as you can see from the slide. And we have a flow of how we communicate and the time limits. So we have KPIs for when to answer, when to reply, when should the consultant reply, when should the team get deployed. And we have a dashboard now at the level of the MOH that shows all the numbers and the cases that has been done. And this is our ECLS survival. So the definition of ECLS survival is once I remove you from the machine, so you're off the machine, and you're within 48 hours. So this is, if I remove the machine and you survived up to 48 hours, we call this ECLS survival. Anything after that, it's called ICU survival of ECMO, and then 90 days survival. So it is an important factor in ECMO, just to see if you died because of ECMO itself or not. Because if you die 48 hours, it's probably due to other complications, sepsis, MI, or something else that happened to you in the ICU, but it's not related to the technology. So it's an important KPI or research point in ECMO literature. So 67% ECLS survival, and this is very, very, very good numbers in a pandemic situation. So internationally, it's somewhere between 55 to 70. So we're in that range in a pandemic. And then patient who died within 90 days, so we had a 43% survival. Again, comparing to numbers worldwide, we're close. Internationally, it's around 50%. One of the main problems was really infection control. And patients were dying. A lot of patients who died, they came off the ECMO, but they died because of multi-drug resistant bacteria, and that's one of the reasons. The type of ECMO most common was the veno-venous ECMO, which is respiratory ECMO. And this slide for the final outcomes of the patients. What was interesting also, again, for administrative point of view, ICU length of stay. So as you can see, VA ECMO length of stay was 10 days if you're not on ECMO, if you're on ECMO, and your average length of stay in ICU was about 15 days. So again, it did not increase the days in ICU because you were on ECMO. Actually, some centers, the people who were put on ECMO were faster. They got off ECMO faster and they were discharged faster. Because again, the longer you stay on a ventilator, the more chance that you're going to have lung injury. So aggressive centers actually were putting people on ECMO earlier, and they had less times on inside the ICU. 80% of the cases in Saudi Arabia were retrieved. I'm talking about the retrieval cases now. So the retrieval cases, 80% were done by ground transportation and 20% were done by aeromedical transportation. We actually had 4 cases retrieved from outside the country, from Jordan, from Kuwait, from Emirates. There were Saudi patients that we went and deployed our team there, and they brought the patient back. And the team actually go and put the patient on ECMO and then bring them back. It's not patient already on ECMO. Publication, we had a lot of publication during the COVID pandemic. We did actually the first awake ECMO case. So this is actually a doctor, a thoracic surgeon, who had spontaneous pneumothorax bilaterally without intubation. And the decision was to put him on ECMO because if we put him on a ventilator with his pneumothorax, he's not. So this guy was awake and talking to us and while he was on ECMO. And he had a successful story, and it was a case report. And it was interesting, this study or this case report, before publication, there was a lot of resistance to get it published. And the reason was there was a Spanish team who had like 5 or 6 cases the same, and they wanted to publish, so they were trying to postpone it so they can publish. But alhamdulillah, we were able to publish before, and it was also one of the historical now articles that are put as reference in ECMO studies. Now, these are 2 important articles, especially the one below. So the ELSO, as if you remember when we talked about ELSO, ELSO is the big organization, and one of the guidelines that they implemented during the pandemic is do not start a new ECMO center during a pandemic, because you will cause high mortality, and because there is no expertise, people were not, it's not going to succeed, this program. And during the pandemic, we had 3 new centers. We had the Najran Center, Tabuk Center, and Medina Center. And I would say Mecca also they were actually doing a lot of cardiac. They were not doing respiratory. So we reactivated Mecca Center. And then we published our data. And the new centers actually had the same outcome as the expert center, and some of them actually, if you look at individual, had better outcome and had better survival rate. And the ELSO guidelines changed based on this study, that they said if you are in a country that has the capability of actually able to manage pandemic in a way well organized without chaos, you might actually consider having new ECMO center. So it was a game changer, this article, and alhamdulillah, we're proud that it came from Saudi Arabia. We had an expert consensus about the COVID, ECMO use in COVID era, and you see how much representation from Saudi Arabia, mashallah. So I think we are becoming a leader outside in this service. The other things that we have accomplished, had 2 big conferences. SWAG ELSO was hosted for the first time in Saudi Arabia in Riyadh in 2022, I think, and then, 21. And then our first Saudi ECLS conference was hosted in Jeddah last year. Other accomplishments that are happening right now, we're going to have a national data registry where it will be implemented by the Saudi Health Council, where all hospitals will be connected to it, and all the data will go through that, so we can have more understanding of the service and have research and KPIs. We started a pediatric ECMO, so now we have a pediatric ECMO retrieval team led by Dr. Nada Al-Jassim, pediatric intensivist, and Dr. Hani Mufti, cardiac surgeon. And I think in the last 2 months, we have 10 cases already, so that's a very successful story. Future is having a fellowship, structured fellowship and diplomas for nursing and RTs, and I think this is also coming very soon. And by this, I end my lecture. And thank you very much for your time. And if you have any question, I'm ready to answer. Thank you.
Thank you, Dr. Muhammad, for this interesting and very insightful lecture. We're actually proud that a member of emergency community is part of this progress. Now, my question, before I go to the audience, I'm eager to ask this question. Since ECMO generally in Saudi Arabia has been monopolized by critical care and cardiothoracic surgeons, what is the status of emergency physician role in this, and what do you expect us to do in the future?
So very good question. I think the emergency physician should have a role. The problem is how much cases can they do. You need training. You need to have exposure to these cases. I see in the future all the retrieval cases should be done by emergency physician. Again, when we go for retrieval, you're taking an intensivist from his work to go, and then the next day he's going to come and manage the patient. So they leave when they're on call and they come back, and it's a lot of work for the intensivist. Emergency physician, our nature of work, we do shifts, so we can take on calls even outside our shift, and it might be easy just to retrieve because transportation is bread and butter for emergency physicians, and just adding an extra skill to them is important. The other big role is and the other big role is ECPR. So patients having cardiac arrest and in refractory cardiac arrest, the first person who can manage these patients is the emergency physician. So in the best case scenario, if you have an ECMO or ECPR team in your hospital, it will take them at least 10 to 15 minutes to reach the hospital to be able to manage this patient. But if you're there and you know how to do the skill, then it has to be done by an emergency physician. But if there is emergency physician who are trusted, I can tell you during the years, a lot of emergency physicians contacted me to be part of the team, and I said, yes, of course, welcome, and we'll attach you to the teams. But this is something that I don't push on people because you have to have the interest. It's not a normal life to be working in an ECMO team. You get called, you have to get deployed immediately. So if there is a group of people who are passionate about this, then they're welcome, but they know that they're just adding extra headache for themselves.
I guess we can start by doing this as a section in SASM and go from there.
Sure.
Questions from the audience?
Shukran Mohammed, the presentation, the 67% survival, what's the percentage of them they have good neurological outcome?
So the 90 days survival to discharge is about 50%, and they are neurologic intact. So people get discharged, in Saudi Arabia, people get discharged from the hospital. Usually they are normally functional. So neurological outcome in this 90 days survival was about normal neurological. About 85% of them were back to normal function.
Any more questions? Dr. Ammar.
Question regarding the cost, the financial cost of the ECMO patient versus an ICU patient. What if the patient is in the ICU? How much the cost per day? And if the patient is on ECMO, how much that cost would go up? And then the uses of blood bank products, what are the challenges and how much are we talking about?
Very good question. I don't think any study that has actually looked at the cost or compared the cost between ECMO versus non-ECMO patient. However, from the experience, the cost is the cannulas and the equipment and the supply. You're talking about somewhere between 30,000 to 50,000 riyal, depending on what machine you're using or what company that you're using. If you want to compare, is that you compare the ICU length of stay. And the difference between ICU length of stays are not that different. In a COVID era, you had different between 5 to 10 days extra in the ECMO patient. And I think this is great because in a regular ARDS, they probably will have the same ICU length of stay. There will be some cases that are sick or they're going to go into fibrosis and they will stay longer in the ICU, but this can happen also with the conventional therapy. It's a life-saving procedure. I would look at the medical outcome first before the financial outcome, because I think Muhammad's question was valid. If we're making them survive, but then they're bedridden with severe neurological disability, then yes, you're wasting your time. However, because they are actually having a good neurological outcome, it's probably nothing to compare 30,000, 50,000. If you want to compare it to PCI is double or triple the price of an ECMO service to a patient.
Afia, my question is how much of these cases are initiated by ER physicians and in terms of consultations? And are we missing a lot of cases, good candidates, that their outcome would have been different if they were initiated early in the emergency department?
Because of most of all these cases are respiratory cases, so probably the ER physician has not much of a role, because you're going to intubate them in the ER, and then they're going to go to the ICU, and then the escalation of service will go up until they're paralyzed, prone, and then after that we'll talk about ECMO. Are we missing cases in ER? We're probably missing the ECPR cases. We're probably missing the cardiogenic shock cases. But at the national level, I don't think we're ready yet to accommodate these patients. There will be a pilot trial in Riyadh, I think in the next 6 months, where we'll see if we can do ECPR. So basically, once there's someone who passed 5 minutes of cardiac arrest, shockable rhythm, with the pre-hospital team, they will just push them directly to an ECMO center and they will be activated. It's still in the phase of studying. Once we reach that, then I think, yes, there will be more role to the ER, and then we'll do more awareness. I don't think we did awareness from our side to the emergency physician to ask them to refer cases, because still there is no indication really at the national level for that. But if you're in a center that has an ECMO service, you should start talking to your colleagues in the ICU and see how are we, in case if we had cases that come to the ER, how are we going to initiate the service from the ER, especially for cardiac cases.
Okay, just last question, Dr. Azam. Okay, regarding the survival rate for cardiac arrest patient, the percentage of 50% or so looks like a bit inflated. Is that for all cardiac arrest, or you have a subgroup analysis for selective cases, or what?
And it's coming from data in centers that are doing ECMO very, very active. France, Germany, England, Prague. Where's Prague? Forgot. Ukraine? Sorry.
Europe, yeah.
Or Czech, sorry. Yeah, so these centers, they have pre-hospital service. They have pre-hospital ECMO services, and they're very advanced. So these numbers are based on patients who are indicated for ECPR. To say that you have an ECPR, that means you passed 5 to 10 minutes during your cardiac arrest, and it's shockable rhythm, VFib or pulses VTAC, and you already inserted the ECMO within 20 minutes from the arrest. And these numbers are coming from that. So again, it's not representing all cardiac arrest. It's a selective patient. There's a recent study called the Prague study, where they compared, it was a very good study, with a randomized clinical trial between a patient who had ECPR, a patient who had conventional CPR, standard CPR, versus ECMO CPR. And the mortality, the survival rate in the standard group was 18%. In the ECMO group, 1 to 36. So it's almost double the survival rate. But you have to have the whole system. You cannot do ECPR and your paramedic is not able to do just regular chest compression. It's a whole cycle.
I guess thank you so much. If you have any further questions, you can contact the speakers directly. Before we end this session, I would like to ask our speakers to come back to the stage. Dr. Ammar and Dr. Rasha, please.
by experts in the fields of emergency medicine. So we will continue, and now it's honestly an honor and a pleasure to introduce the upcoming speaker. He's a consultant, emergency physician, sports medicine, and an assistant professor of emergency medicine in the College of Medicine in Qatar University. And he's also the chairman of emergency medicine at Hamad Medical Corporation and the regional director of the Middle East and site director for the Canadian Point of Care Ultrasound Society. So this is Dr. Aftab Mohammed. He's joining us to speak about the first 10 minutes in shock and the use of ultrasound. Welcome, Dr. Aftab.
Thank you very much, Dr. Rasha. It's really a great pleasure and honor for me, and I'm very lucky that my moderators are Dr. Rasha and Dr. Muhammad Khogir. They didn't tell that I'm working very closely with both of them, so thank you very much for this honor. And first of all, congratulations to all of you for your National Day. A warm congratulations from State of Qatar. By the way, it's a very huge topic, and I'm not sure if most of you know it, that both myself and Dr. Rasha love point-of-care ultrasound, and we have been trained in that. It's a topic which is given to me, and we can speak on it for days. But we will try to make it very quick and give you an overview that how we can utilize this in our daily practice. So thank you very much once again. That's already Dr. Rasha has mentioned. I'm coming from Qatar, working as a senior consultant and chair of the emergency department. This is where I'm coming from. You can see multiple hospitals we have currently. We are running 5 hospitals under one umbrella. We call it Corporate Department of Emergency Medicine. I have no disclosure, no conflict of interest, except that we are POCUS enthusiasts and we love point-of-care ultrasound. So this is going to be the outline for next 20 to 25 minutes, why we do POCUS. But before I go forward, before we move forward, may I just ask a question from my colleagues? How many of you are practicing or use in your daily practice, you are using point-of-care ultrasound? Just show of hands, except this side. Except this side, hey, I know that. Okay. So how many? Right, that's great. So that's more than 70%, I guess. Now, let's see how we can make sure that by the end of this session, or by the end, you already had a session in the morning on ultrasound, so by the end of these sessions, how we can convince all of you that this is going to be important. So that's the outline, why POCUS, and how POCUS can be used in shock, what are the different components, and some evidence-based medicine, right? Without that, we don't believe in anything in this modern emergency medicine era. We are all physicians. And what we do in our daily practice, we get patients, then we take history, or we ask our residents or fellows to do history, physical examination. We request for some tests. We do ECGs if needed, and imaging studies, right? That's our daily routine. This is what we do for most of our patients if it's needed. And then, what do we have available in diagnostics, in imaging? We have MRI, CT scan, ultrasound, and X-rays, right? And of course, this is going to be we're going to talk about more ultrasound. And this is point-of-care ultrasound. That's very important to understand. We are not talking about the conventional radiology imaging studies. They are very important when they are needed, but we are, almost everybody here, emergency physicians. So we're going to talk about that. And we know by now, and at least 70% of you had your hand raised, so you are using it. So I'm sure we all agree that this is portable. It's very cost effective once we buy the machine. So you have to talk to your head of the departments to convince them. And once it is there, we know even it's more cheaper than X-ray machines. It's dynamic. We can do the scans multiple times. There are no radiations, and we can tell the patients their concerns, their worries. We can reassure them that with this modality, we do not have any effect of radiations. And it's time sensitive, time effective. Like you can do the scans right there in front of you, drag the machine and scan the patient and see the results. Image quality is a challenge that we need to worry about, and that challenge can be sorted or can be overcome by appropriate training courses during your training programs, whatever is applied, that's going to be helpful for that. And as I said, that conventional or imaging, when sometimes we request for a patient, he or she needs diagnostic imaging like ultrasound in the radiology department. So let's see what happens. We order, somebody is going to perform the test, somebody else is going to interpret, and then we will integrate the overall picture. What was the clinical findings and what are the results which are coming from this ultrasound, which is done in the Department of Radiology, right? So imagine that we are in the clinical shift and it's about 12 o'clock and shift finishes at 3. I'm not sure. Most of the hospitals which we came across, at least it takes 3-4 hours, I believe, to request an ultrasound from radiology department. And then, you know, as I said, technicians, radiologists, many people are involved. But if we are able to perform bedside point-of-care ultrasound, it's going to be right there. Everything is going to be done by the same person, and that's us, all of us sitting here. Of course, the time which will be taken by the radiology department is going to be longer. Information is going to be way more. And in these scenarios, we are not trying to look for detailed exams. We have to have a specific question before we put the probe on the patient, and then it's yes and no most of the time. Is there free fluid? Yes or no. Is the aorta bigger than 3 centimeters? Yes or no. We are not going to look into how big is the spleen, what's in the liver, and all those things. Sometimes when we are teaching this, you will have students, they will ask you more questions, and the simple answer is this is beyond this point of care ultrasound or bedside ultrasound. So the specific objective of this talk is to understand the use of POCUS in shock. We all know the definition. It's a clinical syndrome characterized by inadequate tissue organ perfusion, which leads to the cellular damage and the disaster. Why we worry about it? We know the mortality already. Whenever we speak about a topic, we almost always look how fatal it can be, what's going to be mortality and morbidity. So we all know that this is a very important topic or important subject in bread and butter emergency medicine. So what happens, or what do we see when we have patients presenting with shock? They have hypotension, tachycardia, they are pale, sweaty, cold or warm extremities, depending upon the type. So we know it can be either distributive, cardiogenic, obstructive, and hypovolemic, right? This is all going to be in the shock whenever somebody is presenting with this state. They all almost going to look the same. And we get into the management dilemmas. Shall we start giving this patient fluids? And if we are, how much fluids is needed? How fast are we going to do inotropes? Are they going to be beneficial? Or when to start them? Do we need vasoconstrictors? Or is there any procedure which we can do to save the patient's life? And of course, there will be components which is most important, like clinical judgment or anything which can help us. We need to think. We all do physical exams. We all learn physical exams. We have medical students also. They most believe in that physical exam. But let me share with you some of the characteristics of bedside examination for shock parameters, for CIRS, cardiogenic versus hypovolemic shock. And the findings were the accuracy of clinical examination is 60 to 80% predicting the categories of shock. So that's not that great what we want, how we can save this patient, or how we can guide our management according to what's happening right there. It does not mean that I'm trying to say physical examination is not important. It's very, very important. And we consider point-of-care ultrasound as an extension of the physical examination. So how useful is it? Another randomized controlled trial, and the point they were trying to look at was patients who are presenting with undifferentiated hypotension. Shall we do an immediate ultrasound, or we do the scan after 15 minutes? And what was shown, the result was POCUS in undifferentiated hypotension narrows down the number of potential diagnoses. And that's what we want, because we want to make sure that this patient gets the right treatment and we don't delay the management. We are not missing something. And of course, when we use point-of-care ultrasound, there are pros and cons. All of us sitting here, we know that it's going to be rapid. We can repeat the scan if there are changes. We all know that when we go for our exams, we always try to remember that when an examiner gives you a scenario and there is something wrong happening or something bad happening, so what do we say? Just step back and think and restart. So likewise, if something is changing in the patient's physical examination or in the vital signs, we can always repeat the point-of-care ultrasound. And of course, it doesn't require transportation. It's going to be always with you. And these days, most of us are carrying the portable devices as well. it's user dependent, we know that, and that's why we need training. Now, when we talk about shock, we all have heard at multiple points of during our practice, there are lots of protocols. There is ACES, there is BEAT, there is BEEP, there is RUSH, there is free, FATE. Well, while I was reading these during my fellowship, I said, okay, why can't I make one with my name? See, I can have airway, free fluid, look for free fluid, look for tension pneumothorax, look for AAA, and B lines for CHF. So many protocols. You can have one by my name, Aftab protocol. I just made it up. Right. So some surveys and observations have shown that most of our colleagues, we use RUSH protocol. What is it? Rapid ultrasound in shock. It involves 3 bedside ultrasound protocols. We always, when we are dealing with patients who are presenting with shock, we speak about, okay, we need to look at the pump, the tank, and pipes, or we need to think about these components, right? So why we just keep thinking, why we don't see and look what's happening in these 3 components to come up with an accurate answer, or as much as possible accurate answer. This is again some details. What are we going to look in the RUSH protocols components? So the first one you can see is the pump, where we look for pericardial effusion, contractility, and we also look at the right ventricle to see if there is strain or no. Second part is the tank, where we try to see tank volume. We see if there is any leakiness or there is any compromise in the tank. The third component is pipes. We look at the abdominal aorta, thoracic aortic aneurysm, there is dissection or no, and of course it requires training. And we look at the veins, the DVT, look for DVT, signs of DVT using point of care ultrasound. And every single component, so we are not going to go in how we do that. That's a separate chapter, separate topics. We have to have specific criteria. Whatever we do, we need to make sure that we follow the criteria which are approved and agreed in your department, or you are following some standards from recognized places, like you can follow ASAP, you can follow Canadian Point of Care Ultrasound Society. Whatever guidelines are there in your department, I'm sure there must be, because these days most of our colleagues are trained. So make sure that whenever we do these scans, it's not just to take the probe, look at the heart, must follow the protocols. Where we train together, we used to call it minimal criteria. So you can have it for your department, so your trainees, your juniors, your colleagues can follow them, and everybody should do those scans in the same way. So that's the standardization, which we do in everything. And there are specific requirements by different societies, how many scans are needed. Now, as we said in the pump, we are not going to go into the how we do it. So what you're going to do, you're going to, for us, we prefer the parasternal long axis. Just put the probe on and find the best views as much as you can. And believe me, I learned this from Dr. Rasha. She always says, every patient has a window, right? So don't be too much worried about if you're not getting it in the first time. So you have to get it. It will be there, and you will be able to find it, and fine-tuning will be there after some practice. I wish I had the pointer so I could move. I'm not sure if somebody can get me a pointer. So that's what we look for. You can see there is an example where there is a hyperdynamic heart, and on the other side you can see a hypodynamic heart. And in these cases, we will know if we try to give, I'm sorry, I wish, is it possible to get a clicker or a pointer? Okay, but we will continue. So you look at the left side, oh, sorry about that. Can I get a clicker or a pointer? All right, thank you. Right, so here we can see this heart. What do you think? If we start pushing fluids in it, what's going to happen? A disaster, probably. And here we can see that, yes, we will get benefit. And it's never one component. Volume status assessment is a challenge. Nobody knows till now what is the exact one thing which you can do, and you will know about the volume status of a patient. So it's going to be a combo. It's a combination. You need to look for the heart, you need to look at the IVC, look at the IJs, and we will go over them very quickly. So that's for the contractility. Again, we are looking at the left ventricle. Here you can see most of you are already using it. I'm sure you know EPSS, E-point septal slap. Look at the anterior leaflet of the mitral valve. When it is hitting the septum, if there is no distance and it's less than 7 millimeter, it's 100% sensitive that the EF is going to be at least more than 50%. And if it is more than 7 millimeter, it is again 100% sensitive that this patient is going to have an EF of less than 30%. Still, we are looking at the pump. So we said the third component, we're going to look for the right ventricle. We're going to see there is strain or no. And then when it's going to be a bigger size. Normally, when you are looking at the parasternal view, the top part is RV, as you can see in this picture. Then you have the LVOT, left ventricular outflow tract. And at the bottom, you have the left atrium. So normally, when there is a normal situation, each of these three components should take 1/3, 1/3, 1/3 of your screen of the image. If something is bigger, so you need to think and how you can correlate it with the clinical presentation which this patient is coming to you. There can be some pitfalls, and again, if the patient or somebody is able to tell you, or if it's in the chart, you can know that if there are chronic pulmonary hypertension or RV hypertrophy, it will tell you that this is chronic. There are, of course, there are ways with some advanced training. You can measure the wall of RV, and you can know if it is more than 5 millimeters, that's chronic. So if it is less than 5 millimeter and RV is dilated, clinical presentation, patient is coming from Florida, for example, and also having calf pain. So combine everything, and you will know your answer. This is the example. So what do we call it? What sign is it? Very easy. I heard an alphabet, but I couldn't hear it clearly. So it's D, right? You can see it's a D sign. And then again in this picture, another sign. You know, sometimes we love signs. So that's the McConnell sign. You can see the free RV wall here and the apex. So that's what we hear. So now we're going to move to whatever we heard, whatever we learned, we want to see it. So it's not hidden anymore. Moving forward, tank, very easy. This is the first basic protocol what we look at in point of care ultrasound, where we started it actually. So we essentially are looking at the components of EFAST. And what do we want to learn, or what's the outcome we want to see from this? How full is the tank, and if there is any leak. And that leak is going to be where? In the cavities. What cavities we have? We have abdominal cavity and thoracic cavity. So all what we're going to do is apply the FAST protocol for this patient and look for any leak. That's it. And we all know how to do FAST, right? And then again, at the same time, we can see, is there any compromise? Like you have a big tension pneumothorax and you find it using your ultrasound, there is your answer. So as I said, we're going to look at components, and then all these components together will be able to give you an answer. So see, if we see an IVC which is like that, we know what to do next, right? And at the same time, if you see this, plump, big, fat IVC, no. So think carefully before you start pushing the fluids in this patient. Maybe there is something else which is wrong. And then, if you remember, I said earlier, there is no single modality which can tell you the overall volume, accurate volume status. So as I said, we're going to do quick exams. We're going to look at the IJs, how full they are or how collapsing they are. Bring your probe down, look at the heart, move your probe a little bit to the middle, and then you'll be able to see the IVC. This we already talked about, the FAST protocol. Look in the right upper quadrant, left upper quadrant, look into the pelvis, and also you can use subxiphoid view to look around the pericardium at the same time. So you can have your own techniques, how you're going to move your probe. So for example, I'll start from heart, then move to IVC, then go to the right and left upper quadrants. So majority of the things will be covered. Then you can come back to the pipes. We said that we're going to look at the pipes after the tank. I already got the warning for 5 minutes. Here, when we said the E components of the FAST, you can see how we can very quickly identify if there is a pneumothorax or no. Or there is a tension pneumothorax, because we should not have tension pneumothorax on an X-ray. If we have it, it's a disaster. Trust me. nobody will be happy. And if Dr. Khogir is on shift, he's going to be very angry, right? So that tension pneumothorax, we need to pick it right there. And then if it's a small pneumothorax and patient has other complications, we do not want to intubate it before we make a plan how we can save this patient, right? So it's going to be very useful to know and learn these techniques. And I repeat, the criteria must be followed. Otherwise, we will miss, and then they will say, oh, who are these people who are trying to teach you point-of-care ultrasound, and then we are presenting, or we are being presented in M&Ms. Pipes, so we look for abdominal aorta to see if there is an aneurysm or no. As I said, criteria, if you see it more than 3 centimeters, that's positive. So again, binary questions. So I'm looking at the abdominal aorta, I'm going to follow my protocol and start from sub-xiphoid view all the way down to the umbilicus till it bifurcates. I can't miss anything. If I find it positive, done, scan is complete. We don't need to move forward. If you are looking at iliacs, it's 1.5 centimeter. And then, as I said, evidence, right? We need to know the evidence. And you can see in this slide very clearly, using point-of-care ultrasound, the diagnosis time was 5 minutes, 5.5 minutes, roughly. And if we wait for CT and all these things, 83 minutes. Patient could be taken to OR in 12 minutes, and if we have to wait for CT, 90 minutes. But we do understand that sometimes the surgeons, the vascular surgeons, they need to know more extents, but it depends on the clinical representation. If there is time, they can do this, and if not, then they need to make sure that what they're going to do in the OR for these cases who are presenting with these dilated aortas more than 5 centimeters. Also, once we are very trained, remember, training is very, very, very important. I'm emphasizing on it again and again. Once we are trained, we can also look at the aortic root. Somewhere when you see it more than 3.5 centimeters, start thinking about it. More than 4.5, uh-oh, there is some abnormality. And also, sometimes we can see the intimal flaps. But again, it's a combination. Clinical presentation, what's happening, difference in blood pressures, and then you put your probe on, you got the answer. Here you see a very nice Mickey Mouse for when we are looking for the DVTs. Previous exam, you have a dilated RV. You are not sure it's acute or chronic, but you had a component from the history that patient had traveled, some risk factors. Put your probe down on the veins, and you got the answer. If you see this, done. So almost always we used the bedside ultrasound for positives. So when you get the positive, you are done. You have your answer. When it's negative, make sure we follow the clinical protocol. We can't miss anything. There was always a challenge. Can we do these DVT scans by ourselves at the bedside? We are emergency physicians. No. So we look at the studies. Lower extremity Doppler for DVT. Can ED physicians be accurate and fast? I'll just tell you the conclusion very quickly. Yes. They were able to accurately detect the proximal DVTs and are able to do it in a timely fashion. And we are proud, we are smart. A very interesting study I came across. Somebody asked a question, what do you think, how many lawsuits, because most of the evidence is coming from states and Canada, and in those places, these lawsuits and all these legalities are still more than our region, right? So they looked at a 20-year period and try to find out what were the correlations between these people like us, they call it neophytes, who are using these ultrasound, what the H they are doing, right? What the hell they are doing. So somebody looked at it, and let me ask you before I show you the answer. What do you think, how many lawsuits were there for point-of-care ultrasound? Any guess? How many lawsuits? How many times they found there is something wrong and they had to go for legal issues or legal challenges? Anyone would like to share a number? Yes, please. Thank you very much. Have you seen this slide before? Okay, thank you. So yes, the data showed that there were only one case, and that was because the physician did not do bedside ultrasound or point-of-care ultrasound. So this is reassuring. This is more encouraging that this is a modality in this modern era of practice, and for emergency physicians, no. You can't do anything without it. We don't walk without our machines. It's always there. Just bring it and you will have your answers. So as our colleague said, it was our failure to perform the ultrasound. So to summarize, we know, and it's proven, the ultrasound is safe, it's fast, it's reliable. And trained emergency physicians, and of course, now other specialties are also using it. We have protocols and criteria for internal medicine, trauma, ICU, they are all using it. But for us, we are emergency physicians. If we are trained, we can definitely do it accurately. But remember, we are talking about point of care ultrasound, binary questions, yes and no, very simple. We're not going to go into the details, how big is the spleen, where is the spleen. We get these details in the ultrasound reports which we receive from radiology. But our question is, do we see free fluid around that spleen and kidney, yes or no? Once we have the answer, done. How much it is, what type of fluid it is, it's beyond the scope. So we need to know the question before we go. We're not going to go for fishing, take the probe and start looking at what we're going to find. No. I need to know my question before I put the probe on. I hope that that message is received and it's clear. And please do not forget that we are clinicians. So this is, again, part of the overall clinical presentation of this patient who is with us. So we have the history, we have the vital signs, we have some sort of physical examination if we do it properly these days. And once you add the probe on to the patient, then we will have as much information as needed to make sure that this patient is taken care. I'm going to end this presentation by asking one question. I have asked this question many times, and it's for you. Can anyone tell us 2 uses of stethoscope, which was invented, I think, somewhere in 1821, 2 uses of stethoscope, if you still are using it, which are those 2 uses, modalities to look for something are better than ultrasound or can be helpful more than point of care bedside ultrasound? Just give me 2 examples if anyone would like to participate in this. And there will be a prize if you win. Pneumothorax, we said it, so I'm going to be very fast and quick. Pneumothorax, we said that we already have a protocol. You can put the probe on, and the difference is going to be, how are you going to find it? By sending him for an x-ray? How long it's going to take? You have to write a request, patient has to go. If you know the protocol, put the probe on, and you get the answer. Yes, sir. Wheezes? So why we want to look at the wheezes? So we're going to just go into a little bit discussion for 30 seconds. So wheeze is why. There can be many reasons this patient has a wheeze. So this used to be, like maybe 5 years ago, I used to ask the question, give me one use, and that was at that time. But now let's say you are dealing with a patient who presents with asthma, right? How are you going to, you may ask me or ask our colleagues who are using this point of care ultrasound that how I'm going to assess the benefits of the treatment. Now, there is a protocol. Put your probe on before 1 or 2nd or 3rd x-rays. You will look at the A lines. You will see how many lines are there initially, and then you compare it, so you will know that your treatment is beneficial. So I would like to thank you all for listening, and thank you very much. I'm not sure if we have time for questions, and I will leave it for our moderators. Thank you very much again.
Thank you very much, Dr. Aftab, for the great presentation, for the great insight. Again, I'm biased because I'm a POCUS enthusiast. Because we're running a little bit behind on time, we will go ahead with the next speaker, and then we have maybe 10 minutes at the end and see if we can have a collective questions from the audience. So thank you so much for the amazing presentation or for the insight. So now we're actually switching gear from point of care and resuscitation and hypotension and shock to trauma. This is always, one of our favorite subjects. This is what makes emergency medicine unique, right? Is because we need to be experts in trauma management. So I would like to introduce our next speaker is Dr. Hamza Awad. He's an emergency physician consultant at King Fahd Hospital, Al Medina, who will be talking to us about updated in the approach of trauma. So please welcome Dr. Hamza on the podium. So until Dr. Hamza comes up, I have a 1 second that I want to tell you from the previous presentation. If you want to invest your ultrasound skills on one patient, it's the hypotensive. If you go any hypotensive patient, scan their heart. Trust me, it will make a big difference in your management. So with this, I'm going to hand it over to Dr. Hamza.
Assalamu alaikum. First of all, I'd like to thank Sasim for this opportunity. Assalamu alaikum. How are you, everyone? Happy National Day, first of all. And I'd like SASM committee for giving me this opportunity to present in this conference. So my talk today will be update in approach to trauma. First of all, I'll start with the history of trauma. ATLS was created in 1976 by Dr. James Steiner. He's an orthopedic surgeon. After his family involved in RTA, and he see a variety of management. So he decided to start the ATLS to standardize the care of all patients. The original intent of ATLS program was to train doctors who do not manage major trauma on daily basis. And the primary audience for the course has not changed significantly. So all trauma patients are managed similarly despite vast difference in presentations, pathology, and severity of illness. So basically, the ATLS protocol and approach has been updated many times in the last decade. ATLS is a team approach rather than an individual step-by-step approach. Regarding the airway management, over the last decade, we have learned and embraced the mantra of resuscitate before intubate. There was an exception, dynamic airways such as expanding neck hematoma, burns, and so on. Once you decide to intubate the patient, you have to complete the intubation or go back approach such as CRIC for failed airway and so on. Because if you decide to intubate the patient, that means patient need intubation. Hyperangulated video laryngoscope should be your primary approach if available, because it minimizes the movement. The C-spine precaution do not carry harms, including missing neck injury, creating a pain, and making airway management. As well, more difficulty in intubating patient. So if you cannot obtain an adequate view, mobilize the neck to improve your view, because hypoxemia and hypercarbia are far worse to the patient. And there is an evidence here. This is European Journal Trauma and Emergency Surgery published in 2022, the evidence of use spinal collar stabilizing spinal injury in the pre-hospital setting in trauma patient. It was a systemic review conducted between 1990 and 2020. The use of spinal collar is outdated and is not essential in the pre-hospital use. As well, it has a psychological and physical impact along with the side effect on the patient and their consequences of recovery. The psychological effect, it includes an anxiety, as well the physical effect such as increase the pain when the patient supine or any other position. As well, patient might complaining of shortness of breath. So regarding the update in resuscitation, the ATLS continue to recommend administration of 1 liter crystalloid to the hypotensive trauma patient. However, crystalloid induces or contributes to coagulopathy and can contribute to hypothermia, which is part of triad of death. So the blood should be the only fluid used in resuscitation of major trauma, as long as you have blood to administer. So this study, was published in the Journal of Trauma. It was conducted 110. They randomized 110 patients, comparing the systolic blood pressure above 100 and systolic blood pressure above 70. There was no difference in mortality. So, regarding the permissive hypotensive, it's good in the major trauma patient. So you will have a patient with a hypotensive, and you will actively resuscitate this patient, so he will get in normal physiological pressure, and he will bleed again, and he will become hypotensive again. So the permissive hypotensive is good in all trauma except in the traumatic brain injury. This study enrolled 7,521 traumatic brain injury patients, and they found that the systolic blood pressure above 90, the mortality of 7.8%. And as well, the mortality less than 90, it's increased by 33.4. So the traumatic brain injury and hypovolemic shock, the systolic blood pressure is supposed to be above 90. But no, this is a limited evidence. So regarding this study, it was published in 1994 in New England Journal of Medicine, immediate versus delayed fluid resuscitation for the hypotensive patient with penetrating torso injury. It was a prospective trial. They enrolled 598 patients with a pre-hospital systolic blood pressure less than 90. The immediate fluid resuscitation had a higher mortality and more complication and longer hospital length of stay. This is the proper trial. It was published in JAMA 2015. They enrolled 680 patients, adult trauma. They compared the ratio 1:1:1 versus 1:1:2 of packed RBC, plasma, and platelet. There was no difference overall mortality at 24 hours, but 1:1:1 ratio achieved hemostasis faster and fewer experienced death due to exhaustion at 24 hours. So there was as well another trial. It's called refill trial. The patient enrolled around 432 adult trauma patient with a trauma related to hemorrhagic shock and hypotensive resuscitated with a pre-hospital blood product. Unfortunately, this trial recruitment was stopped due to intended sample size or 490 patients due to COVID pandemic. So they compared packed RBC with plasma versus saline solution. The primary outcome was mortality and impaired lactate clearance or both. They concluded with no difference in composite primary outcome. This trial, it could be a negative trial due to most of the patients were blunt trauma. As well, there was a transport time less than 20 minutes, so the better resuscitate pre-hospital sicker patient and getting to the hospital, which could be drive up mortality overall. So regarding the massive transfusion protocol, we all know the ABC score. It's a penetrating plus hypotensive or tachycardia or positive fast. So if the patient get more than 2 points, that means the patient, you have to consider MTB in this patient. So regarding the other score is RAPT score. Is if the patient as well get more than 2 points, you have to consider MTP as well. So regarding the exposure, most of the time when we activate trauma team, we expose the patient fully. If the patient is critically ill, you can expose the patient to look for important things such as bleeding or deformity. In well-appearing patient trauma, there is no clear indication to expose the patient fully or cutting the clothes off, because the cutting the clothes off is just mean uncaring, because the patient will develop hypothermia and he will get cold. So regarding as well the log roll, if the patient well appearing, attempt to clear the C-spine by nexus criteria and other criteria as well. So you can ask the patient to sit up and assess their back. If the patient has a major injury and heading for pan-CT, the utility of pressing the spine vertebrally, it's getting the patient wasting time only. So looking at the back to assess the visible injuries is useful. So regarding the rectal exam, the literature shows the extremely low utility of the digital rectal exam for all comers. If you suspect rectal injury, do not do a rectal exam. Otherwise, no reason to do a rectal exam. Regarding the pelvis exam, pushing the pelvis has no utility in the well-appearing patient. In the hemodynamic unstable trauma patient with a suspected pelvic fracture, pushing on a pelvic can worsen the injury, as well worsening the bleeding. Instead, a binder should be applied and the pelvic X-ray should be obtained for this patient. So use the fastest strategy to control the bleeding, to find the bleeding. If there is a bleeding, if you think about bleeding, use the scalpel. I think it's easy to memorize it. S for scalp, C for chest, A for abdomen, L for long bone, P for pelvis, extremities, and retroperitoneum. So as well, we can use the fastest strategy to control the bleeding. Tourniquet or direct pressure, packing the patient, suture, or definitive surgical repair. So there was a study conducted in 2017 in emergency Tehran, pan-CT versus selected CT. It was a prospective cross-sectional from 2014 to March 2015. They concluded with the using of pan-CT in these patients lead to 16% increase detection and diagnosis of traumatic intrathoracic injury. So there was as well the labs to follow in the trauma patient. The platelet, our target is 50% unless we have head injury or ICH. The target will be 100,000. The INR, our target is less than 2. The fibrinogen level target is 150 to 1,000 milligram per deciliter. The 10 unit of cryoprecipitate can elevate the fibrinogen level by 75 milligram per deciliter. So the calcium as well, we have to follow it. As well as you know, the calcium also augment the clot formation. So the citrate in the blood product dilute out the calcium. So if you have a patient with hypocalcemia, you can correct it with 1:3 ratio calcium or to calcium chloride versus calcium gluconate. For every 6 unit blood product, we can give it empirically. So the home message is ATLS is very different from ACLS. In the ACLS, all patients arrest have the same severity of illness, and we rarely have a story on what happened. Trauma is very different. So that was my talk, and thank you.
Thank you, Dr. Hamza. Anybody have any questions for Dr. Hamza? Okay, thank you. Our next speaker is Dr. Ahmed Wazan. Dr. Ahmed Wazan, he's a senior emergency consultant with a trauma fellowship. He's the trauma guru. He's having a passion for trauma cases. He also was the previous president of the Society of Emergency Medicine. His talk today is about update in trauma management. Let's welcome Dr. Wazan.
السلام عليكم جميعا. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It's always great to be back in SASM. It's home to me. I'm really honored to be here. So, one day I was with my family, my kids, Mahmoud, who's my eldest. That was 20 years back. So we were in the theme park. He fell down and he cut his head. And there was blood all over the place. And guess what? People were coming to me and trying to help me. And one of them said, Hatu bun, hatu bun. He wanted to put bun in my son's wound. That was 20 years back. That moment, I took him, I controlled his bleeding, and I took him to the hospital and we stitched him. Now I'll get back to that story later on. So thanks to Dr. Hassan, he had a good overview of the trauma approach update. Now, the scientific committee made it a bit hard on me to talk about updates in management of trauma. Now, there is nothing to say. I'll be very frank. Why I'm saying so? Because it's a big topic. It's not a very straightforward topic. And the clicker should be working now. Okay, so there's not much to say. Everything is there. If you Google it, if you go to UpToDate, if you go to ATLS, it's all there. Many things have been studied, many things have been worked out in trauma management. If this is left to me, I would say there's not much to say. However, many things are old. People, guidelines, medications. Not everything that is old is gold. However, many of the old things are still gold. If you look at the studies, examples given by the previous speaker, many of them rotate and talk about the same concepts, the same issues, giving blood, giving fluid, crystalloid, colloids. All of these issues are always there. But at the end, you would conclude to certain level of agreement where there are certain things that has to be done. There are certain things that are always, that we have known for decades and never have been changed. Now, when I got this talk, what do you think? Which literature I should review? Is it only emergency medicine? I don't think so. Trauma is a big chunk of a disease. It's not only emergency medicine. It's emergency medicine, it's radiology, surgeons with all their specialties. It's critical care. So if you want to look deeply into the management of trauma and its update, you will be not fair to yourself if you look only in the updates or the literature of emergency medicine. You have a vast amount of literature to review, and it will make it very hard on you to decide which way to take. Because usually trauma care is a teamwork. It's not a one-man show, it's not a one-department show. So this is why you could see here, we have our colleagues, the radiologists, who are competing with the surgeons for many of their procedures. You have the surgeons with their different approaches, different attitudes, different level of confidence and training, etc., etc. We have our critical care people whom we have bias with some of our colleagues who are subspecialized in critical care. Those who wants to admit the patient to the ICU or don't, and those who wants to prepare him for organ donation or don't. So if you want to review the literature about trauma, it's not going to be only emergency department. It will be critical care, urology, ophthalmology, general surgery, radiology, the whole package. So it's a very cross-sectional specialty that you need to look at. Now, the question comes, what to apply? Now, I know most of you are practicing in different locations. Some of you are doing service in a trauma center. Some of you are doing services in a general hospital. Some of you are in an academic center. Some of these academic centers are not serving as trauma centers. So first thing to ask yourself is, where I'm practicing? That's important. So the hospital level, from a trauma aspect, is my hospital capable of taking care of trauma comprehensively or not? So you need to know this before applying any of the literature review that you will go through, whether in this talk or the previous talks or in the whole conference. Because it's not like, you know, taking care of a wound and giving a stitch or so. It's a complete package. So the first thing you should ask yourself is, where am I practicing? Is it a general hospital? Is it a peripheral hospital? Is it a university hospital with trauma setup? Or it's just simply, a primary healthcare center? Now, the second thing is your level. Now, being a resident, an intern, a student, a consultant, a senior consultant, you need to know, where am I standing in managing trauma? If you don't know where are you at, then this will make it tough on you to apply any of the literature that you will go through. It's a huge amount of literature. So don't expect yourself to apply the latest update in trauma management while you're still in your, say, very humble hospital that does not take care of complicated trauma patients. Now, another thing that you need to consider is your team members. Now, if your team members are great, and usually we have great team members, then proceed. Go ahead and do whatever is needed. However, if your team members are not up to the standard or they need more training and more improvement, then you need to know their limits. You cannot push them beyond what they cannot know or what they don't know. So this is an important thing to know. City versus out of the city. If you are in a big city, you know, with lots of referral centers, with advanced centers, this would be different if you're working in a village or a suburb area. It's a complete different game. You cannot say that, yes, I will do the latest update of trauma in this area or in that hospital, and without knowing your limitations. And the logistics. So the transportation is one of the most important logistics that you have to do, to consider. The stuff that you have in your emergency department, all of these things has to be in your mind when you're looking at any trauma-related issues. Now, to summarize the whole thing about trauma, this is one of the most important domains that you will see across all the literature that you would go through. All the literature will be talking about bleeding. And this is why I named it bleeding vigilance. You need to be aware of the blood with all the related details. So first thing is you need to keep the blood intravascular, as simple as that. No matter what literature you review, this is the bottom line. You need to keep the blood intravascular. How would you do that? By exposing patients, by checking their bleeding sites, by controlling their bleeding sites. This is simple. You need to do this. The second point is knowing it early. And this is very important as well. You cannot leave a patient who is bleeding, whether internally or externally bleeding, without knowing it. So knowing it early is a second thing. The third thing is replenish early. Again, if patients are losing blood, give them blood. Don't give them fluid. Again, all the literature will be talking in these domains. They will not be away from that. And I always say, in everything in trauma, reassess and reassess and reassess. Always reassess repeatedly. This is a cornerstone. You don't give blood and leave the patient. You don't take the blood pressure one time and leave him. No, you need to do that repeatedly and frequently. Now, the second domain in trauma is control. Control is a magic word in trauma management. It's very important. Without control, you're not doing good trauma care. Without control, you cannot deliver appropriate care. So controlling your teams, by briefing them, debriefing them, training them, talking to them. It's very important. Controlling the environment of care. A chaotic environment of care does not help the patient by any means. So controlling your environment of care, controlling your patient. A shouting patient, irritable patient, somebody, I always tell my team, if the patient shouts the F word more than 3 times, he is indicated for intubation. So if he is so uncomfortable or uncooperative, you need to control him. Now, how you control him? Either by simple pain control or all the way to intubation. All of that are for his favor. Control pain. Without controlling pain, there's great evidence that if you don't control pain, you're increasing your morbidity and mortality, plus the patient satisfaction. And this is evidence. I'm not saying so. You have to control pain. Control physiology and control the management. So the physiology of the patient, you need to control it. Sometimes it goes beyond you. However, you need to keep in mind that you're referring back to the physiology of these patients and you have to control it. So control is another important word in the management of trauma. Now, if you go to all the literature again, in emergency medicine, in critical care, in surgery, they all talk about control. In a way or another, it always talks about control. Now, this would be a bit of a heavy slide. Now, this is one of the Rebuild EM update. I will talk about that in a second. Now, first, again, if you go through all the literature, if you go through all the articles, the books, most likely you will not be away from these 3 items: the temperature control, the base deficit, and the coagulation. So this is a targeted resuscitation. Some of them would talk about blood pressure, some of them would talk about lactate, etc. However, all of these items will fall into these 3. So you're talking about a control of temperature, a control of base deficit, and a normal coagulation. These are the 3 points that you always need to keep in mind when using fluid, blood product, and nutrition. No matter what. If you tell me, should I give crystalloid, colloids, blood, etc., etc. If you keep that in mind while dealing with the patient, believe me, you will get the right answer. The in and out chart is very important. Sometimes in trauma care, whether in the emergency department or when they move to the surgical floor or so, or the ICU, it will, not in the ICU hopefully, but in the emergency department, you might lose track of the in and out chart. The tech-guided transfusion is very important. However, honestly, in the kingdom, so far, I did not see a hospital that uses it. Very good evidence about it. It helps and guides. And I would ask the seniors in the kingdom, in the emergency departments in the kingdom to start utilizing it. It helps you to go which way. It tells you what's going on with the blood of the patient. And this is an example, as you have seen, as you're seeing in the graph, it tells you. So you put a drop of blood and it gives you a certain graph. And with the shape of that graph, you could tell where is that patient. Is he in a fibrinolytic state? Is he in hypercoagulable state, etc., etc. And accordingly, you can give blood, you can give fresh frozen plasma, you can anticoagulate, it depends. So I would strongly recommend using the tech-guided transfusion. The anticoagulant reversal is another part in the story of trauma management. Now, again, without need of evidence, if somebody is on an anticoagulant, he has trauma, simple, you need to reverse it. How to reverse it, when, and all of these details are very straightforward, and you can find some debates. However, once you know that if the patient is on anticoagulant, mainly warfarin, and nowadays the NOACs, you need to reverse it, especially if he is traumatized, and you need to initiate that very early. And again, this goes without saying, doesn't need much of evidence to say that if somebody is having high tendency of bleeding, you need to fix it. It goes without saying. The massive transfusion protocol, again, this is another message that I would ask all the leaders in the place and all the future leaders in this place to take back home to their hospitals. You guys need to push for the massive transfusion protocol. If a hospital is saying that we are a trauma center and they are not having a massive transfusion protocol, that's a big question mark. That's a very big question mark. So this is a very important piece of information that you guys need to take back home. Massive transfusion protocol, you have to adopt it in your hospital. Now, nutrition might be beyond the emergency department. However, it's a very important thing. Many studies have shown that hyperglycemic patients, especially if they're young, have worse outcomes. But this usually would go in the critical care area and so, but this is something that you need to keep in mind. And this goes with the sugar control, whether avoiding the low or the high sugar. Now, radiology. X-rays. I think X-ray is part of the day-to-day practice that we're doing. Dr. Aftab just mentioned that we are replacing the X-rays with many other procedures like ultrasound or CT scan, pan scan, but we need to be very wise in using the X-ray. We need to know the story of the patient. I should not insist on a cervical spine X-ray, for example, in a patient who's going for CT scan in 5 minutes. That does not make sense. I need to use the X-rays very wisely and correctly. The FAST and the E-FAST are or have become a very important piece of the management of trauma. There is no need for evidence for that. It is there. The ultrasound, teams are there. They're publicizing their work and they're advertising very well for it. And I cannot see an emergency department live without it. It has to be there all the time. We have to push for it. The CT scan, pan scan, again, is something that has been introduced over years. Now, if you ask me, are we using it wisely? I would say no. We are in certain area we're underusing it, and certain area I'm sure we're overusing it. And I know hospitals where they repeat pan scans for patients, which is complete insane. So pan scan is a CT scan from head to toe. The idea behind it is to identify any injury or any trauma that the patient is having. It's not for follow-ups. So when you have the pan scan, you will identify the initial injuries that this patient is having. However, pan scan is related to higher rate of malignancies, and you need to keep that in mind, especially with young people. So I would ask you kindly to think twice before going ahead and asking for a pan scan. Although if you ask me now, I would fight with anyone who does not do a pan scan. It's a bit of a controversy. However, there is good evidence that there is an association between massive use of pan scan with malignancy, especially with the young people, with brain tumor actually and leukemia. Interventional lab. Now this is something 10 or 15 years back it was not there. The interventional lab now is becoming a very important piece of the trauma care. Now it's not the OR anymore. I would say it's the interventional lab that is taking over. Many of the procedures, many of the bleeders, many of the injuries can be fixed with the interventional lab, with the interventional radiologist. This is a very important piece of information, and this will bring us to the previous slide where we said you need to know where are you practicing so that you can implement or invest in these people. If you have a 24/7 cath lab or interventional lab that is working in your place, you need to make use of it. The MRI eventually is not something that we use in the emergency department. However, there are certain instances where we used MRI. It's not so frequent. However, it's something to consider. Special studies, like some of the contrast studies or so, these are used case by case. And this is where some of the dilemma comes in, where the radiologist would say, yes, we need to do this study. We need to do an oral contrast. The other radiologist would say, we need an IV contrast. The surgeon would say, no need for contrast. And you as an emergency physician would fall in the trap between all of them. So other studies has to be clear to you. Now, which intervention to take? Now again, this goes back to the slide I have mentioned earlier. It's a huge amount of literature. Now, which intervention should I do? We need to identify. Does this patient need a surgeon? Does this patient need an intervention radiologist based on the pathology he's having. So once you identify, you will then push for the intervention you want to fix. For example, an internal bleed from a pelvic fracture, for example, is embolization, say. However, you don't have an internal intervention radiologist, and you cannot transfer the patient. So this is very critical, guys. You need to merge both the evidence and what you have on the ground. Behind this alone, and patients do not come with a single injury. You need to count all the injuries that this patient has. And if the evidence contradict, this is a very high possibility. So again, this is another factor that you need to keep in mind, other injuries and the number of them. If the patient having multiple stab injuries and multiple solid organ injuries, would you manage him as a single liver stab? I don't think so. And this goes again to the solo versus single organ damage. And always there is an evolving evidence. And the more days that we go, the more evidence that happens, the more data that we have. Every day we have new data. However, if you again look deeply in the first slide, it will go around that area of controlling the bleeding, of keeping the blood inside the vessels, of having the targets of coagulopathy, base deficit, and the temperature of the patient. All of that is an evolving evidence. If you Google it now, probably within the coming few minutes, you will have something that I did not catch either in my talk or the previous talk. However, it will all revolve around that concept. Now, to summarize, trauma management is a domain that involves 4 or more specialties. You need to look at the literature of all of these specialties if you want to do so, and you cannot take a decision alone. It's a multidisciplinary teamwork. It's a multidisciplinary literature work that you cannot talk on your own. Now, going back to my kid's story, my wife became an expert in trauma management by always, when somebody call her and tell her, my son or my daughter have a cut wound, she always tell them, just put your finger on the wound, which is a massive, bleeding control measure. With this, I conclude my talk, and thank you for listening. I appreciate it.
Thank you, Dr. Ahmed. Anybody have any questions for Dr. Wazan?
From an operational point of view, and I face this on a daily basis, we work in a trauma center that basically does not practice real trauma. But what happens is, my question is, according to my knowledge or my review or my practice, let me put it this way, a mechanism of injury solely, if you're talking only mechanism of injury, is an indication to go to a trauma center and to be evaluated by a trauma team. But I have never read that it's an indication to do a PAN-CT, just because of if you have a well-looking patient that is fine, vitally stable, you did all your assessment, nothing to appear to be abnormal, is just mechanism of injury a sole reason to do a PAN-CT for these patients? As you mentioned, it increases the chances of cancers and this thing. And at the same time, it's just easy to order a PAN-CT, make sure that everything is fine. But if you keep doing this to every patient, it will create like a log where you have a patient waiting for a stroke code, another patient waiting for a PE, and this trauma patient, maybe multiple victims. So just because this is creating a problem from the trauma teams, you say you're activating a trauma team, it equals a PAN-CT. This is another problem. What is your input on
Yes, thank you for bringing this up. Now, activating trauma team has sort of legal, ethical type of implications after that. Now, there's no, I would say there's not enough evidence to say if somebody is having so-and-so with a good-looking, exterior of that patient, there's an indication for PAN-CT. However, it's an indication to initiate a trauma team. Number two, I can extrapolate from certain rules, like the Canadian rule, if there is a high energy speed or trauma, it is an indication to do a CT scan. I can extrapolate on that, and I would push more towards doing that, especially in the blunt injuries. Now, the blunt injuries, especially some of our guys here are driving at a speed of 200 or 180. I would pan scan him, right? Now, I would not say that initiating a trauma team equals a pan scan. I agree with that. However, we can extrapolate on available evidence that some rules uses the high energy mechanism as an indication to go into the rule. The Canadian CT head rule found that the high energy is related to injuries. So we can extrapolate on that and do the CT scan. The third factor is, where is this patient going? If this patient is going home, I would pan scan him. But if he's being admitted to the hospital for observation, I can hold and observe him. There is always role for that. I know it's not a very straightforward answer, but yeah, there's no straightforward, but we can extrapolate from existing data. We can build on it. We can consider the political and the legal aspect of initiating a trauma team and the destination of the patient. If the patient is going home, I would scan him definitely. But if he is staying and being observed, there is a room to let go with the pan scan.
Clearly, very controversial topic, Doctor.
Yes.
Look at the hands. We have a good number of hands in the second or third row. So we're just waiting for the mic. Thank you, Dr. Ahmed, for the excellent presentation.
Thank you, Dr. Ahmed, as usual, excellent presentation. I know it's very tricky, and you already highlighted this. The decisions, trauma is about decisions, and sometimes those decisions is not primarily by the emergency physicians, and we are dealing with surgeons, trauma surgeons. And I know you already have mentioned this, that this sometimes you don't want to walk on other people's shoes, that's pushing them to do something they are not comfortable to do. I'm facing this every day, every week, and the ER and the ICU, the same thing. Especially if this judgment comes from an expert surgeon or trauma surgeon. Sometimes there are a lot of controversy in when to go, some type of injuries, grade 2, grade 3, spleen, liver. So we better observe those patients, not to go for OR. I need you just to your input on, because I know this is, again, it's a tricky, but I've seen some emergency physicians that they fight a lot for some decisions. They will not, face the consequences.
Yes.
The surgeon is the one who will. So it's sometimes I think we need to be reasonable. We discuss our opinion, but again, I need to hear from you, please.
Yeah, absolutely. Thank you, Prof. Muhammad, for bringing this issue up. It's always a controversy. First thing to have in mind is the patient safety. As long as the patient is safe by admission, by observation, eventually the decision is by the surgeon, and he is the one who's going to put the knife. And he will face the mortality and morbidity committee eventually, and the mortality will be counted on him. So let's put ourselves in his shoes from that perspective, and we cannot push him, and I completely agree with that. And I think you're doing that every day, even in the critical care. So my take home for that is you need to come to a middle ground where there is a safe disposition of the patient. If I have a major concern that this patient is bleeding and the patient and the surgeon does not want to take him to OR, then discussion and communication. There is one case I faced that I would never forget. I spent the 8 hours of the shift giving that young boy blood, and he had an aortic injury, and the surgeon refuses to take him to the OR, unfortunately. And I was pushing them. Unfortunately, the boy did not make it eventually. And I escalated that to even the chief executive officer eventually. And because of that, the surgeon took the decision. Unfortunately, the patient died, but he was terminated. Another surgeon was disqualified. And this is how it goes. Life is not always fair. So keep that in mind, and I really thank you for that question.
Thank you, Dr. Ahmed, for the nice revision. I would like to hear your input for our pre-hospital emergency service candidates regarding the use of long spinal board and cervical collar. Do you have any change?
Well, I think this is, I would say only the backboard is to facilitate the transfer, to make it easy for them. Otherwise, personally, the first thing that the patient, when he comes in, I would just take him off the board. That's a very important piece of information. And as it has been mentioned, if the patient is mobilizing, obviously there is no deficit, I think it's reasonable not to use it. I don't think that we are using it as we are supposed to. Even if you look at the way we are fixing the patient on the spinal board, if you want to use it, you should use it the very right way. So you need to have the straps, you need to have the sandbags, you need to have him strapped all over and be ready to respond if he vomits or so. But I would say most of the time we see patients on the backboard and the spine and they're moving around, so it's useless. So I would be very comfortable taking them off the spinal cord and taking care of them accordingly.
This is in the hospital. What is your advice for pre-hospital?
As I said, it's mainly to facilitate their transportation because it might be difficult to transport the patient without the backboard. So mainly to transport the patient. Yeah.
We'll just keep this last question because we have a few minutes before we move on to the next speaker. Thank you.
Assalamu alaikum. Thank you, Dr. Ahmed, for the very nice and useful talk. My question for you is for pan scanning. I will add a point to the first question from my colleague. My question for you is when you pan scan for high-speed mechanism for asymptomatic patients that has normal exam, is CTA of the neck part of your usual exam? I know that there are criteria to follow, but in the center where I trained, we change our practice based on one case. One case can change your management where a young lady lost her life because of a missed injury. So I want to know your thoughts on that.
So thank you for the question. So the pan scan is always there with a certain protocol. Okay, and it's an agreed upon protocol in the radiology department with the emergency department. Now, if you have extras, I would say you need to justify it well. So the CTA of a neck of somebody who's asymptomatic does not, and there is no good evidence, clinically to say you have to do it. I would not do it. Okay, if you miss a case, then this is okay, a different game. It happened. Probably you missed a subtle clinical finding. And I'm saying the pan scan, I'm saying this provided that you do a very appropriate clinical examination. But I would stick to the pan scan protocols that you're having in the hospital and identify add-ons or extras as needed.
Thank you.
No.
I was told, Dr. Wazzan, because it's very controversial, we have more time to address the audience question. But my thing is, I think we will also have, if you want to ask the other speakers, because we have them in the room with us, that is also possible. But apparently we have more trauma questions, Dr.
Thank you, Dr. Ahmed. I have one question regarding the termination or withholding of CPR. There are a lot of talks in the format especially and controversies about when to terminate the resuscitation efforts and traumatic arrest. So what is your intake on this?
That's a tough question. Now, there are straightforward cases where you have, very clear evidence that this patient is not making it. And there is, the trauma scores are always there and you can extrapolate on them and say that if a patient is having a blood pressure and so-and-so, GCS of so-and-so, it indicates high mortality. Now, trauma care is a very demanding service. I'll go back to the example that I gave. He was 18 years old. He was T-boned with a car. He came with his nephew, and his sister and brother-in-law died at the scene. So it's the nephew and the boy. I spent the 8 hours of my shift on that particular patient, and he died eventually. Now, the whole hospital came in, the intensivist, the surgeon, everyone. Now, when to terminate, going back to your question, one, if there is very clear evidence of a terminal injury, one. Two, if a patient with trauma reaches cardiac arrest, the chances of him going back, unless a very obvious tension pneumothorax or massive hemothorax, that's a different game. But if he is reaching you with a terminal pulse or a terminal state, this means that he had enough of his trauma and he reaches an irreversible state. Now, if you're talking about the age, if somebody is elderly, multiple comorbidities, I would consider terminating early. If you have multi-casualties, you have to choose one day because trauma is demanding, as I said. You would choose the least survivable. طبعا كل الأعمار بيد الله سبحانه وتعالى. لكن we are only reasons. It's all about judgment call. But I will not call somebody dead unless I give him enough blood and I address all the possible reversible causes. I would decompress his chest, multiple areas. I would do ultrasound. I would give him blood. I would do the whole package. However, when a trauma patient reaches, especially if he reaches you in a sort of a cardiac arrest stage, he will not make it طبعا بعد مشيئة الله سبحانه وتعالى. Did that address your point?
Yes, thank you. Thank you.
Any other questions? طيب شكرا دكتور أحمد يديك العافية.
شكرا لكم.
Our next speaker is Dr. Khawla Hakim. She's a senior registrar at International Medical Center. She will give us a lecture about common sport injury. Let's welcome Dr. Khawla.
No, أحتاج سلايد. Freeze. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. It is my pleasure to be with you today. I'm Khawla Hakim, ER Senior Registrar. Common sports injury. Why common sports injury? Today I will talk about these topics. As ER emergency physician, we face these injuries commonly during our shift. So the early diagnosis and correct management are important in protect preserve the functions and leads to decreased disability. Today I will talk about the top 10 of common sports injury. Let us start with the first one, ankle sprain. Ankle sprains are an extremely common sports injury. Approximately 27,000 of the injuries we see per day. And approximately 85% of the ankle sprain is of lateral ligament, especially anterior talofibular ligament. Brief anatomy about the ankle. Ankle joint is amortis and tendon ship articulations. Usually, articulation involving talus bone, articulating in amortis created by distal tibia and fibula. Ligamentous support of the talus into the tibia and fibula created laterally by anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. Medially created by deltoid ligament with both superficials and deep portion. Lastly, there is a strongest ligament called the syndesmosis ligament between the tibia and the fibula, and it is interosseous membrane. Regard presentation and diagnosis. The most commonly related injury to ankle sprain is due to inversion injuries. There are multiple classifications of ankle sprains, but routinely we use both of them. The first one, American Medical Association, and second, clinically oriented classification system. Both of them classify the ankle grades into ankle injury grades into 3 grades. Regard grade 1 with American Medical Association. It is microscopic tear of the ligament with preserved function and grosses of the ligament evaluation. And grade 2, it is partial tear of the ligament with partial loss of the function. Grade 3, complete rupture of the ligament with complete loss of function and evaluation. The useful one and routinely used clinical oriented classification, also graded into 3 types. Grade 1, partial tear of the ligament or intraligamentous injury with mild swelling and tenderness as seen in the picture. So this is, in this grade, the patient can walk without instability or disability. Regard grade 2, partial tear of the ligament with moderate swelling and moderate tenderness. In this stage, the patient can walk but with limited disability. Grade 3, complete rupture of the ligament with severe tenderness and swelling. In this grade, the patient can able to walk without special or assistant devices. Be attention during the grades of the ankle sprain injuries. Sometimes the symbol is not simple, and usually we have high ankle injury like the syndesmosis injury, which clinically suggestive by presence of tenderness in syndesmosis ligament, pain on external rotation of the leg, pain on external rotation of the ankle on the leg, and compression or tenderness by compression the tibia and fibula at the mid-lateral leg. This is called the positive pressure test. Positive squeezing test. Regard presentation and diagnosis. History is very important. Regard the mechanism of actions, and it is acute or chronic injuries. Physical examinations is very important regarding the inspection if there is deformity or wound or associated any injuries. By palpation, ask the patient where is the most site of the pain. We have also functional examination. This is to test the integrity of the ligaments. The first one, anterior drawer test, to test the integrity of anterior talofibular ligament. As see in the picture, this is test done by hold the distal or stabilize the distal part of the leg with place the patient ankle joint in plantar flexion with the angle degree 20 degree, and hold the calcaneus with other hand and try to push it anteriorly while the tibia posteriorly. Talar tilt test to assess the integrity of calcaneofibular ligament. This is also by hold or stabilize the distal part of the ankle, of the leg, on the other hand, applying inversion force on the ankle ligament, which causes lifting or tilting at the ankle mortise. The indications of radiographs regard ankle injury. The aim of X-rays in this injury is to rule out the fracture. Usually we have at our rules of the ankle, which included pain near the malleoli and unable to bear weight immediately and ER 4 steps, or pain or tenderness at the posterior tip or at the posterior tip or near the medial malleolus, and last, tenderness at the posterior edge or the tip of medial malleolus. Regard management, usually conservative, and few cases will go with surgical in cases unstable joint or recurrent injuries. Conservative management usually depends on the grades of ankle injuries. Usually grade 1s go with mnemonic rest, ice applications 3 times per day, ice applied solid 3 times per day for 20 minutes to decrease the pain and the swelling not more than 20 minutes to avoid thermal injury. Compression in grade 1 usually with simple, no need for casting, crepe bandage or rub. Elevation and analgesic. Usually it is important to give the patient analgesic for pain control and decrease the swelling. Paracetamol, we can give it 1,300 3 times per day from 5 to 7 days. Non-steroidal anti-inflammatory drugs for pain control and to decrease the swelling, and we have many options, but we use it usually ibuprofen 400 milligram 3 times per day from 5 to 7 days. Naproxen 500 milligram 2 times per day from 7 to 10 days. Regard also we can use it opioids in case we can't use it non-steroidal in cases of peptic ulcer disease or patient have renal impairment, and combined with paracetamol, morphine 5 milligram Q6 hours or 8 hours, or hydrocodone. Regard grade 2 and grade 3, we need to cast immobilization. So we have 2 options, functional bracing versus splint. Functional braces have more advantage in compared with the splint. The reported outcomes: 1, higher rate of long-term returns to the work and the sports, less disability and less edema. Regard grade 1, need to stabilize, immobilized with the functional bracing or splint from 10 to 14 days. But regard grade 3, needs more time, around 2 to 3 weeks. And all cases should be referred to orthopedic surgeon within 1 week. The second one, most common, regard common sport injury, anterior cruciate ligament. The ACL is the most common injured ligament with more than 200,000 ruptures, or 1 of every 3,000 people documented yearly in the United States alone. The ACLS injury is usually occurring in patients with age, which stabilize the outer of the knee and prevent the lateral movement. Anterior and posterior cruciate ligament stabilize the inner of the knee and prevention or stabilize the anterior and the posterior directions. Also medial and lateral meniscus. Clinical presentation and diagnosis of anterior cruciate ligament. Very important to know what is the history. It is the mechanism of action is very important, which it is contact or non-contact through the position of the knee joint during the surgery. It is flexed or extended. There is any fault of head of the pop, if there is any swelling at time of examination. Physical examination, also again by inspection and palpation to the most tenderness area. The most important triple stability test, we use it to test the integrity or to know what is the injury in anterior cruciate ligament, we have three. One of them, the first one, Lachman test, we use it in acute phase after good control of the patient to avoid the false negative test. Lachman test, it is do it as mentioned, seen in the picture. The patient in the supine position is stabilize the distal part of the femur, and the other hand put below the proximal part of the tibia, and the knee flexed in position related. Imaging test. Regard ACLS, the aim from the X-rays or CT scan or MRI or ultrasound to rule out the fracture or the dislocated joint. X-ray also we have at our role of the knee, we can use it. Age more than 55, isolated tenderness to the patella or isolated tenderness to the fibular head. Also enabled to pair weight 4 steps in the ER and immediately after injury. Regard CT scan would give us more information about the injury. MRI to assess the soft tissue injury, but we cannot change the management of ER. Ultrasound to rule out the vascular injury, like for example, popliteal artery aneurysm. Regard management, also conservative and surgery. Most cases of the ACLS can be managed conservative, except in special cases. The patient who has meniscus injury needs surgery, or the patient who desires to return to the vigorous sports and works early, and also in cases unstable joint or deformity, not response to the conservative. Regard conservative management, icing, also applying 3 times per day, each one for 20 minutes, not more than 20 minutes, to avoid the thermal injury. Elevation, compression, and weight bearing should be protected with crutches and knee immobilizer. Regard knee immobilizer should be from 2 to 4 days, not more than 4 days, to avoid joint stiffness, muscle atrophy, and loss range of motion. Aggressive physical therapy with range of motion and quadriceps and hamstring strength exercise are started within a few days. Analgesia, as mentioned in the ankle sprains, paracetamol, non-steroidal anti-inflammatory drugs, or opioids, depend on the medical history of the patient. Early referral to an orthopedic surgeon to discuss treatment option. Thank you for your time.
Thank you, Dr. Khawla. Any questions for her? Okay, we'll conclude this session. Can we have all the presenters that present this session, please? We will have now coffee break until 3 p.m. Thank you, guys.
خلاص وعلق هيك
الو
لما تحب تفصل ماشي.
Bismillah ar-Rahman ar-Rahim. Good afternoon. Welcome to our session. We're going to start our session by introducing Dr. Ahmed Madkhali. Dr. Ahmed Madkhali is a consultant emergency medicine, trained as a Saudi board emergency medicine. He is the director of the emergency department at King Abdullah Medical Complex in Jeddah, and he is going to be presenting drowning in ER. Welcome, Dr. Ahmed Madkhali.
Thank you for Dr. Azzam. Assalamu alaikum. Hello, I'm Dr. Ahmed Madkhali, emergency consultant. Today, I will talk about the saddest story for me in the emergency is the drowning, especially in the pediatric and the infant patient. I will start by the definition of the drowning. In the past, the drowning referred as the death within 24 hours from the submersion or the immersion. Near the drowning describe a victim who survived at least 24 hours past the initial, regardless of the outcome. In 2005, WHO is published of the policy of the definition of the drowning as the process of the experiencing of the respiratory impairment of the submersion or the immersion. Epidemiology, in each year, estimated 350,000 victims of the drowning. It's around 56%, 1 to 4 years, drowning in the artificial pool, and 63% of the deaths among children occur in the natural body of the fresh water. The risk factor of drowning by the age group started by the infant. The most common causes we are facing in our emergency is unsupervised bath time, bath seat, Caucasian ethnicity, that's in worldwide, a resident pool, low and middle economic entries. In the children and adolescent, underlying medical condition like epilepsy, or arrhythmogenic disease, access to the open pool water, unsupervised swimming, African American ethnicity, male sex, autism. And in the teenager and the adult, underlying medical condition like epilepsy, intoxication, trauma, tourism, swimming alone. In the old age, the cardiac arrhythmia syndrome or epilepsy. The pathophysiology, unexpected submersion leading to the breathing hold, that's leading to the panic for the victim. That's leading to the air hunger and the hypoxia, swallow water, that's causing of aspiration. It's only 1 to 3 ml per kg of the either fresh or the salt water that can cause destroyed of the integrity of the pulmonary surfactant. Profound hypoxia, metabolic and respiratory acidosis ensues, leading to the cardiovascular collapse, neuronal injury, and ultimate death. There is the debate in the study between the cold water is survived of the drowning victim or no. In the one study, there is 1,094 drowning victims of all age where the temperature had no correlation. Preserve risk of the drowning, last inhalation effort, causing of the moment of the submersion of the immersion, tissue hypoxia, acidosis, and hypercapnia, leading to involuntary respiratory drive, gasping, or loss of consciousness under the water, leading to the laryngospasm or aspiration, that's leading to the respiratory failure and death. The most important prognostic factor in the drowning patient is hypoxia, is the oxygenation of the patient. Hypoxia, which usually depends on the submersion time, is the most important factor related to the outcome and subsequent the quality of the life of the drowning victim survive. Drowning victim who's arrived to the ED with alert with the normal hemodynamically unlike experiences with the neurological impact. We have poor and good prognostic factor, but the most important prognostic factor is the hypoxia for the patient. Poor prognostic factor, submersion more than 5 minutes, no resuscitation for more than 10 minutes, fixed dilated pupil at the reach to the ER, Glasgow scale less than 5, comatose patient, and pH less than 7.1. Good prognostic factor, age less than 40, CPR started in the field. Usually drowning is the time. When they started the early resuscitation, we have good outcome for the patient. CPR less than 25 minutes, detectable pulse at arrive, temperature core less than 35 degree. There is the mixed result. Some studies support these items and some show no effect. The differential diagnosis for the causing the leading of the death or leading or of the drowning, drug ethanol intoxication, cardiac arrest by the trauma, hypoglycemic or seizure, attempt of the suicide or homicide, and child abuse or neglect. Diagnostic test. When we are facing the patient with a drowning victim in our ER, usually started by the ABC. ABC and started by the cardiac monitoring and the electrocardiogram to detect if there is any arrhythmogenic like QT prolongation, pulse oximetry, capnography, arterial blood gases should be monitored closely because maybe the patient after the resuscitation he may be need to the intubation or non-invasive pressure control. Blood glucose, serum creatinine, electrolyte value should be obtained, and the chest radiograph. Usually, the first chest radiograph in the drowning patient, especially if the patient came with the mild to the moderate symptoms, it was normal. Resuscitation of pulseless apneic patient should be attempted. The management for the drowning patient, we have two phases, pre-hospital and the hospital. In the pre-hospital, we must train everyone in our community about the BLS. The recommendation of the BLS is started by the CAB, and except in the drowning patient started by the ABC. Open the airway, give the breath, and compression. Routine cervical spine immobilization for the submerged victim patient is not warranted unless there is the significant trauma. Rewarming of the hypothermic patient. What I said previously, there is a debate about this point. If carbon dioxide in the arterial blood gases, BaCO2, if greater than 50, in the initially should be promoted the strongly considered of the intubation and the lung protection ventilation. Saturation if greater than 90%, or with an oxygen of the BaO2 greater than 60 with the high flow oxygen, require positive pressure airway. The safest parameter for resuscitation of the patient continue until the core temperature reach at least 32 to 35 degree. The administration of the corticosteroid in the setting of drowning and the ARDS is not clearly helpful to the patient and not improve the outcome of the patient. Barbiturate, induced coma, diuresis, neuromuscular blocker, and the hyperventilation do not improve the neurological outcome. Empirical antibiotic is not also does not increase the survival rate unless if there is clear indication if the patient is if the victim is submerged in the uncleared water. That's the indication of antibiotic. In the summary of the treatment, if asymptomatic patient came, we can take full of vital sign, including temperature, pulse oximetry, chest X-ray. We can discharge with precaution, or we can observe to 4 to 6 hours. In mild symptoms, by the same, full vital sign, temperature, oxygen saturation, bronchodilator, we can use it. It can help the patient. Chest X-ray and the electrolyte. Treat mild hypothermia of the patient and observe from 6 to 24 hours. In moderate to the severe patient, full vital sign, temperature, oxygen BRN, chest X-ray, electrolyte must be continuous reviewed. CBC coagulation study considered non-invasive positive pressure, intubation with the PEEP, volume support, treatment of the hypothermia, and supportive care and admission. In the cardiopulmonary arrest, started by the ACLS, post-arrest temperature management, and may be considered of ECMO. Before I finish this lecture, it's the simple lecture. There is a lot of the update about the drowning. I will talk about the saddest story I faced before 2 weeks. We are calling from one of the BHC. There is a patient is 13 months only. She was found here in the drowning in the container of the water inside the house. And they are resuscitation since 8 o'clock to 12 p.m., from 8 p.m. to 12 p.m. That's the saddest story I face it from the drowning for any patient in the emergency. And thank you.
Thank you, Ahmed. Any questions from the audience? Just please make sure that we can give the mics for... There is a question there.
Thank you, Doctor, for an amazing presentation. My question is, in the drowning patient, can we use the back valve mask and put it on the PEEP mode to increase alveolar capacity, or just use the back valve mask on the simple mode? Thank you.
The PEEP in the drowning patient, the PEEP is the important, because the PEEP it can save it of the opening of the alveoli, but we can use it with the PEEP. Also, we can use a non-invasive positive pressure with the PEEP also for the moderate to the severe patient.
Thank you, Doctor.
Welcome.
السلام عليكم يعطيك العافية دكتور. معك دكتور عبد العزيز من الكويت. عندي سؤال regarding البروجنوسيس حق البيشنت اللي present with خلينا نقول mild or moderate symptoms of drowning as a long term. هل راح يكون في عنده tissue damage or neurological effect to the brain because of the hypoxia اللي صارت معه؟
Usually in the mild and the moderate, no, because the all study that show if the patient came to the emergency or reached the emergency without neurological symptoms, there is low chance or the no chance he came with long term of neurological impairment.
Assalamu alaikum. You're dealing with the patient, you said before, patient arrested due to drowning. As a patient, you're dealing as a patient, hypothermic patient. You're not end of the resuscitation until core temperature more than 35. Am I right? I get this point?
No. Usually, if the patient came as the arrest after the drowning, if the core temperature less than 32 degrees centigrade, the recommendation, there is debate in the recommendation. Some of the recommendations said start and continuous resuscitation up to that body temperature reached to 32 to 35. And the other one, there is no difference. Also, there is the other debate. If the cold water or the warm water, also there is the debate. Some studies tell the cold water can survive the drowning victim. That's why continuous the resuscitation until the temperature reaches to the 32 to 35. And the other study, there is not recommended, but no any benefit. Show it.
We have still time if there is more questions. There is one question in the back, but until the mic goes, so I just want to ask the audience, and Ahmed also can comment. If someone drowned in water or a swimming pool, so non-salted water, there is physiology says that because you drowned in non-salted water, you become hyponatremic because of the water that goes into your lungs. So did anyone resuscitate patient with other than normal saline? Did you use hypertonic saline in patients who has drowning or in cardiac arrest? And would it make a difference? The audience or...
One literature that they said there is no difference at all. There is no difference between the salt and other water. It's the same.
Anyone practice anything different? So I guess, yeah, this is a question because maybe we see it more in the critical care. We see patients coming from rural areas and they were started on hypertonic saline, and when you ask, he say because the patient is hyponatremic or he was in a non-salted drowning case, and that's why they give them hypertonic saline. If you're going to treat with hypertonic saline, then you have to have really hyponatremia. So after assessing the patient and they have really low sodium, then you treat them. And it doesn't even help in brain resuscitation.
Yes.
So these patients, when they have edema in their brain, it is not because of low sodium, it's because of
the
hypoxia.
Yeah.
And hypertonic saline is not going to help this.
Yes.
There was one question in the back. Yes, go ahead.
Yeah, assalamu alaikum.
Salam alaikum.
In a drowning patient, in a drowning victim, the frothy secretion, should it be suctioned from the trachea, and the other part, the use of lung surfactant in a drowning victim?
If patient came drowning with the frothy secretion, we will intubate the patient. Actually facing, we are intubated the patient. We can do suction from the endotracheal tube or from outside.
Usually, most of the water that when we say suction, yes, we do suction, but most of the macro water or macro aspiration has already, just by you doing your chest compression. And the pre-hospital team have already, when you intubate someone, what you're seeing, the secretion that is coming is just the inflammatory process of the lung, secondary to the injury that happened to the lung. It's not just water inside the lung that you're suctioning, so it's not the big amount of water that you see coming out. And also, if you're doing suction, you're doing the regular suction. You should not do it if you don't have secretions. Should not just because automatically do suction, because actually the suction in an inflamed lung will cause more injury to the lung and will cause the ARDS.
We can put NGT or OGT to just relieve the compression from the stomach.
So thank you very much, Dr. Ahmed.
Thank you.
So I would like to introduce our next speaker, Dr. Yassar Kamal. Dr. Yassar is an emergency medicine consultant at King Abdulaziz University Hospital. He's a teaching assistant at the university, and he will be talking to us about dysbarism and other deep sea emergencies. Dysbarism, not dysbarism, sorry.
طيب بسم الله. My name is Yasar Kamal, and today I'm going to talk about dyspyrism and deep sea emergency. Dr. Ahmed Madkhali talked about drowning, so we're going to stay underwater, but this time we're going to take the oxygen tank with us. So let's start with the objective. Actually, knowing the law of physics gonna make us afraid of scuba diving. Scuba diving is very awesome and it's fun, but knowing what's gonna happen to our bodies, it's not that fun anymore. So we will talk about descent disorder, depth, and ascent disorder. Then management. To understand the physics and how can we apply it to emergency, let's imagine our bodies as liquid and our lung is the air interface. So just by knowing this, Boyle's law, as a constant temperature, the absolute pressure of the volume and gas and the pressure are inversely proportional. So if the pressure increases, the volume of the gas will be reduced. And as the pressure is reduced, the gas volume will be increased. Just by knowing this fact, that the gas might explode in our lung. So the Boyle's law, as we are at the surface, we are in the constant temperature. Our volume, our bubble volume is 100%. As we are going down, the pressure will increase, and therefore the volume of the gas will be reduced. It will be reduced at 50%, at 10 meters, 33 at 20 meters, and so on. And Dalton's law, the total pressure excreted by the mixture of gas is equal to the sum of their partial pressure. This is significant as the partial pressure of the gas, such as nitrogen, increases as we are going down. It's represented here. So if you are assuming our gas tank is 20% oxygen and 80% nitrogen, as we are going down, we are increasing pressure and therefore increasing pressure of the nitrogen and oxygen at the same ratio, 20 to 80. So this will take us to the Henry's law. We agreed that as we are going down, we are increasing pressure. So as we are increasing pressure of a gas, actually we're dissolving more of that gas into the liquid. So it's represented here in our chart. So as we are increasing the pressure, more gas molecule will be dissolved in liquid, which is our bloodstream. These are the disorder-related descent. We can represent any air chamber in our body can be affected by the Boyle's law, which is the volume of a gas varies inversely with the pressure. It can affect the middle ear, external ear, barosinusitis, and facial barotrauma. If we took this picture, this is our normal pressure in middle ear and external ear. So as we are going down, you can see at that picture, we are increasing pressure to 850, and inside our middle ear, it's still 760. Stacking tube is the only anatomical passage that can equalize this pressure. So if we have any swelling, any stacking tube dysfunction, we won't be able to equalize these pressures. This is for external ear barotrauma. Our external ear is an open space. It's not air chamber. But if we have any obstruction due to earwax, due to very tight swimsuit, we can make external ear as air chamber, closed air chamber. And the same Boyle's law will be applied here. Barosinusitis is the same. To the left picture, this is for our deep, as we are going down, the negative pressure will be in the sinuses, and if we go above the sea level, such as the right picture, the positive pressure will be in the maxilla, and if there is any obstruction with the sinus ostia, we won't be able to equalize the pressure. And this is the mask squeeze. Actually, we can avoid this by a gentle nose blow, so we can equalize the pressure between the closed chamber and the environment. Its treatment is supportive. We can avoid it by avoid diving while having URTI, because we want our stacking tube nasal ostia to be patent. So at the disorder, nitrogen toxicity or nitrogen narcosis can develop. It's because it can be explained by Dalton's and Henry's. So as we are going down, we are increasing pressure and more gas will be dissolved in water or liquid, in our case, the bloodstream. So it's like being intoxicated or being drunk. Symptoms can vary from euphoria, dizziness, confusion, and then loss of consciousness. Some divers with the deep, frequent dives can tolerate these symptoms. So as we said, it's like being drunk. So some divers link these symptoms with being with the martini effect. So they said for every 10 meters, after the initial 30 meters, it's like having one martini. So it's one martini at 30, another one at 40, and another one at 50, and so on. So there is no specific treatment for nitrogen narcosis, but we can avoid it by avoid risk factor, never drink and drive, never drink and dive, and never drink and do anything. Dive with your limits so you can build your tolerance. Ascend to a shallower depth if you start feeling dizzy. So this is the real deal, ascent disorder. Let's start with the pulmonary barotrauma. It can be explained by the Boyle's law we talked about, but this time we are doing the opposite in our lungs, okay? So the volume of a gas varies inversely with the pressure. During ascent, pressure reduces and the volume expands. So if you take a full breath down at the 10 meters, at the surface, the volume will be doubled. So let's imagine if we did this with a closed airway, we're going to double the volume of the gas. No way to the gas to go out, so eventually it's going to explode, causing pneumothorax, pneumomediastinum, and pneumopericardium. Asthmatic are at a high risk because they already have their auto PEEP and air trapping. So if they went up too quickly with the closed airway, they easily can develop pneumothorax. But its management is supportive. Unless the patient is going to recompression therapy and we are increasing the pressure again, at that time we have to manage the pneumothorax. So arterial gas embolism is same as pulmonary barotrauma, but this time the alveoli ruptured into the pulmonary vein, traveled to the left side heart, and did systemic effect. It can travel to the coronary, making MI, dysarrhythmia or arrest, cerebral, such as stroke, causing stroke-like symptoms, or intracardiac. During ascent, it happened during ascent, very fast, very dramatic symptoms. It's life-threatening, and it has to be treated by recompression. Decompression sickness. It's also treated with the recompression, but it has different physiology, different pathophysiology. It is explained by Dalton's and Henry's law. Again, as we are going down, we are increasing pressure, so we are increasing more dissolved gas in the liquid. So resulting from nitrogen gas bubble formation in the blood. As we are going up, we are decreasing the pressure, so the gas will be forming again into the gas form, not into the liquid. It has a slow gradual symptoms compared to the arterial gas embolism. There is two types. Type 1, which can affect the musculoskeletal, skin, lymphatic. It's more benign, but it's still requiring recompression therapy. Decompression sickness type 2, more severe, but it's also more gradual and slower onset compared to the arterial gas embolism. It can affect and causing the similar symptoms as arterial gas embolism, but more gradual and slower onset. So initial management for all arterial gas embolism, decompression sicknesses, supportive management, and it has to include recompression therapy. Recompression therapy, it's basically we are taking the patient, like if we are taking the patient down there, and we are gradually ascending the patient. So this will provide pressurized air or oxygen of an ambient pressure greater than the sea level as we are going down. With this increased ambient pressure and increasing oxygen delivery, we are slowing we are taking step back of what happened to the patient. So there is two types of recompression or hyperbaric oxygenation. This is the monoplace. It single occupant, monitor from outside. Usually this type using 100% oxygen. But this type is a multiplace. It can accommodate multiple victims and a personal health medical staff that can do a hand-on assessment if needed. The recompression therapy patient symptoms will guide us to the pressurization level, duration, air break, and number of sessions. Usually there is a standardized table of how much pressure we are using and for how long. Decompression sicknesses usually started at the 2.8 and then gradually decreasing to 1.5 and then to 1. But because of arterial gas embolism is more severe, we may need more pressure, reaching 6. So, because we are dealing with the pressure, if we want to transfer the patient into recompression center, ground transportation is preferred. If we have to transport him by air, it's a preferred pressurized airplane or a helicopter, but to be at the very low level. So any air or any gas chamber in the equipment, such as ET tube, fully cath, should be filled with normal saline or liquid to avoid its rupture. As we talked, pulmonary barotrauma can be treated conservatively or supportive, but in such a case, if there is decompression sickness with it or arterial gas, and we are using recompression because we don't want the small asymptomatic pneumothorax to be tension pneumothorax, we might treat asymptomatic or small pneumothorax with a chest tube. But at the end, I'm happy to announce our new workshop, me and Dr. Ahmed Madkhali. It's a scuba diving, discovery scuba diving course. Will be held in 26th of September. We're gonna do a discovery scuba diving session. We're gonna talk about scuba diving emergency and drowning emergency. Thank you, and I'm happy to take your questions.
Thank you, Yassar. So take-home message from this lecture, we can drink alcohol-free by just going to dive.
Exactly.
Any questions?
Thank you, Yassar. Wonderful talk, despite the fact that we hate physics. You made it look very simple. And I have 3 comments. First, how are you going to deal with critically ill patients who are intubated and in pressors? How easy is to transfer these patients to such chambers, or you have to change your management plan if they are so sick? My second question is, from practicality point of view, most of us know that they need chambers, but then we got stuck on how to find the center that has such chambers. So I think a take-home message, wherever you work, please ask where are these centers, how you can transfer patients, and how you're going to accommodate or solve any issue with the payment or insurance, because most of the centers are private, and how the transfer is going to happen. My last comment, the workshop, you didn't mention the location. Is it going to be on
Lablad?
Okay.
Answering the first question is how to deal with the critical patient who's requiring recompression therapy. If the patient is intubated on vasopressors, first thing first, we have to know how to deal with it after stabilizing the patient, like intubated, vasopressor, central line. We have to make sure that the patient won't be complicated inside the chamber, such as a small pneumothorax. We have to deal with the small pneumothorax before going to recompression therapy. Intubated patient, before started recompression therapy, let's just deal with its balloon, fully cath, the same. We won't delay the recompression therapy because of the critical situation. Here in Jeddah, we have the monoplace in Haras al-Hudud, the monoplace chamber. So we can do any intervention inside the multiplace, multiplace, so we can enter the chamber with the patient. If he needed any hands-on assessment, after doing the initial procedure outside, we can start our decompression therapy. The effect won't be the same if they push the patient rapidly, but it's still required, even if it's delayed. So after doing whatever procedure we have to do, we still have to do the recompression therapy. And for the second question, here in Jeddah we have, without mentioning the name, we have 2 chambers in 2 private hospitals and 1 chamber in Haras al-Hudud. Haras al-Hudud, they are happy, they are announcing their numbers, they are happy to take even if it's eligible patient. But we have to, each hospital have to arrange its transportation, or if the patient is stable, like decompression sickness type 1, we can just send the patient by informing the Haras al-Hudud their ID number, their name, age, and some medical information. And for the third question, it's going to be held in La Plage Beach, inshallah.
Any other questions?
Yeah. You were talking about the depth of the scuba diving and the effect on the oxygen and the gases. What about the duration, the time?
Yeah.
Let's say I'm a pilot and I will just go for my target and I will just go in and out, and someone who's searching for
for the duration, if you go in and out, you might develop arterial gas embolism, because arterial gas embolism, it's only with the boil is low. So once you are in, that's it. But for the duration and time spent down, we are dealing with the decompression sickness type 2. So the more time you are down, the more dissolved gases into liquid, so the higher risk to develop decompression sicknesses.
Sorry for the second question. If I'm diving in a lake and someone who's diving in the sea and someone who's diving in the ocean, does the solvent of the water make a difference?
No. There is small percentage about the pressure of the salted water and the fresh water, but it's not going to affect in practical way. So because we are dealing with the pressure, there is a very small percentage in salt water and fresh water pressures.
Any more questions? It's a comment as what Jamil mentioned about sick patient. So to have a patient on vasopressors, that's just usually disequilibrium syndrome. There's something else. So usually it doesn't cause hemodynamic instability. And so you need to know what's the cause of the hemodynamic instability. And this patient probably will not go to the chambers. As you mentioned, there is chambers where physicians can go inside and a medical team. However, as you know, it's a high pressure, and also having patient with central line inside the hyperbaric, it's a high risk of having air bubbles going into through the central line. So again, it is a lot of work. It is rare that you will see a critical care patient inside these chambers. And then the other option or the other alternative is to put them on 100%, even if they don't require, but you put them on 100% FiO2 on a ventilator until they're more stable, and then you can take them to the chamber.
Yeah, because most of our talk is not going to cause critical illnesses. It's only about the airway and the pressure, which can be solved by intubation, such as small pneumothorax. But dealing with the hypotension patient, I think we have to look for another cause, because these illnesses won't cause severe hypotension that requires vasopressor. And as Dr. Azam mentioned, the complexity is how to deal with the equipment. We are taking vasopressors, infuser, and how to deal with this inside the chamber, pressurized chamber.
Thank you, Yassar. Thank you so much. Yassar, just a quick question for the workshop. Does it include diving sessions, live diving sessions through the workshop?
Yeah,
or
it include diving, a discovery diving session lasting for about 30 minutes with a certified instructor. Then we're going to talk about some emergencies related to the scuba diving and drowning, inshallah.
But no martinis. There is no martinis in the course if you...
Well,
that's your question, Yani. So
it seems it comes
it's an
free,
indirect
right?
question, I know, but... Thank you very much, Yasar.
Thank you.
So we actually have a lot of time, to be honest. If there is more questions, but if not, we can go proceed with the next speaker. So I guess we thank you very much for your talk. Please welcome our next speaker, Dr. Khalid.
Thank you.
Dr. Khalid Atiya is a dear colleague. He's an emergency medicine consultant. And he is an EMS expert trained in Wisconsin. And he is an assistant professor in Taiba University. And he will be talking about a very old topic, ringer lactate versus normal saline. So let's see what's different now. Thank you very much. Welcome, Dr. Khalid.
Thank you, Abu Yusuf. طيب, السلام عليكم. Okay, as you heard, today we'll talk about ringer lactate and normal saline. And okay, it's not working. طيب, خلاص ما في مشكلة. Okay, we have breaks then good contributory review about dispelling myth about ringer lactate and normal saline. And I think all of us uses those two solutions oftenly in the emergency, almost daily. But which one we use more? Huh? Let's see now. Do we really call it normal saline, or it should be called an abnormal saline? Let's see now. So those are the most famous fluids. So lactated ringers, normal saline, and the plasma light, which is not really available everywhere. Maybe in some very advanced center, but it's not available. And this is how we compare them. In general, as you see, the cost of the plasma light, which is about $7, in comparing to the price of normal saline and ringer lactate, is a huge difference when you use large amount of fluid. And here, just to have a zoom in about the content of the fluid, especially the normal saline. As you see, the sodium there is 154, and it's well known. The chloride is also 154. And the osmolality in 1 liter is 308. The pH reaches to minimum of 4.5, but it reached to there. So they said there's the risk of acidosis. One thing more here I want to share is the SID that we'll talk about it later in this talk. Let's see about the ringer lactate. If you just read the sticker there, it will show you that the sodium is 130, chloride around 110, sodium lactate. So it's not another lactate. Potassium is 4, so it contains potassium, and this would make some debate in some management. It has also calcium, and it is also there is a problem with that calcium, theoretically. Osmolality is how much? 273, and the osmolality there is how much? 308, which is more physiologic from your point of view. We'll see now. Anyway, normal saline is considered an acidic fluid because the mean pH is 5.5, which is far away from the normal pH. The biggest problem with normal saline is the content of chloride. As we saw, it's 154, and the normal chloride is around 100 plus minus 8 plus minus 7. So it has high amount of chloride. And this will ultimately lead to NAJMA, which is hyperchloromic, non-anion gap metabolic acidosis, well known to anesthesia when they have long operation and they give the patient this amount of fluid, and then when they follow up the patient with their blood gases, they found this, although they can't explain it easily, that it is because of the large amount of normal saline. So they said that it's assumed to be harmful for the patient, especially when they are acidotic to begin with, like patients who are septic and DKA. And we'll see now why is that. So there are multiple studies, although they are animal, but it's objective. They found that acidosis caused by normal saline increase a rate of death, kidney injuries, oliguria, and tissue oxygen level at the muscles. On the other hand, a lingual lactate has a buffering content, which is the amount of bicarb that they have, which is 28, which is more alkaline than the normal saline. This is the SMART ED trial. They have studied 15,800 patients, critically ill. They have started the trial in the emergency, but they continue with the trial in the ICU. So what they found, they assigned patient to either NS, the normal saline, or balanced cholesterol, either ring lactate or the plasma light. And the median amount of fluid they have used, or they calculated in the study, is at least 1 liter. And they found that in the normal saline group, they found a higher rate of death, which is 31.2 in comparison to the other group of patients, which is 26%. And acute kidney injury was more with the normal saline group rather than the other group, which is 40 to 35. Another study, SALT ED, they have reviewed admitted patients who received at least 1 liter of normal saline, and they found that they have a higher risk of renal failure within 30 days, 5 to 4. And they have added that people who are already having kidney injuries at the time of admission, they were more susceptible to further renal damage from the normal saline. So it is around 37.6 versus 28% with a significant p-value. So we have a percentage myth regarding the use of ring lactate versus normal saline. The first myth is about hyperkalemia and the use of ring lactate. And I faced this one with a couple of physicians, that when we discuss a critical patient and the management in the emergency, and the patient is hyperkalemic or kidney renal failure, we cannot give this patient ring lactate. It is crazy to give because the ring lactate contains potassium. So how come patient with a hyperkalemia, you give a fluid that contains potassium that initially would means something insane, that you add potassium and the patient will not be benefit. And the problem is that there was no literature to support the claim that it is should not be used, not to be given. So giving the patient ring lactate in a state of hyperkalemia, it will do the opposite. Why? Because we have a very small minimum amount of potassium in the ring lactate, which is 4 milliequivalent per liter, not per 500. So the 4 milliequivalent is not here. It is in 1 liter. So we have here only 2 milliequivalent. So it's a very small amount. So when we give it, it will balance the amount of potassium circulating in the blood. So actually it will decrease the potassium rather than increasing the potassium as was assumed. So the balance, to balance and pull the potassium from the other area and balance it with the very low potassium within the fluid, it will make it low. On the other hand, they found that a normal saline would indirectly increase the potassium because of acidosis that is contributed by the fluid. So we'll have the exchange of hydrogen ion and potassium. So it will expose the patient to hyperkalemia more than the ring lactate, where the ring lactate contains potassium. Another 4 randomized controlled trials performed during kidney transplant surgery. They have a direct compare between ringal lactate and normal saline. One study demonstrated that 19% of the patients who received normal saline developed hyperkalemia because of the mechanism that we have just explained, compared to none with the patient who are taking ringal lactate. And of course, metabolic acidosis, it was higher with the patient who are using normal saline, which is really abnormal saline. No evidence have reflected that the ringal lactate causes hyperkalemia whatsoever. It will not cause. So we can use it liberally in a patient with hyperkalemia. Another myth with the ringal lactate, from the name, because it contains lactate, we should not use it because it will affect our follow-up lactate and the management and the response of shock. And they say that it is routinely increasing lactate. If it does, it will do with a very minimal amount that will not affect the results. On the other hand, I told you from the beginning, it is sodium lactate, which is converted to lactate and sodium, not lactic acid, which is converted to lactate and CO2, which contribute to the acidosis. And it has been shown with a large amount, around 30 ml per kg bolus. Then you will have that difference. So it does not cause significant. Actually, they found both fluids in the station will increase the lactate. So there is no much difference between ringal lactate and normal saline in increasing the lactate. So conservative management regarding patient with hepatic injury, that to avoid the increase of lactate because the liver is impaired and cannot metabolize the lactate, is not found to be true. Unless it is very advanced, severe liver injury, then it will affect. So the harm is usually from the amount of fluid that the patient is receiving, not from the type of fluid. Regarding blood transfusion, it's compatible with a blood transfusion. Did anybody face any problem with the ringal lactate and the blood transfusion? Even if by mistake the nurse forgot to change the fluid or the patient had the fluid along with the ringal lactate. So there is no evidence to say that. So the amount of calcium that is present that will interact with the citrate, so it's not really true, it's a theoretical concern only. So no study have supported that the blood product will increase the clot risk or the flow of blood product regarding using the ringal lactate with the blood transfusion. Again, our cost is a little bit expensive, more than the normal saline, but it's something very little, 25 cents only. And that should not be a factor for you to change from ringal lactate to normal saline. So in general, what fluid that we have to gauge or favor over another, we would say that people with severe hyponatremia, people who are in need of sodium more than other patients, like traumatic brain injury patients, they need more sodium, definitely. Or the patients who are alkalotic, with the metabolic alkalosis, they might benefit a little bit from the normal saline as a fluid in comparison to the ringal lactate. But ringal lactate, it should be the fluid, the first fluid to start with in patients with sepsis, DKA, in which most endocrinologists will disagree with you. They have in their guidelines, in their algorithm, normal saline is bloated there. And with the update of the DKA management, you can see they have started their algorithm with normal saline. Then they change the term and they say normal saline or ringal lactate. The most update again, they say normal saline / ringal lactate. So now they are changing gradually that the ringal lactate is as equal from their point of view. But we would say normal saline would contribute to more acidosis if it is used in DKA. And we have been practicing this for years and years. Similarly, I give you a good example. The atropine we were used to use in cardiac arrest. Now it is out. We have used it for years and years. Now it is found to be harmful. And it is out of the cardiac arrest algorithm. Pancreatitis, renal failure, of course, ringal lactate will be the better solution. So available go-to fluid will make it easier. So our standard fluid is ringal lactate. Other fluid will come in exception or in conditions. But who listens? Still, the normal saline, it is in the ED stock. All the resuscitation bays are full of normal saline bags. No one is thinking to change this, okay? Although there are evidence. So what is my take-home message here? So IV fluid is a drug we should not be using unless the patient is having a good indication. Hyperchloromic, non-anion gap, metabolic acidosis is a well-known phenomenon that is caused by normal saline, which is abnormal saline. It is associated with AKI and increased mortality. Lactate and hyperkalemia are not valid evidence against ringal lactate. Maybe we can avoid it because it is considered hypotonic in comparison with the normal saline in head injury patients or severely hyponatremic patients. Of course, we need more balanced fluid to be used in sepsis or DKA. So it is more toward ringal lactate, which is more physiologic than the normal saline. Before I conclude, I will just leave you with this concept of SID, which needs a whole lecture regarding this. I will not go too much, but give you the concept about the SID and the SIG. So the normal strong iron difference is 40. When you calculate of plasma, when you calculate the SID of normal saline, how much it will be? If you subtract, if you minus sodium minus chloride, how much will be the SID of this fluid? How much? 154 minus 154. It contains the same amount. It is 0. And if you calculate the SID here, how much we said? 111 for chloride and 131 for. So it's around 20. So definitely the SID of ringal lactate is higher than the SID of normal saline. So definitely normal saline is more acidotic. And here is the equation that we have the cations and the anions. And if we increase the amount of chloride, it will be in the expense of bicarb. So lesser SID will cause lesser bicarb will contribute to a low pH. This is where the acidosis comes from. Thank you very much.
Thank you, Khaled, for a very informative lecture. Any questions from the audience?
Thank you, Dr. Khalid. Wonderful speak, and mashallah, you made it very easy and simple. Anna, I want you to advise the audience regarding the concept of giving fluid, any fluid.
Yeah.
So I think many practices we've seen in the emergency departments, second nature for our resident and some of our colleagues, any patients in the ED equals giving them fluid.
Yes, yes.
So I think we need to change that habit.
It is.
Yani before we get into the trouble of picking, actually ask yourself, does this patient need a fluid?
Yeah.
Can this patient just drink some water, or does he really need a hydration? So fluid is management and treatment, and need to be given.
Yeah. It's similar to the oxygen, that not everybody needs oxygen. We have hypoxia, is dangerous, and hyperoxia is also a free radical and dangerous.
طيب, show of hands. Patient coming to the ER and he's having hypovolemia. When you treat them with fluid, what do? Do you give them boluses, or do you just put them on fluid? Let's give them fluid rehydration. This is a thing that you hear a lot. Okay, I'm not talking like very sick patient, someone who had some gastro, his blood pressure maybe 95 over 65. So when you want to give them fluid, you give them boluses of fluid, or you just put them on maintenance drip with, let's say, 150 cc per hour. So boluses, raise your hand. And maintenance 150 cc per hour. And the rest doesn't work in the ER, right? Okay. So yeah, so when we say that we want to give fluid is because you're giving fluid for volume depletion. So if you're volumely depleted, if you give maintenance fluid, it doesn't make sense, because again, this is isotonic. Well, we can discuss ringer lactate versus normal saline, which one is isotonic, but 2/3 of this fluid goes away in your interstitial fluid after half an hour. So it doesn't make sense that you're treating volume depletion or low blood pressure or hypovolemia by giving maintenance. So that's one concept for every emergency physician. We should stop giving maintenance fluid in the ER. It doesn't make sense. If someone needs maintenance fluid in the ER, he does not need to be in the ER. So that's one concept. The other concept, as Jamil mentioned, not every patient coming to the ER needs fluid. Fluid is given for people who have hypovolemia, or maybe in pediatrics when they have severe dehydration. But giving fluid through the oral route rather than the intravenous is much, much better than the intravenous fluid. Now, I agree with Khalid in his lecture, but I'm a guy who likes to make things simple. If I'm not going to give more than 1 liter, I don't care what do you give. Give fluid, IV, normal saline, IV, ringer lactate, IV, whatever, it doesn't matter. Once you're giving fluid more than 1 liter, yes, we see these problems a lot in anesthesia, in ICU. Patients come with severe acidosis just because you gave 2 to 3 liters to that level, just 2 to 3 liters of normal saline. They will go into hyperkalemic metabolic acidosis. Ringer lactate is a safer fluid in all type of patients, except maybe severe liver cirrhosis. Other than that, it is a safe medication. I think it's one of the things that can be as an awareness or a knowledge translation. Yes, we all talk about this topic has been there since ages. Which fluid should we choose? But I think by doing good awareness in the departments from the head of departments, it's very easy, I think, to change this practice.
Yeah, hopefully, yeah.
Any other questions? So thank you, Dr. Khalid. Allow me to bring the speakers to the stage, Yassar and Ahmed. And I would like to welcome also the president of the society, Dr. Jamil Abulanin, if you can come. I'll just take picture with the group.
our session is concluded, and we will open again at 4:30. Opening ceremony at 4:30, inshallah.
بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين أما بعد السلام عليكم ورحمة الله وبركاته. نحلم ونحقق شعار أتى ليؤكد أن لهذا الوطن همة تتعالى وتسمو فوق الجبال بفضل من الله ثم بقيادة حكيمة ورؤية طموحة جاءت لترتقي بهذا الوطن ومواطنيه. فنهنئكم أولاً بالذكرى 93 لتوحيد المملكة العربية السعودية، فكل عام أنتم والوطن بخير. ثم نرحب بكم وبضيوفنا الكرام بالمؤتمر العلمي الثامن للجمعية السعودية لطب الطوارئ بجدة برعاية معالي الوزير الأستاذ فهد بن عبد الرحمن الجلاجل.
It is with great pleasure and honor that we stand with you on our National Day here, on our National Day, to welcome you to the 8th International Scientific Assembly of the Saudi Society of Emergency Medicine. This gathering marks a significant milestone in our relentless pursuit of excellence in emergency medicine. And it's an honor to see so many passionate professionals and experts from around the world here with us. Emergency medicine is not merely a field of healthcare. It is a calling, a dedication to swift action, unwavering commitment, and the tireless pursuit of knowledge.
نجتمع اليوم كمجتمع شغوف لتحقيق هدف مشترك: أن ننقذ حياة المريض، أن نزيل المعاناة والألم، وأن نقدم أعلى مستويات الرعاية الصحية لكل مريض. سيكون ساسم منصة علمية لمشاركة الخبرات وأحدث التطورات وطرق العلاج المبنية على أحدث البراهين العلمية المثبتة لمواكبة تطور طب الطوارئ. خلال 3 أيام سنستمع فيها لمتحدثين هم الأبرز في مجالاتهم في مسارات مختلفة، وورش عمل تمنح الفرصة للممارسة والتطبيق تحت إشراف مختصين.
As we embark on this educational journey together, let us keep in mind the importance of collaboration, innovation, and compassion. Let us honor the dedication and resilience that defines emergency medicine, and this year's theme, Together We Advance. We extend our deepest gratitude to all the committees, speakers, sponsors, and each one of you here for being a part of this conference. Together, we are shaping the future of emergency medicine.
لنستمع، نكتشف، نتعلم ونلهم. أتمنى لكم كل التوفيق والسداد. أفيدوا واستفيدوا، فبكم نرتقي. وخير بداية لكل بداية آيات من الذكر الحكيم يتلوها على مسامعكم الدكتور جهاد مليباري.
أعوذ بالله من الشيطان الرجيم. الله نور السماوات والأرض، الله نور السماوات والأرض، مثل نوره كمشكاة فيها مصباح، المصباح في زجاجة، الزجاجة كأنها كوكب دري يوقد من شجرة مباركة يوقد من شجرة مباركة زيتونة لا شرقية ولا غربية يكاد زيتها يضيء ولو لم تمسسه نار نور على نور نور على نور يهدي الله لنوره من يشاء ويضرب الله الأمثال للناس والله بكل شيء عليم.
الله العظيم.
أشكر كل الجهات الحكومية على جهودها ولخص العاملين في المجال الصحي هناك الذين يقدمون جهودا جليلة للمحافظة على صحة المواطن والمقيم.
For people on the outside looking at this, what would you tell them? You know, if they want to come visit, they may be skittish about coming to Saudi Arabia because of what has been written in the past, what they see. What would you tell them?
I will tell them the greatest success story in the 21st century is Saudi Arabia. This is the story of this century. Do you want to miss it or not? That's your call.
And do you think you're going to slow down at all?
No, we're trying to speed up every day.
Your Royal Highness, we really appreciate this time. Shukran.
Thank you.
كلمة ترحيبية لضيوفنا الأكارم وامتنان لكل من سعى لإنجاح هذا المؤتمر يلقيها الدكتور عماد خوجة رئيس المؤتمر العلمي للجمعية السعودية لطب الطوارئ في نسخته الثامنة ورئيس اللجنة التنظيمية، فليتفضل مشكورا.
بسم الله الرحمن الرحيم. الحمد لله الحمد لله الحمد لله. شاكر لكم جميعا حضوركم. قبل يومين كنت مع الزملاء كنا بنحضر كلمات، كل واحد بيكتب كلمته، فقالوا لي انت يا عماد حتكتب كلمتك، قلت لهم اسهل حاجه نكتب كلمه. حادخل على شات جي بي تي او كوبي بيست واجيب احسن كلمه. جلست امس على شات جي بي تي، طلع لي كلمه جدا رائعه، قريتها مرة مرتين، الكلام جدا منمق لكن ما حسيته يعبر عني، فقررت اني استغني عن كلمة شات جي بي تي واطلع هنا على المسرح واكسبرس ماي فيلينج تو يو جايز. اول شيء حاب اشكركم جميعا على حضوركم. اليوم الوطني اجازة، مبروك علينا، كل عام ونحن بخير، وكل وطن كل يوم وطني جديد ونحن بخير. أشكركم جميعا على حضوركم. أحب أشكر معالي وزير الصحة لرعاية الحفل والدكتور فيصل بالنيابة عنه. أحب أشكر رئيس الجمعية السعودية لطب الطوارئ دكتور جميل أبو العنين وجميع مجلس الإدارة على ثقتهم وعلى إتاحتهم الفرصة لنا لتنظيم المؤتمر. أحب أشكر أبوي وأمي. أبوي موجود معنا اليوم. أحب أشكر زوجتي مريم وأولادي محمد ولبنى برضو موجودين معي. أحب أشكر جميع الزملاء اللي ساعدونا على تنظيم المؤتمر. في العادة الأشخاص يقولوا ما حذكر أسماء، أنا حذكر أسماء. أولاً أبدأ بالدكتور معن جمجوم وجميع فريق اللجنة العلمية، كانوا معايا من أول يوم وجهزوا لنا البرنامج العلمي. الدكتورة غادة مرداد، الدكتور عبد المنعم، والدكتورة مرام المسؤولين عن الجلسة الكوميتي. الدكتور أحمد عالم وجميع الفريق الميديا كوميتي. الدكتور يسار وجميع اللجنة المنظمة للمؤتمر والفينيو كوميتي. الدكتور عبد السيد وجميع الفولنتيرز في المؤتمر. واخيرا الدكتور عبد الله بصنوي والفاينانشال كوميتي. انا حابب اوصل لكم رساله، حسيت افضل طريقه اوصل بها رساله اني اعبر بها عن موقفين حصلوا لي انا شخصيا، فمعلش سامحوني، مواقف شويه شخصيه لكن حبيت اشارككم هي. في عام 2018 هنا في جده كان خالي رحمه الله جالس بين اولاده في ليله من الليالي، جاله الم في صدره، عنده 3 أبناء وزوجته. قال حروح على الطوارئ، الدنيا زحمه في الليل، ما في مكان، ما حيستقبلوني. فقال انا حنام وحصحى الصباح اروح على المستشفى. نام، ثاني يوم الصباح صحي، لبس ملابسه، استل عنده شويه الم صدره، نزل ركب السياره، هي ارستد بساعد الكار، اغمى عليه جنب السياره. قعد مده طويله، الناس شافوه، ما في اي احد بدا اي انعاش. اتصلوا على الاسعاف، الاسعاف اخذ مده اطول عشان يوصل. وصل الاسعاف، اخذوه المستشفى. لما وصل المستشفى كان الوقت اتعدى فتره طويله، فما كان في مجال لاي انعاش. اعلنوا وفاته، فهو في الطوارئ ذاك الوقت. كثير ايام من يوم ما توفى، وكثير مواقف كان نفسي اشوفه يكون موجود معنا فيها. ابناء واولاده تركهم، كانت اصغر بناته في سنه في الابتدائيه. الله يرحمه ويسكنه فسيح جناته، وان شاء الله انه في مكان افضل واحسن. كنت اتمنى يكون موجود معنا. في المقابل السنه اللي قبلها 2017 امي كانت في شيكاغو إلينوي في امريكا مع اخوي الصغير. كانت ماشيه في السوق، ما عندها اي امراض مزمنه غير ضغط وسكر. فجاه بدات ترجع دم. الناس اللي حولها حطوها على جنبها، اتصلوا على الاسعاف. خلال 3 دقائق الاسعاف كان موجود. بداوا اخذوها على الطوارئ، بداوا عمليه الانعاش. خلال 20 دقيقه هي في غرفه العمليات، بيسووا له منظار، وقفوا النزيف. الهيموغلوبين حقها في العاده نسبه الدم عندها 14، خلال الفتره هذه نزلت ل4. بعدها سووا لها اكثر من منظار. الحمد لله امورها استقرت، جات السعوديه بعد 2 تقريبا. ابن خالتي تبرع لها بالكبد، سوت زراعه في الرياض، والان هي موجوده بيننا. كل يوم تكون موجوده هي معانا فيه هديه من رب العالمين. انا ممكن ابيع الدنيا كلها واقضي يوم مع خالي، ممكن ابيع الدنيا كلها واكون يوم زياده مع امي. الحمد لله. الفرق في الموقفين انه there was a good emergency care system، كان في نظام صحي طارئ فعال. نحن كلنا نستحق خدمة طبية طارئة أفضل. أنتم تستحقوا خدمة طبية طارئة أفضل. هذا الوطن وأهاليكم يستحقوا خدمة طبية طارئة أفضل. نحن كجيل حالي من أطباء الطوارئ ومن الممارسين الصحيين في طب الطوارئ راح نوعدكم أنه نقدم كل اللي نقدر عليه عشان نلتقي بالخدمة الصحية الطارئة في المملكة العربية السعودية. سعيد أن أشوف وجه شابة كثير. أنتم من طلبة، من أطباء امتياز، من ريزيدنت، راح تاخذوا مننا المسيرة وراح تكملوا وتوصلونا لأعلى المستويات. فنحن بكم سنرتقي. And together we will advance. شكرا لكم.
يسعدنا أن نقدم لكم الدكتور معن جمجوم رئيس اللجنة العلمية ليلقي كلمته لحضورنا الكريم، فليتفضل.
السلام عليكم. عماد، ايش هذا؟ I cannot follow this. طبعا أنا عندي attention deficit ف I wrote something down. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أيها الحفل الكريم، يسعدني ويشرفني انتقائي كرئيس اللجنة العلمية لمؤتمر هذا العام. شاكر ومقدر كل اللجان جهودهم، وبالأخص فريق عمل اللجنة العلمية. كما يسعدني ويشرفني حضوركم. بكم نرتقي هي شعارنا لهذا التجمع العلمي. نقصد بها أنه لولا الله ثم جهودكم وعطائكم لخدمة المريض لما كان هناك هذا اللقاء الذي يجمع الأفضل والأكثر علما ومهارة لتبادل العلم والآراء فيما هو أحسن لمرضانا وعافيتهم بعد الله سبحانه وتعالى. أسرة واحدة ضخمة أطرافها تصل دول متجاورة ومتباعدة. أكثر من 100 متحدث ومتحدثة، والحضور الجميل من كل زوايا الخدمة الصحية. صراحة منظر يفرح. أيها الحفل الكريم، لن ننسى من سبقونا الرائدون في هذا المجال. هم قليلون وبعضهم موجود اليوم، نسميهم the elders، ولكن أنتم رواد مستقبل الخدمات الطبية. أنتم رواد الصحة والعافية بعد رحمة الله. أنتم البركة، والله يطرح فيكم البركة وينفع بعلمكم، وبكم نرتقي. السلام عليكم ورحمة الله.
السيدات والسادة الحضور، يشرفنا أن ندعوكم للاستماع لكلمة الدكتور فيصل الدهمشي. وكيل وزارة الصحة المساعد لخدمات المستشفيات بالنيابة عن معالي الوزير الأستاذ فهد بن عبد الرحمن الجلاجل.
بسم الله الرحمن الرحيم. أصحاب السعادة، الحضور الكريم، رؤساء وأعضاء اللجان التنظيمية واللجان العلمية، أطباءنا، حضورنا، خبراءنا، سلام الله عليكم ورحمته وبركاته. يسعدني أن أكون متواجد معكم اليوم في المؤتمر السنوي الثامن للجمعية السعودية لطب الطوارئ، ويسعدني أن أنقل لكم تحيات وتقدير راعي هذا الحفل معالي وزير الصحة الأستاذ فهد بن عبد الرحمن الجلاجل، وتحيات وتقدير سعادة وكيل وزارة الصحة للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، فلكم منهم جزيل الشكر والامتنان على جزيل صنيعكم. اسمحوا لي في هذه الدقائق أن أبعث برسالتين. لا أستطيع أن أبعث بمثل ما بعث به زميلنا الدكتور عماد من الكلمات الرائعة المؤثرة جدا، ولكن في البداية نهنئكم جميعا بمناسبة اليوم الوطني 93 لهذا الوطن المعطاء، وطن الحب والرخاء. فالتهنئة مرسولة لكم جميعا، وشعار هذا العام نحلم ونحقق. فوجودنا اليوم في هذا الملتقى اللي بيوم من الأيام كان حلم أصبح حقيقة، أن نرى التنافس ونرى التكامل في تقديم خدمات الطوارئ. فشكرا لكم من الأعماق، وأسأل الله العلي العظيم أن يمدكم بعونه، وأن تستمروا في التميز والإخلاص والإحسان في تقديم خدمات الطوارئ. لكم أن تتخيلوا في عام 2000 كان هناك 4 أطباء طوارئ فقط يدرسون في برنامج وحيد لطب الطوارئ في المملكة العربية السعودية. اليوم نتكلم عن أكثر من 30 مركز تدريبي تابع لبرنامج الطوارئ في هيئة التخصصات الصحية، تخرج منه قرابة 700 طبيب وخبير. أنا شبه متأكد أن أغلب الموجودين اليوم إما كانوا تخرجوا من هذا البرنامج ساهموا في صنع ومخرجات هذا البرنامج، فهنيئا لغرسكم، هنيئا لكل ما عملتم به. اليوم حصاد وسنستمر بإذن الله بالحصاد. شكرا لكم من الأعماق، وبإذن الله سنرتقي بكم وبهممكم إلى المزيد وإلى التقدم والتميز في خدمات الطوارئ في الوطن، ووضع الوطن في مجال طب الطوارئ في المكان الذي يستحقه منا هذا الوطن المعطاء. طب الطوارئ، إن تكلمنا عن طب الطوارئ نتكلم عن هذا التخصص الذي يعتبر هو البوابة الرئيسية للخدمات الصحية، وهو التخصص الذي يتسارع بشكل سريع جدا. وبهممكم ولله الحمد كل نطاق من هذه النطاقات التي ترونها أمامكم أصبح مجال للتميز، فهي ليست فقط تقديم الخدمة في أقسام الطوارئ في المستشفيات، بل هي طب الكوارث، طب الإصابات، طب الطيران، طب الرعاية الحرجة والمحاكاة السريرية، الطب الرياضي، الخدمات الطبية الطارئة، وعلم الدراسات المبنية على البراهين، وعلوم السموم، وطب البراري. فكما تشاهدون كل محور من هذه المحاور أصبحنا نلمس ونشاهد تميزه وإبداعه. بكم وباهتماماتكم وبجهودكم سنصبح علامة فارقة عالمية في كل نطاق من هذه النطاقات. على سبيل المثال لدينا في مركز القيادة والتحكم في وزارة الصحة الكثير من منصات المتابعة والرصد والرقابة لكل ما يجري في كواليس مرافق تقديم الخدمات، بل من شؤون وقاية المرضى من وصول لخدماتنا الصحية. ولكن فيما يخص الطوارئ هناك كثير من المنصات تميزت، على سبيل المثال منها منصة مستعد، وهي هذه المنصة التي تساهم في التأكد من الريدنس والاستعدادية لكل قسم من أقسام الطوارئ، بحيث أن يكون الممارس الطبي من طبيب وممرض وإداري موجود في قسم الطوارئ تكون له منصة يوصل فيها صوته إلى الجهات ذات العلاقة في تأمين الإمدادات والقوى العاملة وجميع ما يحتاجه قسم الطوارئ. أيضا هناك منصات مهمة ومفيدة جدا في تقديم خدمات الطوارئ، ألا وهي منصة إدارة الأسرة. فمن المهم جدا لدى طبيب الطوارئ أن يتأكد بتوفر طاقة استيعابية في المستشفى، بحيث يتأكد أنه لا تقف الخدمة لأسباب خارجة عن إرادته كطبيب طوارئ. فمنصة إدارة الأسرة والإحالات الطبية هي أيضا من المنصات التي تميزت فيها منشآت وزارة الصحة والجهات الأخرى، بحيث أنها أصبحت هي الأمبريلا أو المظلة الكبيرة لجميع القطاعات، بحيث أنه كل قطاع يعرف ما يتوفر لدى القطاع الآخر من قطاع خاص أو قطاع حكومي آخر أو منشآت وزارة الصحة. أيضا التكامل مع هيئة الهلال الأحمر الشريك الرئيسي لأطباء الطوارئ، فوجود منصات التكامل والتفاعل مع سيارات وأسطول الهلال الأحمر أصبح من الضرورات التي تمكن أطباء الطوارئ من الاستعداد قبل وصول الحالات للأقسام. شكرا لكم أبطال الطوارئ. كلمة الشكر لا توفيكم حقكم، فأنتم العيون الساهرة، فنسأل الله العلي العظيم أن يوفقكم وأن يمدكم بعونه، وأن تحلقوا بنا إلى المزيد من التميز والإبداع. فما نحلم به اليوم سنحققه بإذن الله باهتمامكم وبإحسانكم وبإخلاصكم. والسلام عليكم ورحمة الله وبركاته.
أعزائي الحضور، رسالة ترحيب وكلمة الافتتاح من رئيس الجمعية السعودية لطب الطوارئ الدكتور جميل أبو العينين، فليتفضل.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد سيد المرسلين وإمام المتقين ومعلم الخير للبشرية أجمعين. نيابة عن وزير الصحة معالي الأستاذ فهد الجلاجل، سعادة الدكتور وكيل وزارة الصحة المساعد لخدمات المستشفيات دكتور فيصل الدهمشي، سعادة الأستاذ الدكتور عمر سعادة عميد كلية الطب بجامعة الملك عبد العزيز، أصحاب السعادة أعضاء الجمعية السعودية لطب الطوارئ، أسرة طب الطوارئ، السلام عليكم ورحمة الله وبركاته. وغيرهم ممن يعملون في أقسام طب الطوارئ، فأنتم أيها الأبطال كنتم وما زلتم صمام الأمان للمنظومة الصحية على مدار الساعة، فالكل يسمع ويشاهد أنه ومهما تنوعت الأحداث واشتدت الصعاب فلا شيء قادر على أن يثني عزائمكم وهممكم التي شبهت من خلال أهدافها أعلى جودة من الرعاية الصحية الطارئة المقدمة للمرضى والمجتمع. وعلى هذا النهج فإن الجمعية السعودية لطب الطوارئ ومن خلال شعبها المتخصصة الدقيقة تعمل على تحقيق استمرارية واستدامة التعرف على طب الطوارئ وتقديره كخدمة عامة أساسية من خلال أطباء وممارسي الطوارئ المعتمدين، وأن يتم دعمهم في ممارستهم بجميع الموارد اللازمة لتقديم رعاية طبية عالية الجودة في بيئة يتم فيها ضمان حقوقهم وسلامتهم وعافيتهم. وفي الختام لا يسعني إلا أن أتقدم بالشكر الجزيل لحضورنا الكريم على تشريفهم لحفلنا في هذا اليوم المميز، وأخص بالشكر معالي وزير الصحة على أنه رعى مؤتمرنا الثامن العلمي، وكذلك سعادة وكيل وزارة الصحة وسعادة عملية كلية الطب على تشريفهم وحضورهم معنا. وكذلك أتوجه بشكر خاص لأبطال مؤتمرنا الثامن الذين عملوا بجهد وتفاني لأشهر عدة ليقدموا لنا تحفة جديدة من مؤتمرات الجمعية عالية الجودة. أهلا وسهلا ومرحبا بكم، والسلام عليكم ورحمة الله وبركاته.
فليتفضل الدكتور فيصل الدهمشي لاستلامه التكريم من الدكتور جميل أبو العينين. مع أعضاء مجلس الإدارة العلمية.
We extend our deepest gratitude to our sponsors for their generous contribution and support. Help us thank our golden sponsors, Bassam Trading Company, and our other sponsor, Saudi Center for Pharmaceuticals. We would like to thank our silver sponsors, Pharmaceutical Solution Industry. And Serb Pharmaceuticals. Thank you. And of course, our other sponsors, Minarini Group. If the representative can please come to stage, thank you. Dar al-Najat Medical Company, Yahma Medical, Abdul Latif Jameel Health, Fumedco, Gulf Medical Limited, باقي الصالحين
ما عندنا.
and الصالحية. Thank you. Good.
Just a moment. دقيقة لا أخيرا لا يسعنا إلا أن نشكر كل من هم خلف الستار، من بذلوا وقتهم وجهدهم في سبيل نشر العلم والفائدة والارتقاء بمستوى الرعاية الطبية عامة ثم
And the Vice President, Dr. Amal Youssef. And the General Secretary, Dr. Tariq al-Thibati. And finally, the Society's Treasurer, Dr. Abdulaziz al-Rabi'a.
Dr. Ma'an Jamjoom, the head of the scientific committee, and may his supporting team be above with us.
If you can please help us welcome the entire scientific committee, Dr. Khalid Atiyah. Dr. Yasir Nafa'i, Dr. Anas Murad, Dr. Abdullah Bakhsh, Dr. Asad Al-Sifyani, Dr. Faisal Asiri, Dr. Manal Halawani, Dr. Rula Rabah, and registered nurse Huda Ba Abdullah. تبي معاي؟ تمسكي معاي؟ ايوه دحين حيجيبوا لك في هدى. دكتور أسد جيبوا تفضلي دكتورة منال. تفضلي. منال. طيب أعطوني حق دكتورة منال. موجود أرقام. لا اسمعي. The volunteer team and the media team, led by Dr. Abdullah Basnawi, Ghada Mirdad, Yassar Kamal, Abdul Sayyid, and Ahmed Alim.
باقي جائزة صح؟ باقي جائزة. مين؟ عاصم فين؟ قولي لي وجه الكاميرا على أي شيء. باقي بس الجفت. باقي بس الحين الصورة بعدين. طيب ما في مشكلة. اوكي. طيب. أخيرا فليتفضل جميع منظمي هذا المؤتمر لصورة جماعية على المسرح.
السلام عليكم جميعا. الصورة هذه كل سنة نحن ناخذ صورة لساسم، فأي أحد يعتقد إنه هو جزء من عائلة ساسم اللي نتجمع كل سنة عشان نتقابل كل سنة، بليز اتفضل على الاستاديوم، خلينا ناخذ صورة الجماعية المعتادة حقتنا. شكرا.
ينفك كده ولا
أحد يمسك؟
دخلوا يعني